Doctors will be going live in 30 seconds.
Okay.
Doctors, we are live now.
Okay. A very good morning to all the delegates, the faculty members of the EPIC 21. Today we are in the middle of the sessions, and today is day 5. We'll be taking a very interesting lectures. So I hope you're all enjoying the lectures that are being conducted every day. So to start with, we have very important 2 lectures on fetal circulation, neonatal physiology, and in concerns of neonatal emergencies. Yusuf, are we live?
Yes, doctor.
Okay. So without wasting any further time, I would like to now invite our first chairman. She'll be Dr. Aparna slide. Yusuf, Dr. Aparna's. So Dr. Aparna ma'am, she is the chief anesthetist and the head and the director of pediatric anesthesia in the Department of Minimal Access and Bariatric Surgery. Either the name has been changed, ma'am, in the Max Hospital, Super Speciality Hospital, Saket. And ma'am has had a vast experience of doing many pediatric emergencies, many pediatric surgeries in her career. And currently she is associated with the Department of Pediatric Anesthesia in Max Hospital, Saket. And ma'am is very much academically oriented and is a known name in the circle of anesthesia. So ma'am, do you want to say a few words before we start the session?
Yeah, definitely. Yeah, definitely. Thank you so much, Dr. Anupama. And at the outset, I will definitely to congratulate the program. Had privilege to log in and listen to a couple of lectures, and it has been really overwhelming and going very well and very beneficial for the postgraduates. So thank you again for the kind introduction. And for the delegates and for other faculty who are here, pediatric anesthesia has been my first love. And I have been associated with pediatric anesthesia for more than a decade. So definitely I'm delighted to be a part of this session. And I think without wasting time, let us go ahead with the first lecture. And let us have, we will be having Dr. Parul Malik as the first speaker. Can I have the intro slide of Dr. Parul?
Yusuf, are you playing the slides?
Yeah, so Dr. Parul is a very well-known name, and we all know that she has been, doing such good work as editor of the ISA Delhi. And the previous slide, please. Previous slide, please.
Yeah.
Yeah. So Dr. Parul is professor at VMMC and Safdarjung Hospital, and obstetric and pediatric anesthesia are her main interests. So very soon we will be having Dr. Parul deliver her lecture. So I think let's go ahead with Dr. Parul's lecture first. Dr. Parul, please.
Yusuf, are we playing the videos?
Neonatal circulation. Neonatal. Good morning. I'm Dr. Parul Malik, Professor Anesthesia at VMMC and Safdarjung Hospital. And I'll be taking fetal circulation and neonatal physiology. Now, the objectives of this session are to be able to understand fetal circulation, the transition from intrauterine to extrauterine life, neonatal circulation, neonatal physiology and its clinical implications. And then we'll be discussing some exam questions which have come in past DND and MD exam. Now, in fetal circulation, the fetus is inside the maternal uterus attached to the placenta by means of an umbilical cord. Now, this umbilical cord, basically, it has one umbilical vein that carries oxygenated blood and nutrients from placenta to the fetus, while with the help of a pair of umbilical arteries, which carry deoxygenated blood and waste from the fetus to placenta, where finally the gas exchange occurs. Now, you must remember that the fetus basically has only one umbilical vein, and that is the left one. An easy way to remember would be left is left and right regresses. Now, coming to this circulation, just see, this is the placenta. And from here, the oxygenated blood is carried via the umbilical vein. And this blood in the umbilical vein, it takes two pathways. 50 to 60% enters the ductus venosus, bypasses the liver, and then enters the inferior vena cava. So ductus venosus is the first shunt of fetal life, whereby blood is bypassing the liver and flowing from the umbilical vein into the inferior vena cava. The remainder of the blood perfuses the liver and then enters the inferior vena cava. Now, the blood which is coming through the ductus, the blood which is coming through the ductus venosus is relatively more oxygenated and it is at a higher velocity. Now, this high velocity blood is directed. Now, there is a valve here at the junction of inferior vena cava and the right atrium, that is the Eustachian valve. So this valve, it directs this high velocity blood across the foramen ovale into the left atrium. So from the right atrium to the left atrium via foramen ovale, this is the second shunt of the fetal life. Now this blood from left atrium goes into the left ventricle, then into the ascending aorta, and then supplies the heart and the brain. While the remaining blood which is there in the right atrium, along with what blood comes from the superior vena cava, that goes to the right ventricle. Now, because the pulmonary vascular resistance is very high, there is hardly any blood that is going into the lungs, and around 93% through this ductus arteriosus, which is the shunt number 3, it goes and mixes with the systemic circulation over here, right? So this ductus arteriosus is the third shunt of the fetal life. Then this blood supplies the rest of the fetal body and then into the iliac arteries, and branch from there is the umbilical artery, and these umbilical arteries, they will ultimately take the blood to placenta where oxygenation is happening. Now, the saturation of blood in the saturation of blood in the umbilical vein is here, it is about 80%. In the left ventricle, it is around 65%, and over here in the descending aorta, it is around 55%. So the three shunts in fetal circulation are at the pre-cardiac level was the ductus venosus, at the cardiac level is the foramen ovale, and third shunt, the post-cardiac level, is the ductus arteriosus. Now, the purpose of these three shunts is to provide a more oxygenated blood to the heart and the brain. So the key features of the fetal circulation are that it is a parallel system whereby both the ventricles, they pump most of their output into the systemic circulation. The systemic vascular resistance is low and the pulmonary vascular resistance is high. Now, at birth, there are two events that are happening. First of all, there is clamping of the umbilical cord. So what happens with clamping of cord? The placenta is removed from circulation, and this causes a rise in the systemic vascular resistance. Secondly, the baby takes the first few breaths. Now, these breaths are by and large at a negative pressure of -30 to -70 centimeters of water. And this much of negative pressure is required to introduce air into the fluid-filled lungs. So with increasing oxygen tension with air breathing, there is a relative hyperoxia, and this is what acts as a stimulus for initiation and maintenance of rhythmic breathing. So with lung inflation with air and increased oxygen tension, there is a decrease in pulmonary vascular resistance. And this causes an increase in pulmonary blood flow and increased return of blood into the left atrium. So now what happens? The left atrial pressures will rise. The left atrial pressures rise because of two reasons. One, increase in the left atrial volume, which it is receiving from the pulmonary blood flow. Then second is the increase in systemic vascular resistance. So as the left atrial pressures go beyond increase, then become more than the right atrial pressure, there is a closing of foramen ovale. Then exposure of ductus arteriosus to oxygenated blood leads to ductal closure. Besides, with clamping of cord, when flow of blood ceases through the ductus venosus, it causes it to involute. So at the if you look at the blood gases, the PO2 level of umbilical artery blood is 19, while that in the umbilical vein is around 30 to 35. And the targeted preductal oxygen saturation after birth, this is very important for you to know. See, at the first minute of birth, when the baby is just born, the saturation of 65% is okay for the child. And with every passing minute, there is an increase in oxygen saturation. By 5 minutes, it becomes 85%, and by 10 minutes, it becomes 95%. So you don't have to, if you see a saturation of 65% at birth, in the first minute, you do not have to give the baby oxygen at that time. It is a normal physiological response, and this is the okay, yeah. Now, coming over to the closing of shunts, these three shunts which are there in the fetal life. Now, though with the birth of the baby, there is these shunts, they undergo functional closure, but the anatomical closure of these shunts takes some time, and it may take a couple of weeks to even months for anatomical closure to happen. So this transitional circulation, basically, it is an intermediate state between the fetal and the adult circulation, and it is characterized by high pulmonary artery pressures and resistance. But yes, these pressures, they are much lower than what they are in the utero, and there is a small amount of left to right flow through the ductus arteriosus. Now, this is a very labile state, and failure to maintain a lower pulmonary vascular resistance can lead to reversion to fetal circulatory pathways and a right to left shunt at the level of ductus arteriosus and foramen ovale. Basically, the conversion to mature circulation, it occurs over a period of, several weeks. So as pulmonary vascular resistance falls further and ductus arteriosus permanently closes by thrombosis and finally by fibrosis. Okay. So this flip-flop between this adult and fetal circulation will happen until there is a true mechanical closure of ductus arteriosus, which is at the age of 2 to 3 weeks. So at this time, infant can revert from adult to fetal type of circulation, and hypoxia, acidosis, hypercapnia, hypothermia, and changes in systemic vascular and pulmonary vascular resistance because of anesthesia-induced changes, there can be a return to fetal circulation and blood being shunted from foramen ovale and ductus arteriosus, causing severe hypoxemia. Fetal circulation is also very necessary for survival in some congenital heart diseases that depend on patency of the ductus arteriosus, like the transposition of great vessels. So in these situations, one needs to maintain the patency of ductus arteriosus with prostaglandin E1. Then persistent pulmonary hypertension of the newborn may be seen in septicemia, meconium aspiration. It may be idiopathic. It may be associated with, lung parenchymal disease and pulmonary hypoplasia. Basically, the suprasystemic right ventricle pressures, they lead to a right to left flow of deoxygenated blood through ductus arteriosus, causing severe hypoxemia. And for management, you need to, optimize the oxygenation and the ventilation, and provide pulmonary vasodilation with agents like nitric oxide. Now, there's some more concerns in a premature infant, and one of the major concerns is the patent ductus arteriosus. Basically, in a premature baby, the ductus arteriosus is very thin-walled, and because of this, there is a delay in anatomical closure, and that leads to the left to right shunt and pulmonary edema. Now, pulmonary overcirculation also leads to vascular steal from cerebral and mesenteric vessels, leading to intraventricular hemorrhage and intestinal ischemia. Now, retinopathy of prematurity is another concern due to exposure to oxygen. And it has been seen that babies who have been exposed to, more than 12 hours at PaO2 of more than 80 millimeters mercury, they run a high risk of retinopathy of prematurity. So it is advisable to maintain a PaO2 between 60 to 80 millimeters mercury and an oxygen saturation of something around, say, 93 to 95%. So you should not be targeting 99 and 100% for these babies. Besides, lack of surfactant can cause this respiratory distress syndrome. Now, moving on to neonatal circulation. Now, in neonate, both right and left side of the heart, they pump blood in series rather than parallel. And now the gas exchange is basically occurring in the lungs instead of the placenta that it was in the fetus. The pulmonary vascular resistance decreases, the systemic vascular resistance increases, and the systemic vascular resistance is higher than the pulmonary vascular resistance. Now, this is a pictorial representation of fetal and neonatal circulation. I'm not going to talk about this. We've already discussed that. Now, coming over to neonatal physiology. Now, basically, this is a terminology. These are some terminologies, and I think that you should all know about these, like what is a newborn and what is a neonate. First 28 days is a neonate, and say a term baby is between 37 to 42 weeks and so on. So this terminology you should be aware of. Then Apgar score, well, this is another very important thing, score that is, frequently asked in the exams. So it is basically used to assess the condition of newborn immediately after birth. I'm not going to go into the details of this, but you must do this score. Now, coming over to the cardiovascular physiology. Now, in a neonate, basically, the myocardium, it has very few myofibrils. And these myofibrils, they are less organized, and so they are less efficient. Besides, they have immature sarcoplasmic reticulum. So all this contributes to a decrease in myocardial contractility. Plus, a neonatal heart has a very high resting tension, and the heart is basically operating near the top of the Frank-Starling curve. So they have limited tolerance for both excessive preload and afterload. Now, in response to an exogenous catecholamines, they have a limited ability to increase the inotropic state. Now, neonates, they have a very high cardiac output, and this is because of their increased oxygen consumption. And cardiac output is dependent on the heart rate because of, they have paucity of elastic elements. So the stroke volume is relatively fixed. And newborns, they also, tolerate bradycardia poorly. This is because, they cannot increase the stroke volume to maintain cardiac output. Now, see, cardiac output is what? It is stroke volume into the heart rate. So when the heart rate goes down, to maintain the cardiac output, you need to increase the stroke volume. And neonates, they have a difficulty in increasing stroke volume. So they tolerate that bradycardia poorly. Then another thing is that the calcium stores in a neonatal heart, they are less because of the immaturity of the sarcoplasmic reticulum. So basically, they are dependent on exogenous calcium, plus they are vulnerable to the negative inotropic effect of hypocalcemia. Then increased susceptibility to, myocardial depressant effects or volatile anesthetics that have calcium channel blocking activity. Then another important thing which you must know is that since newborns, the parasympathetic system is more mature than the sympathetic system. So the response to stress in a neonate is by bradycardia. Now, this is these are the differences between neonatal and mature heart, and I've already covered these points, so I'll skip this. Then the normal physiological variables, if you see a neonatal heart, it is normal to be in the range of 120 to 160, and a blood pressure of 60 to 75 millimeters mercury. And as you know, the baby grows, the heart rate is, you're seeing that it becomes less, and the blood pressure values are ranges increasing. And coming over to the blood volume, premature neonate has a blood volume of around 90 to 100 ml per kg, while in a term newborn, the estimated blood volume is about 80 to 90 ml per kg. Now, hemoglobin, at the time of birth, the hemoglobin levels are very high. And why is this so? Basically, inside the uterus, the fetus is in a very hypoxic environment. So to, cope with that, there is an increase in renal erythropoietin release and increase in red blood cell protection. Plus, they have fetal hemoglobin, which is high oxygen affinity. So that is why fetal hemoglobin is very high. But at the time of birth, as the baby is in a more normoxic environment, the renal erythropoietin release decreases and hemoglobin levels, they come down. So at the by about 2 to 3 months of age, see, these newborns, the neonates, they have physiological anemia. Then the partial P50 of fetal hemoglobin is 19, and it increases to the adult level of 27 gradually. Neonates, basically they have a decreased cardiovascular reserve, and because their P50 is 19, because most of the hemoglobin in a newborn is fetal hemoglobin, so that causes a leftward shift in the oxygen dissociation curve. So it is desirable to maintain a hemoglobin level of 12 to 13 gram% or a hematocrit of 40% in a neonate, while hematocrit of 30% and a hemoglobin level of 10 gram% is okay for a child. Now, in the airway, they say newborns, they are preferential nasal breathers. Now, many places you will see that it's written obligate nasal breathing, and people say they are obligate breathers, but that is wrong, because there is some breathing from mouth that is happening. So it's better that you say that newborns, they are preferential nasal breathers and not obligate. Now, why are they preferential nasal breathers? Is because they have a large tongue and they have a more cranially positioned epiglottis. So when this comes in contact with the soft palate, it impedes oral breathing. Plus, they have narrow nasal passages, so these are predisposed to obstruction by secretions. Then upper airway structures, they are more compliant, so they are prone to collapse during upper airway obstruction. Then the smaller size of airway implies that because of that there is an increase in airway resistance, and any edema of the airway has a more profound effect. Then the large head with the occiput, prominent occiput, it naturally positions the newborn in a, newborn's head in a sniffing position. Then the tongue is relatively large in relation to oropharynx, and this can cause airway obstruction and technical difficulties during induction and laryngoscopy. The larynx is more cephalid, and that makes trach plates even more useful. Then the short, stubby, omega-shaped epiglottis is angled over the laryngeal inlet, makes control of with a laryngoscope plate more difficult. Now, since the vocal cords are angled in a newborn, when you're passing a tracheal tube blindly, it is likely that it may get lodged into the anterior commissure. Then another thing, larynx is in the larynx, the narrowest portion is the cricoid cartilage, and that is also called the Achilles heel. This is because this is the most vulnerable structure in the upper airway and is susceptible to inflammation and edema when irritated or traumatized. Now, length of trachea is 4 to 5 centimeters, and its trachea has, it is mainly non-calcified cartilaginous rings in a newborn. Then the right bronchial angle is 30 degrees and the left is at an angle of 47 degrees to trachea, and this favors right endobronchial intubation if tracheal tube is inserted beyond the carina. Then you will see that in a newborn, the ribs, they are horizontal. Now, horizontal ribs, they prevent a bucket handle movement, and they make tidal volume becomes more dependent on the diaphragm. So splinting of diaphragm by any cause like air in stomach or abdominal distension is going to diminish the tidal volume. Then besides that, diaphragm is also, inserted more horizontally. So that reduces the efficiency of breathing. And uh, the diaphragm does not contract is not able to, contract very well, and is not able to generate increased tidal volumes when needed because of this. Plus, you'll see that type 1 fibers, they're basically necessary for, repetitive kind of an action. So, since diaphragm has fewer type 1 fibers in a neonate, it is prone to fatigue. And high chest wall compliance makes the chest wall get distorted during airway obstruction. This again contributes to a reduced efficiency in breathing. Now there is this Hoover sign. This again you can be asked, so you should know that basically Hoover sign is the inspiratory indrawing of the lower costal margins, which is seen in the respiratory distress. Then baby neonates, since they have a very high oxygen consumption, so because of that they have an increased in minute ventilation. Plus in preterm babies, due to increased work of breathing, they have an increased work of breathing. Plus because of increased cold stress, again they have an increased metabolic demand for oxygen. So that further, cold stress, it further increases their demand. Then a high ratio of minute ventilation to FRC, that leads to causes a faster induction and emergence of volatile anesthetics. Besides, when these volatile anesthetics, there has been a rapid uptake, so it causes an unmasking of the negative inotropic effect of volatile anesthetics, leading to hypotension upon inhalational induction. Then the external intercostal muscles, they contribute to stabilization of the rib cage. So anesthetic agents can impair their function and can lead to loss of the functional residual capacity. Then the high closing volume may be within the normal tidal volume, and increased chest wall compliance and decreased lung compliance can cause an alveolar collapse. Besides, small diameter of airways, we had already said, increases airway resistance. Now, if you look at the pulmonary indices, the oxygen consumption, carbon dioxide production, and the alveolar ventilation, they are almost double as what is seen in the adult. The respiratory rate is high. Tidal volume is by and large the same as ml per kg body weight. Now, if you see, the ratio of functional residual capacity over alveolar ventilation is lower in neonate as compared to adult. So they have less oxygen reserves and they are prone to, they desaturate faster. Now, in response to hypoxia, I should know that in the initial 2 to 3 weeks, the response to hypoxia is biphasic. There's an initial transient increase in ventilation followed by a ventilatory hypoventilation. Now, this response is there in a warm condition, but in cold environment, there is no biphasic response, and response to hypoxia is hypoventilation. Now, after 3 weeks, response to hypoxia is sustained hyperventilation, as in adults. Response to hypercapnia, there is increase in ventilation, but this is less than what is there in older infants. Now, if you see, even normal, even healthy term babies, even in them, you can at times you can see periodic breathing. It is, physiological, physiological, or it's normally seen in them that breathing is basically interposed with repetitive short spells of 5 to 10 seconds with minimal hemoglobin desaturation. Then apnea in neonates can be seen due to exaggerated inhibitory response to afferent laryngeal stimulation or excessive lung inflation. And this response to excessive lung inflation, the apneic response is due to stimulation of pulmonary stress receptors. And this is the Herring-Breuer's inflation reflex, and you should know about this. Now, coming over to the liver functions are immature. At term, glycogen stores are, there are significant glycogen stores, while preterm babies' liver has minimal glycogen stores, and they have a tendency to hypoglycemia. Then reduce in total amount of plasma proteins, albumin, alpha-1 glycoprotein. Because of these, the highly protein-bound drugs, they have a higher free fraction and there is greater drug effect. Reduced biotransformation and metabolism of drugs leads to prolongation of drug effects. And phase 2 reactions are impaired in a neonate, and they result in, jaundice because of decreased bilirubin breakdown and long drug half-lives. Now, in the clotting factors, the vitamin K dependent clotting factors are low. Fibrinogen levels are comparable to adult, but polymerization is not to the full capacity, so they have a prolonged thrombin time. The platelet number at birth is comparable to adults, but the platelet function is impaired. And the even the inhibitors of coagulation, they are decreased by 30 to 50%. So as a net result, neonates basically are in a hypercoagulable state, and they have higher risk of thrombotic complications. Now, ability to coordinate swallowing with respiration does not fully mature till 4 to 5 months of age, and this causes you see a high incidence of gastroesophageal reflux. Then coming over to the renal function, now kidneys again, they're not fully mature at birth, and low renal blood flow and low GFR are basically the renal blood flow is less and GFR is less. And this is because they have a high renal vascular resistance and low systemic blood pressure, and there is a small capillary area for filtration. Now, because of low GFR and decreased tubular function, kidneys, they have a limited ability to concentrate or dilute urine. So neonates, they don't tolerate fluid restriction or fluid overload. GFR increases in the first few days, and it almost doubles by 2 weeks and reaches adult levels by 2 years. Tubular resorption reaches adult level by 1 year. Now, lack of tonicity is there in the medullary interstitium, and this causes some obligate sodium loss in the initial days of life. So exogenous sodium must be provided to neonates. Then again, due to decreased renal clearance of drugs, there may be prolonged drug effects in a neonate. Now, you'll see the total body water in a preterm child is more than a term, which is even more than a 6-month infant, and the major chunk is the extracellular fluid compartment, which is more than the intracellular fluid compartment. However, at the age of 6 months, the intracellular fluid compartment becomes more than extracellular fluid compartment, just like as in the adult. The electrolyte values in a neonate, they are the same as adult, except for potassium, which is about 1 to 2 millimoles per liter higher for the first 2 days. The sodium requirement is about 3 milliequivalents per kg per day, and both potassium and chloride are 2 milliequivalents per kg per day. Now, since these neonates, they have a high percentage of total body water and the extracellular fluid compartment, during the first 3 days, initial 3 days, a lot of this extra fluid needs to be eliminated by the kidneys. So, full-term neonates, they require less fluid intake. So, in term baby, on day 1, the fluid requirement is only about 60 ml per kg body weight, and it's only that it increases gradually to over 100 to 120 ml per kg. Now, coming over to the neonatal brain, brain is they have a large brain with incomplete myelinization, immature blood-brain barrier, and because the blood-brain barrier is immature, it allows passage of lipid-soluble, compounds, and increases the sensitivity of neonates to hypnotics. Then the soft and pliable cranium with open sutures and fontanelles, it provides some space, for the intracranial contents to expand. But the neonatal brain, it cannot tolerate the acute mass effect because of the elastance of skull and dura. So they run the risk of herniation from elevated intracranial pressures. Then cerebral autoregulation is, the range is narrower than that in an adult, and cerebral blood flow is responsive to arterial carbon dioxide levels across the physiological range. So hyperventilation causes a decrease in cerebral blood flow, and it facilitates craniotomy in situations where there is an elevated intracranial pressure. Now, excessive hyperventilation can lead to cerebral ischemia, and this should be kept in mind. Neonates and both premature and term newborns, they show strong pain behavior, and they do require adequate analgesia for painful procedures. The spinal cord is ending at L3 in a neonate, while in adult it ends by, at the level of L1. So there is an increased risk of direct trauma to spinal cord. So epidural above L3 must be avoided. Then, due to low projection of dural sac, it is a possibility that there may be inadvertent dural penetration during caudal. So always check for reflux of CSF. Then the CSF volume is larger in a neonate, and 50% of CSF is within the spinal subarachnoid space. So they require larger doses of local anesthetics for spinal anesthesia. Then the hydrostatic pressure is lower in these babies, and because of this, progression of spinal needle must be very slow so that you are able to detect the reflux of CSF. Then because of the sympathetic immaturity, they are, relatively hemodynamically, they stay hemodynamically stable during the neuraxial blocks, and fluid preloading and vasoactive agents are unnecessary. Then because of delay in myelinization of nerves, there is easier intraneural penetration of local anesthetics and onset time is shortened. And so even dilute local anesthetic is effective. Then cartilaginous structure of bones and vertebrae. Because of this, there is decreased resistance to penetration by sharp needles, and use of short and short bevel needles should be done. Increased fluidity of epidural fat is also responsible for excellent block that is seen after a caudal anesthesia. Now, increase in cardiac output and heart rate, increase the regional blood flow, and leads to an increase in systemic absorption and a shorter duration of blockade. Now, thermoregulation, this is, very important, and you should know that basically neonates, they are vulnerable to hypothermia because of their large body surface area to body weight ratio, a thin layer of subcutaneous fat, and their reduced ability to produce heat. Besides, general anesthesia also reduces their temperature threshold that initiates a thermoregulatory response to cold stress. So they are more vulnerable to hypothermia, and this hypothermia can cause an increase in oxygen consumption, acidosis, delay anesthetic recovery, impaired coagulation, and so much so. What is a neutral temperature? What is critical temperature? What are the values for term, preterm, and adult? You must know these. And in a neonate, the heat production is basically by non-shivering thermogenesis, which is brown fat metabolism. And you should know where brown fat is. Basically, it is on the back, interscapular region, neck, axilla, around the kidney, adrenals. So you must know, these are, very frequently asked questions during your, viva. So you should know that. Then heat loss in a neonate is by 4 mechanisms: radiation, convection, conduction, and evaporation. And if you see, the major chunk of heat loss is by radiation. So what you can do to prevent the heat loss by radiation is by increasing the OR temperature to 27 degrees in term and to 29 degrees for a preterm baby. To reduce the heat loss by convection, keep the infant covered. To reduce conduction losses, you give warm fluids and warm mattresses. To prevent evaporative losses, the relative humidity of the OR needs to be taken care of, and give humidified inspired gases. Now, a neonate's head may account for about 85% of body heat loss. So the head should be covered. And it goes without saying that you must take care of the baby and prevent it from getting hypothermic, but at the same time, overheating must be avoided. So many times I have, seen that babies under radiant warmer in the post-op recovery or what, they are just red and hot. So please don't do that, and this overheating must be also taken care of. Now, coming over to the pharmacology, because of increase in total body water and extracellular fluid compartment, water-soluble drugs, they have large volume of distribution and require a large initial dose. And this goes for most antibiotics and succinylcholine. Now, neonate has less fat and muscle. So drugs that depend on redistribution into fat or muscle for termination of their action, They have a long clinical effect like fentanyl, propofol, and pentothal. Reduce total plasma proteins, albumin, alpha-1 acid glycoprotein, again, because of a higher free fraction may result in greater drug effect. Then drugs that require hepatic or renal clearance, they have a longer elimination half-life, and so infrequent dosing and lower infusion rates at steady state. Now, certain drugs like succinylcholine, etracurium, and remifentanil, they undergo clearance independent of the liver or kidney. But non-specific esterases are mature at birth. So clearance for these drugs does not require an adjustment for maturation. Now, coming over to the exam questions. You must practice these questions because they may be repeated, and like draw a neat label diagram of fetal circulation and enumerate the changes that occur at the time of birth. Describe anatomical and physiological differences in a neonate. Discuss clinical significance of these changes during anesthesia. Discuss the anesthetic consideration for various surgical emergencies in a preterm neonate. What is Apgar score and its importance? Describe fetal circulation. Describe the process of conversion of fetal into adult circulation. Now, basically, these are, all long question, 10 markers. So please practice them, know them. And okay, so these are the references, the textbooks from where the presentation has been prepared from. And yes, good luck and please do well for your exams. Wish you all the best. Thank you.
Doctor, you're in mute.
Yeah, can you hear me now?
Yes, ma'am. Yes, ma'am.
Yeah. So are we taking question for Dr. Parul right now or after the second
Ma'am,
session?
we'll be taking the questions now, ma'am.
Yeah. So Dr. Parul, that was a very lucid, very exhaustive and very, very nice lecture. And I'm 100% sure that the postgraduates will greatly benefit from your lecture. So I can see that in the chat box, Dr. Parul, one of the participants wants to know, can we use cuffed endotracheal tubes in the newborn?
Though traditionally uncuffed tubes have been used in the newborn, but yes, now with modern endotracheal tubes that are coming up with very good material, so that the cuff is not compromising on the airway diameter. So yes, you can use them.
Yeah. So since there are no more questions, I would like to add a few comments, Dr.
Yes.
Parul, to your lecture. Anupama, you have to say something.
Ma'am, there's one more question which is there.
Okay, all right. You can take that.
Yes, ma'am. In Miller, it is one of the delegates is asking, ma'am. In Miller's, it is given that recent German guidelines are being followed for fluid, which states that maintenance fluid is to be started from 10 ml per kg per hour in neonates. So, what is the current take in our practices?
The thing is that maintenance fluid, now when you're talking about it, yes, 10 ml per kg, it has been like mentioned, but that is for, extracellular fluid loss and all. But for there are two things. One is maintenance fluid, which you will give to a neonate when you're not taking up the child for surgery, because otherwise also. But another thing is when you are taking them up for surgery under anesthesia, then you have to give it according to what is the blood loss, what is the third extracellular fluid loss. You have to replace that. Okay, so when you are going for that, then you have to go by the it's also mentioned to go by the it's better that you go by the 4-to-1 rule for the maintenance fluid, plus take care of the extracellular fluid and the blood loss that is also happening during the intraoperative period. Yes, definitely this is mentioned, but by and large, because it is not standard, all surgeries are different. So the amount of loss that is going to happen in each and every surgery, you cannot, say that they are all the same. So you will have to decide accordingly.
Yes, Aparna ma'am, you can complete.
Yeah, so Dr. Parul, I wanted to add a few things for the benefit of the postgraduates. And as discussed by you about the fetal circulation, how we apply it to the neonatal anesthesia as far as postgraduates are concerned. Students, we must remember, and you must mention in your answers if any such question comes up, is that, while anesthetizing a newborn or while you are preparing the OT, preparation of the OT is extremely important. While you're preparing the OT, please stick to some basic pediatric anesthesia ground rules. One of which is that definitely you should know the weight, warming the room, keep the dose calculations ready. And somewhere, if you have a whiteboard in your operation theater, the body weight, the allowable blood loss, the hemoglobin of the child must be mentioned, and your fluid replacement and everything, you should have it calculated. Your syringes should be loaded. And while you are loading your medications, please remember, no bubbles, no troubles. So while you're doing that, please make sure that you remove any smallest of air bubble that might be there, because as Dr. Parul was mentioning, that there are chances that in, first 2 weeks, there will be patency of the foramen, and, you may have a PDA or a PFO. So if you manage to instill even a smallest of bubble, you might think it is insignificant, but it can cause major catastrophe in the pulmonary circulation of the baby. And the child will actually decompensate before you realize, and you may not be able to figure out the cause also. So I think that is a very important thing, that make sure that you prepare the medications yourself and you remove every possible smallest of bubbles from the syringes. Because I have seen that, we should not leave it to the technicians, and especially for, small babies, please take care yourself. If you go to, more advanced centers, you will see that, there are ex-preterms and preterms also, which are coming for surgical intervention. So while you're preparing a thing, sometimes, you're loading fluid also in an IV infusion pump. So please make sure there is no bubble in the tubing, in the high pressure tubing, or anywhere in the syringe. So that is one thing that I want to add. And secondly, babies compensate till the end, until they can't. So, just because the vitals are fine, we should not just take that everything is going well. Because if you have a blood volume calculation ready, you will realize that the total blood volume may be just about 100 ml only, or 150 ml. And if the child is using 1 or 2 ml also, that is a significant amount. So patient may suddenly compensate. You might think that just one drop blood loss has been there, but that might be a very significant thing. So carefully document and carefully write down all the points. How much is the total blood volume, what rate you want to give, what is the allowable blood loss, and of course I will reiterate that there should be no air bubble as far as small baby neonatal anesthesia is concerned. So I think for this lecture, this is what I want to say. And
Thank you,
yeah.
Thank you.
Yeah, so maybe we can move ahead with the next lecture, Dr. Anupama.
Yes, ma'am. Yusuf, can we have the next slides? Dr. Aparna's ma'am is already here. And can we have Dr. Anshu's slide? Thank you.
Yeah. So welcome, Dr. Anshu. Dr. Anshu is Associate Professor of Anesthesia at Lady Hardinge Medical College. And her main areas of interest are pediatric anesthesia, regional anesthesia, obstetric anesthesia, and ultrasound usage in anesthesia. So I'm sure we all are going to benefit immensely from her extensive experience in a pediatric center. So let us start with Dr. Anshu. Dr. Anshu, please.
Good morning, everyone. Today, I'm going to talk about neonatal emergencies. I hope all of you are fresh in this early morning session to listen to the topic. I am Dr. Anshu, Associate Professor in Lady Hardinge Medical College. Now coming on to neonatal emergencies, it is a very important topic as you may get it as a long question in your exam. So let's begin with the scenario. We received a 38-week-old 2.5 kg newborn male child who was admitted to neonatal ICU and was intubated due to severe respiratory distress. The chest X-ray showed there were intestinal loop in the left hemithorax. Now this is the video of the child. As you can see, there is a bulging chest and scaphoid abdomen. Now, what is CDH? CDH is a defect in diaphragm which develops early in gestation, and there is herniation of abdominal organs into the thoracic cavity. It is more common in males and more so on the left side. Now, the clinical features include a classic triad of, you can see cyanosis, and there is dyspnea and dextrocardia. So the child shows scaphoid abdomen, bulging chest, and there are decreased breath sounds, and there is displaced heart sounds to the opposite side due to the mediastinal shift, and there are bowel sounds which can be heard in the chest. Now CDH is of 3 types: posterolateral, anteromedial, and paraesophageal, out of which posterolateral, or also known as Bogdale's hernia, are the commonest. Now, there are various syndromes which can be associated with CDH, which include Beckwith-Wiedemann syndrome, Chart syndrome, and trisomies. And there can be various associated anomalies also which can be associated with CDH. So out of these commonest are cardiovascular, which include VSD, ASD, coarctation of aorta, and TOF. Also spina bifida, hydrocephalus can be there, malrotation, atresia of the gut, or hypospadias may be present. Now, how does this CDH develop? For this, first we have to understand the development of diaphragm. There is a single pleuroperitoneal cavity which is there, and around 6 weeks these pleuroperitoneal folds appear. You can see them in the green color, and this is the septum transversum, and this is the mesentery of the esophagus. Now what happens is around 7th week these pleuroperitoneal folds fuse with septum transversum and mesentery of the esophagus. So pericardio-peritoneal canal is closed, and there is formation of central tendon of diaphragm. Now, around 9th to 10th week, the developing gut returns from the yolk sac to the peritoneal cavity. Now, what happens is whenever there is delayed closure of pleuroperitoneal canal beyond 9th to 10th week, or there is early return of midgut to peritoneal cavity before 9th to 10th week, there is herniation of abdominal contents into the thoracic cavity. Now, coming on to the pathophysiology, there are effects of this viscera in the thorax, which causes compression atelectasis, which compresses the ipsilateral lung, and mediastinal shift occurs because the opposite lung and viscera is pushed to the other side. There is bilateral pulmonary hypoplasia, and there is surfactant and antioxidant deficiency which occurs. Also, there is pulmonary hypertension, persistent fetal circulation, and all this leading to right and left heart failure ultimately. Now, how does this pulmonary hypoplasia occurs? Let's look at the development of the trachea and tracheal tree first. As you can see here, the bronchioles develop beyond the 4th week. From 4th week till the 16th week, the terminal bronchioles develop, and then beyond that, there is development of alveolar ducts and alveolar sacs. So what happens is when CDH occurs and there is abdominal contents into the lungs at around 9th to 10th week, there is decrease in the number of terminal bronchioles, and there is decreased in the alveoli, and there is decreased surface area for the exchange of the gases. So this leads to pulmonary hypoplasia, which is bilateral in nature. The ipsilateral side is due to the direct pressure effects, and the opposite side because there is a mediastinal shift and there is a compression on the opposite side also. So it leads to bilateral pulmonary hypoplasia. Now also there is a pulmonary hypertension which develops, which is due to the increased advential and medial thickness of the intrapulmonary arteries. So it leads to pulmonary hypertension. Also, there is an increased response to vasoactive substances. So all this leads to right ventricular hypertrophy and right ventricular failure. Now also there is a persistent fetal circulation. Because there is a pulmonary hypertension, the pulmonary artery pressures are more than the systemic pressures. So what happens is there is right to left shunting which occurs across the PDA, which lowers the postductal PaO2. Now this right to left shunting through PDA, it also leads to increase in right ventricular load. So this increase in right ventricular load, it increases the right atrial pressures, and now it leads to patent foramen ovale and right to left shunting through PFO. So it leads to ultimately right ventricular heart failure, decreased left ventricular filling, and there is decreased cardiac output, which further precipitates hypoxemia, acidosis, and systemic hypotension. So due to the viscera in the thorax, there is mediastinal shift, compression atelectasis, and hypoplasia of the lungs which occurs, which ultimately leads to respiratory acidosis and decreased cardiac output and metabolic acidosis. This causes a vicious cycle where increase in pulmonary artery pressures leads to both right ventricular and left ventricular failure, and there is persistent right to left shunting through the patent foramen ovale and PDA, which precipitates hypoxemia, hypercarbia, and acidosis. So there are certain prognostic factors which can be used to assess the severity of pulmonary hypoplasia. It includes ABG gas analysis, and we calculate the alveolar arterial oxygen gradient. If it is more than 500 mmHg on FiO2 1, it predicts non-survival, and if it is less than 400, it indicates better prognosis. Similarly, we have other indexes like ventilation or oxygenation index, which is if greater than 40, it signifies poor prognosis. Similarly, we can calculate Bones or ventilatory index. If PaCO2 is less than 40, but ventilatory index is less than 1000, then it indicates good survival. But if PaCO2 is less than 40 and VI index is greater than 1000, or when PaCO2 is greater than 50 and VI is less than 1000, it indicates poor survival. Now, how to diagnose this shunt? For this, we can do pulse oximetry and ABG of preductal and postductal arteries, which will help to identify right to left shunt. If preductal PO2 is greater than postductal PO2 by at least 20 mm of Hg, or if preductal SpO2 is greater than postductal SpO2 greater than 10%, it signifies that there is significant PDA. But if preductal PO2 is low and it is less than 20% of the normal predicted, it indicates there is patent foramen ovale. Now we have to remember that nowadays it is no longer a surgical emergency, and first we have to stabilize the patient preoperatively and delayed surgical repair is done. So whatever our management goals, when we stabilize this patient, we have to keep in mind to reverse the pulmonary hypertension, to decrease the right to left shunting. We have to improve the ventilation and oxygenation. Correction of acidosis, both metabolic and respiratory, needs to be done, and correction of systemic hypotension is required. So in the preoperative management, we place the nasogastric tube to decompress the stomach, and then we have to correct the hypoxemia and respiratory acidosis, which might require the ventilatory management of the patient. Now, remember one thing, that though hypocapnia lowers pulmonary vascular resistance, but to protect the lungs, we have to keep the patient on low tidal volume, and permissive hypercapnia may be allowed. So we do conventional ventilation with permissive hypercapnia to protect the lungs. So we have the goals of peak inspiratory pressure less than 25 centimeter of water, and we allow the PCO2 to rise to 45 to 55 mm of Hg, and FiO2 is to be titrated in such a way that preductal saturation is between 85 to 95%. Further management of pre-op stabilization include that correction of metabolic acidosis by IV fluids and sodium bicarbonate can be done. And we have to correct the persistent pulmonary hypertension. We can give inhaled nitric oxide, which will cause selective pulmonary vasodilation. Then prostaglandin E1 can be given, which helps in severe cases of persistent pulmonary hypertension, as they will maintain the patency of the ductus arteriosus. So it will help in offloading the right ventricles. Then sildenafil, milrinone can be used, and ECMO can also be given as a resort. which is very helpful when there is severe hypoxemia and severe hypercarbia, which is not responding to conventional respiratory and pharmacological intervention. It will help by diverting the cardiac output, so decrease the right to left shunt, and it will allow the growth of hypoplastic lung. Other measures include IV administration of fluids, and inotropes can be given, which will cause systemic vasodilation, leading to decrease in right to left shunt. Then we can also give dobutamine, noradrenaline, dopamine. All these agents can be used for systemic vasodilation, and hypothermia management is not to be forgotten, and it is very important part of the management. Now coming on to the anesthetic considerations. So we insert the nasogastric tube so that the stomach is desufflated. And we have to remember that we have to secure an IV line in the upper limb, because when there is return of abdominal contents, it may compress IVC and decrease the venous return. So in that case, IV line in the lower limb won't help. Now we have to avoid bag and mask ventilation so that there is no barotrauma, as the lung is already hypoplastic, and avoid rise in any pulmonary hypertension by maintaining normoxia, normocapnia, normothermia, and correction of acidosis. Now, always remember that hypothermia is to be avoided because it leads to decreased oxygen delivery, which will further worsen the acidosis and shunting and increase in pulmonary hypertension. We have to correct the acidosis, and mechanical ventilation is to be done, keeping in mind that ventilation is to be done with low tidal volume, which can cause permissive hypercapnia, and peak inspiratory pressures have to be limited and PEEP can be provided. Now, monitoring includes continuous ECG monitoring needs to be done, precordial or esophageal stethoscope is placed, and we have to place 2 pulse oximeters, one in the right hand and another on the any of the foot for the preductal and the postductal saturation. Capnography needs to be done. Intra-arterial BP monitoring is done. Frequent ABGs may be required from the preductal arteries. Temperature monitoring is very important, as we have discussed. CBP monitoring to monitor the intravascular volume, and then intraoperative urine output monitoring needs to be done. Now, when the patient is received, we secure IV line in upper limb, nasogastric tube decompression is done, we pre-medicate the child with atropine, and arterial line is placed in the preductal right radial artery site. Now, we pre-oxygenate the child, but we have to keep in mind that bag and mask positive pressure ventilation is to be avoided till intubation. Our preferred method of induction is inhalational induction with spontaneous breathing, and we can use sevoflurane or halothane and intubate without any muscle relaxant. This will eliminate the chances of barotrauma, and we can give muscle relaxant once the child is intubated. Also, another technique is that we can do RSI with propofol or thiopentone and opioids with succinylcholine. And always keep in mind, nitrous oxide is to be avoided because it distends the intrathoracic gut, compressing the lung tissues, and it may cause difficulty in abdominal closure, and which may lead to increased abdominal pressures. Now, in this child, we suddenly found that there was a sudden respiratory distress. Fall in saturation was there, and bradycardia and fall in BP was there, and there was increase in EtCO2. So what it could be? It was there are various causes of fall in saturation, and this could have been pneumothorax. Why pneumothorax occurs? Because when high airway pressures are given to inflate the lung, which is already hypoplastic, sometimes pneumothorax occurs. To manage this, we have to immediately place the intercostal drain and relieve the tension pneumothorax. And for prevention, lower airway pressures needs to be kept. Also, there are other causes of sudden fall in SpO2, which includes there is increase in pulmonary vascular resistance, sometimes which leads to right to left shunt. So we have to avoid hypoxia, acidosis, hypothermia, and pain. And we can treat with analgesics, hyperventilate to improve oxygenation and decrease CO2, as hypocapnia help in decreasing the pulmonary vascular resistance. Also, pharmacological measures like vasodilators can be used. Now, another complication which can occur intraoperatively is when the abdominal contents are placed back into the abdominal cavity and closure is done, there may be respiratory distress and there will be compression of IVC, which may leads to decreased venous return and patients show sudden hypotension. So management includes opening of abdomen to relieve the pressure on great vessels, and patch closure may be done with temporary celastic pouch. Post-operative care includes that we have to decide according to our pulmonary hypoplasia and other parameters like pre-op respiratory distress, size of defect, tension on abdominal wall, that whether we have to extubate or we have to electively ventilate. When we decide to electively ventilate the child, we have to keep in mind that we have to give low tidal volume and low airway pressures are to be kept with high respiratory rate. And our aim is to maintain a PO2 of 80 to 100 mmHg with pH of 7.55. Opioids and medical muscle relaxation is given if patient is on ventilator. We have to maintain normothermia and control the intravascular volume status and prevent rebound pulmonary hypertension. Now coming on to the next medical emergency, let's begin again with a scenario where a 3-day-old male born with 37 weeks of gestational age by vaginal delivery was received and nasogastric tube could not be passed into the stomach and there was progressive abdominal distension which was noticed. Patient was diagnosed to be having tracheoesophageal fistula type C, which was a large fistula just above the carina. No other anomalies existed and the baby was scheduled for surgical correction. Now, what is tracheoesophageal fistula? It is the abnormal connection between trachea and esophagus. And there is an esophageal atresia where there is failure of esophagus to form a continuous passage from the pharynx to the stomach. It is more common in male and patients have antenatal history of polyhydramnios. Now, tracheoesophageal fistula is of 5 types. Type A is the pure esophageal atresia, where there is no connection of the esophagus to the trachea. Then second type B is proximal fistula, where the proximal portion of the esophagus communicates through fistula to the trachea. Then type C is the commonest one, where there is a esophageal atresia and the distal portion of the esophagus communicates with the trachea through the fistula. Then type D, where there are 2 fistulas which connect to the trachea, both proximal and distal ones. Then there is E, which is where there is no esophageal atresia and the esophagus connects with the trachea through a direct connection. Now coming on to the pathophysiology, what happens in TEF, whenever air is inhaled, it bypasses the lungs and it reaches the stomach, which causes the gastric distension, and also there are reflux of contents of the stomach into the trachea causing aspiration pneumonitis. And the esophageal atresia, it leads to pooling of secretions in the blind pouch and this causes drooling of saliva. So whenever child of TEF is received, he presents with excessive salivation. On feeding, there is history of choking, cyanosis and coughing, which occurs, which leads to aspiration pneumonia. And there is failure of passage of catheter down to the stomach, and it is diagnostic of TEF. There is prenatally polyhydramnios history is present and diagnosis can be confirmed by chest x-ray, which shows the catheter in the blind pouch. Now, how this TEF develops? First of all, let's see how esophagus develops. It develops from the foregut, and at around 4th to 5th week of intrauterine life, there is a laryngotracheal groove which is formed, and it divides the foregut into 2 longitudinal tubes, one in the respiratory tract and one in the digestive tract. An imperfect division of this results in a communication known as fistula. Now, TEF is associated with various other congenital anomalies known as vectoral anomalies, which includes vertebral anomalies, anal canal defects. Commonest are cardiac malformations like VSD, ASD, TOF, right-sided aortic arc and PDA, and renal dysplasias and limb deformities can be present. Now we have to investigate this child with complete blood counts because they have poor feeding history and their low HB can be there. Electrolyte abnormalities can be there. We have to get a EBG done. Packed RBCs should be cross-matched and plain chest X-rays to be done, which will show the presence and severity of pulmonary hypoplasia, and it will also diagnose the CHF or aspiration pneumonia. Or chest X-rays to be done, and abdominal X-ray will show air in the stomach and bowels. And also echogram is to be done, which is almost mandatory because there may be major cardiac defects, and it also detects the right-sided aortic arch which may be present. If it is present, then we have to place the patient upside down, the opposite side, not the left lateral, but in the right lateral position, as then the thoracotomy is done from the opposite side. And spinal plane films needs to be done to exclude vertebral anomalies, renal ultrasound to rule out abnormalities of the renal, kidneys, and hydronephrosis. Now, preoperative risk assessment can be done, and it can be done with the help of various classifications. One of them is Spitz classification, where if it is Spitz group 1, then there are more chances, like 96% chances of survival. It includes when there is birth weight of greater than 1.5 kgs and no major cardiac anomalies are present. And Spitz type 3 is like survival is very less than 38%. And when there is birth weight of less than 1.5 kg and major cardiac disease are present, we classify it as Spitz group 3. Other classification includes Watterson and Kulik's classification, which again takes into consideration the birth weight and the pneumonia and the congenital heart diseases, where if weight is greater than 2500 grams and the child is well, then total repair can be done immediately. But if the body weight is less than 1800 grams with no anomalies, no severe congenital anomalies, or when weight is greater than 1800 grams but with severe pneumonia or congenital heart disease, the surgery needs to be postponed. Now, birth weight is no longer considered to be a significant factor for the child survival and predicting the mortality, as we have now advanced neonatal ICU cares, and which has drastically improved the outcome of the children. So we can also use Montreal classification system, which divides the patients into two groups: high risk group, where there are major life-threatening anomalies or there is ventilator dependence of the child, or low risk group where all other patients are included. Now, surgical repair is of two types: primary or complete. Primary repair is done when the defect between upper and lower esophageal segments is less than 2.5 centimeter, and two-stage repair is done when the defect is large. So in this first stage, TEF is ligated and gastrotomy is done. In the second stage, the anastomosis of the esophagus is done. Surgical approach includes that we have to do right posterior lateral thoracotomy is done, which is extrapleural in approach. Patient is placed in left lateral decubitus position with the roll under the chest, and the mediastinum is approached via fourth and fifth intercostal space. Gastrotomy is helpful as it leads to prevents the gastric distension and rupture, and so improves ventilation. It prevents the reflux of gastric contents into the lungs, and it also can be used for the nutrition of the baby. So preoperative considerations are like we have to optimize the child first. There are copious secretions, so we need to place a catheter in the proximal esophageal pouch, and intermittent suctioning needs to be done. And as there are chances of aspiration in these children need not to be fed, and they are kept on IV fluids and glucose, and antibiotics to be given to treat pneumonia. They are dehydrated, so treatment with IV fluids is required. There can be various acid-base disorders like metabolic acidosis, which can be treated by IV fluids and correction of electrolytes, and respiratory acidosis due to pneumonia and shunting, which can be treated by IV antibiotics and ventilation. Now, when patient is taken up in the OR, it is shifted with supine position with head up of 30 degrees, which minimizes the reflux of gastric fluids into the lungs. 2 IV cannulas are placed, and we avoid IV access in the right arm because it is elevated during right thoracotomy and there may be limited access to the right arm. now in pre-medication sedatives to be avoided, and if gastrostomy tube is present, we should leave it open. Monitors are applied. Besides standard monitors, we have to put a precordial stethoscope, which is placed in the dependent axilla, that is on the left side, to monitor if whenever there is any kinking of the left bronchus, or it can detect the obstruction of the tube by blood or mucus. Intra-arterial line is to be placed for ABG and invasive BP monitoring. 2 pulse oximeters are to be placed if we are suspecting any congenital heart disease, and body temperature monitoring needs to be done. Now, regarding induction, in these children, inhalational induction with spontaneous breathing is the preferred method of induction. The vocal cords are sprayed with lignocaine, and then intubation is done. With this technique, we avoid the muscle relaxants. So we are avoiding the gastric insufflation, and so we are further so that there is not further impairment of the oxygenation. Another technique is IV or inhalational induction followed by muscle paralysis. But then if we give muscle paralysis, then we require to give very gentle IPPV, because if we'll give IPPV, risk of distension of fistula and stomach is there, which will increase the risk of aspiration. And awake intubation is not recommended these days at all, because this is so because not only it is difficult to perform and distressing for the baby, but it is associated with oxygen desaturation and trauma, and there are increased chances of rise in ICP or IVH can occur even sometimes. So awake intubation is not recommended these days. Now, after when we intubate, we have to keep in mind that endotracheal tube is to be placed below the opening of fistula and above the carina, so that the fistula is blocked. So we do it with a special technique where we pass the tube into the right main bronchus, which is then withdrawn gradually until the breath sounds are heard equally. Or another thing we can do is we can intubate and pass a fiber optic bronchoscope through the endotracheal tube. We identify the carina, and then endotracheal tube is pulled back along with the fiber optic inside the endotracheal tube until the fistula is visualized. And once we visualize the fistula, we advance the endotracheal tube just distal to the fistula. Now, endotracheal tube position can also be confirmed if we are not using FOB by placing gastrostomy tube in the beaker of water and applying positive pressure ventilation. If there is absence of bubbling, it confirms good positioning of endotracheal tube, that it has occluded the fistula. Now, like the problem comes whenever there is a large fistula, like it was present in our case, or fistula is at the level of carina. So it may be difficult to block the fistula by simple endotracheal tube. So what we can do is we can do a fiber optic bronchoscopy and pass a 2 to 3 French gauge Fogarty embolectomy catheter through the fistula into the stomach, and we can then inflate the balloon of the catheter to occlude the fistula. The disadvantage of this technique is not only being technically a bit difficult, sometimes this dislodgement of the catheter can occur and which can occlude the endotracheal tube, so we have to be very vigilant. Intraoperative management include we maintain the patient with oxygen and air and sevoflurane and on spontaneous ventilation. We don't prefer to give 100% oxygen as there is a risk of retinopathy of prematurity, and muscle relaxants needs to be avoided till the fistula repair is done, though it may be technically challenging. It is because if we give muscle relaxant and ventilate, then there might be some pulmonary damage which can occur. So till the fistula is ligated, we don't prefer to give muscle relaxants. And controlled ventilation with sevoflurane and muscle relaxants is done after the repair of the fistula is being done. Now there can be intraoperative problems, like there are sometimes repeated episodes of desaturation. Why this occurs is because the surgeons pack the lungs to mobilize the distal end of the esophagus. So the management include immediate release of the lungs retraction, which improves the oxygenation and ventilation. Now, other causes of desaturation are that endotracheal tube may enter the fistula sometimes. And you should suspect this if there is difficulty in ventilation or there is desaturation and decrease in end-tidal CO2. ask the surgeons to stop and ask them to palpate the tip of tube in the fistula, which they'll be able to palpate if their tube is in the fistula. Other problems which can occur is that there can be obstruction of the airway due to the kinking of the bronchus, or there can be endotracheal obstruction by the clots or secretions. So you need to do repeated suction, and precordial stethoscope is helpful. There can be bradycardia, as there may be traction on the hilum or traction on the hilum. So it will lead to vagal stimulation. And so there can be bradycardia. Management includes IV atropine. After fistula is ligated, anesthetist passes a catheter from nose into the esophagus, which meets the one from the stomach. Anastomosis is done over the catheter and then withdrawn just above the suture line. This length of the catheter also acts as a guide for suctioning in the intraoperative as well as postoperative period. Now, extubation is planned according to the clinical condition, and we have to keep in mind that there may be tracheomalacia, defective tracheal wall at the site of the fistula, which can lead to collapse of airway. Sometimes we prefer to keep the tracheal intubated, as it is helpful in avoiding the reintubation and damage to the tracheal repair, and it also helps in keeping the gastroesophageal tube in place for several days. And if there are pulmonary complication or inadequate ventilation, then certainly we need to put the child on controlled ventilation. Regarding pain management, IV opioids are helpful in both intraoperatively and postoperatively pain management. And if child is going to be postoperatively ventilated electively, generous dose of opioids can be given. Regional anesthesia is advantageous as it decreases the dose of opioids and it decreases the risk of postoperative respiratory depression. We can pass a caudal catheter and advance it to T6 to T7, and intercostal nerve block can be given by surgeons before the wound closure, and we can place an intrapleural catheter also. It is also placed by the surgeons before closing. Now coming on to the next topic, exomphalmus or omphalocele. What is it? It is a central abdominal wall defect which involves the herniation of abdominal viscera into the umbilical cord. As you can see in the picture, there is a membranous covering over the viscera, and it is that there can be liver, spleen or ovaries which may be present in the sac. The cause of development of omphalocele is that at 10th week there is failure of midgut to return to abdominal cavity. So there is incomplete closure of the anterior abdominal wall around the umbilicus. This defect can be minor or major. Exomphalmus minor means that there is small defect 2 to 5 centimeter in diameter, and major includes larger defect. It involves liver and spleen, and there are poorly developed abdominal and thoracic cavities, and sometimes even pulmonary hypoplasia may be present. Now, in omphalocele, congenital anomalies are more commoner than gastroschiasis. Congenital anomalies include cardiac anomalies, which are commonest, and also there can be trisomy 13, 18 or 21, or collateral or bladder extrophy can be there. Beckwith-Wiedemann syndrome can be associated, or there can be pentalogy of Cantrell. Now, what is gastroschiasis? This is a smaller defect of abdominal wall. It is located to the right side of the umbilical cord, and it occurs due to the occlusion of omphalomesenteric artery with ischemia to the right periumbilical area. Now, testes, ovary and liver are less commonly involved in this, and there is no membranous covering present in gastroschiasis, as you can see in this picture also, and herniated bowel are directly exposed to the contents of the amniotic cavity. Congenital anomalies are less common, and if present, they mainly include GIT anomalies like intestinal atresia and malrotation of gut. Now you can see the difference between omphalocele and gastroschiasis. This is omphalocele, which is central defect and there is a membranous covering. This is gastroschiasis, which is a periumbilical defect and there is no covering. And the difference in their etiology is that one is due to the failure of gut migration from the yolk sac into abdomen, and gastroschiasis is due to occlusion of omphalomesenteric artery. So the omphalocele is centrally located and gastroschiasis is lateral to the umbilicus. Now, surgery for exophthalmos is elective unless and until there is rupture of the sac, and gastroschisis is taken as an emergency procedure. If it is a small defect, it is done in single stage, but if there are larger defects, then there is a formation of sialistic pouch is done and gradual reduction is done. Now, anesthetic concerns include that these children have congenital anomalies. There may be difficult airway, especially when associated with Beckwith-Wiedemann syndrome. They have a large tongue. Then we have to take care of the herniated bowel or viscera, because see, if the membrane is ruptured, then it has to be covered with saline soaked gauze, and the patient is to be nursed properly with the bowel supported. As you can see in this picture, that the bowel is supported. This reduces the edema of the bowel, and it is very helpful after the surgery also. Then we have to prevent the heat loss. As you can see here, it is covered with a waterproof cellophane bowel bag, and temperature regulation is to be taken care of. As this viscera is exposed to the environment, there may be large amount of heat loss, so they needs to be nursed in incubator and to be kept warm, and fluid resuscitation is very important. Treatment of sepsis is done with antibiotics, and lung hypoplasia may be present in infants with large omphalocele. Bowel decompression needs to be done with the nasogastric tube. Investigations include routine full blood count, capillary blood gases, RFT and KFT, BGCM, X-ray of the abdomen and chest, and then ECG, renal ultrasound, head scan to rule out the congenital anomalies. Now, anesthetic concerns include that we have to prevent the heat loss and hypothermia, which can be in very large amount if the bowel is exposed to the environment. So we need to transfer the neonate to OR in warm incubator, and we have to maintain the ambient OT temperatures and place the neonate on a warming blanket, and we have to give humidified inhaled gases. Then we have to keep in mind that IV line is to be placed in upper limb only, because when the abdominal contents are put back into the abdominal cavity, it may cause compression of the inferior vena cava, and there may be decreased venous return from the lower body. Now, anesthetic management is done by rapid sequence intubation. Rapid sequence induction, we intubate the child. Nitrous oxide will be avoided as it will cause bowel distension. And muscle relaxant of choice is atracurium. We have to watch for abdominal compartment syndrome and avoid hypotension. So we have to use volatile anesthetics, moderate to low concentration. Serial blood glucose monitoring is to be done as it may be associated with Beckwith-Wiedemann syndrome. Intraoperative challenges include that after amniotic membrane is removed, large volumes of fluid loss may be there from exposed abdominal viscera. So this fluid lost is ECF, so it should be replaced with balanced salt solution. Now there can be one complication which can occur, which includes abdominal compartment syndrome. This occurs when the abdominal contents are placed back into the abdominal cavity and abdominal closure is done. It may compress onto the vena cava and the liver, which may decrease the venous return and cardiac output, leading to severe hypotension. And ultimately, there can be even bowel necrosis or perforation because of this. So to avoid this, we have to be vigilant and we have to monitor the lower extremity BP and SpO2 so that we can identify the circulatory problems. We have to identify the congestion and cyanosis in the lower extremity. And there we can observe whenever abdominal compartment syndrome is developing, there may be increase in peak airway pressures which can occur. And so it can lead to even decrease in SpO2, which are indicative of that there is non-feasibility of the primary closure. So management includes immediate opening of the abdomen. Now, a decision for extubation is done depending on the size of the gastroschisis and exophthalmos major. And neonates are extubated when they are fully awake, and we have to watch for signs of abdominal compression. And we can consider giving TPN in the postoperative period. Last but not the least, let's come to HOPS, hypertrophic obstructive pyloric stenosis, which presents between 2nd to 6th week of life. Here there is hypertrophy of the pyloric smooth muscle with edema of the pyloric mucosa and the submucosa. This leads to obstruction of the pyloric wall, causing persistent vomiting and loss of fluid and electrolytes. Diagnosis is made by the symptoms and ultrasound. So the child presents with non-bilious projectile vomiting with visible peristalsis. Also, there is hyponatremia, hypochloremia, hypokalemia with metabolic alkalosis. Dehydration and lethargy is noted. Metabolic alkalosis is there, which causes compensatory respiratory acidosis, shift of ODC to the left, and there is hypocalcemia and convulsions. So remember, it is not a surgical emergency, but it is more of a medical emergencies. So we have to correct the metabolic alkalosis, which is present with hypochloremia and hypokalemia, and we have to correct the severe dehydration first. Then we have to take up the child. Also, we have to remember that these children are considered to be full stomach. So patient is resuscitated adequately with balanced salt solution, and we can add potassium to this once the urination of the child starts. Anesthetic management includes, we place a large orogastric tube to aspirate the stomach contents, which reduces the gastric fluid and the aspiration chances. RSI is preferred, and again, awake intubation is not done. After intubation, orogastric tube is repositioned and left in place. Sometimes it is used to insufflate the stomach with air to test for the mucosal perforation after hypertrophied muscle is split by the surgeons. And at the end of the case, the patient should be wide awake before extubation. And one more important thing is that these children have high incidence of post-op apneic spells. So apnea monitoring is to be done for first few hours. Regarding pain management, as these children are at post-op apnea risk, opioids have to be given minimal. We can use IV or rectal paracetamol. Bupivacaine can be used for infiltration, and then we can give tab block ultrasound guided for post-op pain relief, and local infiltration at the laparoscopic sites can be done. So with this, I conclude my topic, neonatal emergencies. Thank you. I hope you enjoyed listening to the topic.
So that was another very lucid lecture by Dr. Anshu, and I am sure the postgraduates, have benefited hugely. At least I have managed to go through everything all over again, and I think it has been presented very, very well. So, Anupama, are there any questions from my chat box? I cannot see any questions actually. So you may ask the questions. We can't hear you.
Ma'am, there are two questions.
Yes.
Dr. Anshu, for the first question is, what is the narrowest area in a newborn?
Narrowest area in the newborn is subglottic area. And regarding previous talk, can I speak a point? Like I would like to add, like one of the students asked about the cuff tubes. So I would like to tell that in our center in Kalavati Saran Children Hospital, we are very well using cuff tubes in neonates, and we are using micro cuff tubes. See, micro cuff is made up of a very thin material. So what happens is it is better than PVC, that it causes a complete seal around the trachea and it is not exerting any pressure. It is a very thin material made tube. So micro cuffs are very helpful, and we are using micro cuff tubes for the neonates these days. And
ma'am, if you can say something.
That's a good point, definitely. So any other question is there, Dr. Anupama?
Yes, ma'am. There's another question, Dr. Anshu. How noradrenaline and dopamine can be given for systemic vasodilatation?
See, the role of NORAD and DOPA and DOBUTA, all these agents come because as we have discussed, there is right ventricular hypertrophy, right heart failure, and there is left heart failure. So due to the left heart failure, what is happening is there is decreased cardiac output. So noradrenaline, when given in low doses, it causes positive inotropic effect and it increases the cardiac output. Similarly, dopamine, if given in intermediate doses, it will increase the cardiac output.
it has a positive inotropic effect, and it will cause increased cardiac output and systemic vasodilation also. Now remember that whenever ADR is given in low doses, it will cause positive inotropy, whereas if it is given in higher doses, in low doses I mean 0.1 to 0.5 mics per kg per minute, but if it is given more than 0.5 mics per kg per minute, then it will again cause increase in systemic vascular resistance, and it will not be helpful for the child. So remember to give ADR in the low doses, and dopamine should be given in intermediate doses. That means 5 to 10 mics per kg per minute can be given. That will helpful in increasing the cardiac output, and this will be very helpful in maintaining the circulation.
Yeah, so I would like to add a point in to Dr. Anshu's lecture, is that children, when you are monitoring a patient, when you're medically optimizing a patient who is for a pyloric stenosis surgery, for a cardiomyotomy, how do you monitor that, how much optimization has been done? So you have to keep track of the chloride levels, the bicarb levels, the sodium and the potassium levels. So when you see that the chloride levels are going beyond 95, and when the bicarb levels are coming in the range, and of course sodium and potassium have normalized, that is the point when you know that your patient is optimally optimized for a surgery. So you have to keep on giving fluid replacement till the chloride rises more than 95. Yeah, so that was one point over there. And
Okay,
otherwise, I think everything has been taken, done very, very well. So are the children getting any handouts also of these lectures?
Yes, ma'am.
So are the chairpersons also
Ma'am, we will
getting
be,
a handout?
yes.
Yeah, we will definitely like
Ma'am, we will be present.
Yeah,
So,
so
ma'am,
I
before
think it
that,
has
moving,
been
we
covered
have
very
few
well,
questions.
all the pictures and the diagrammatic representation. It was very lucid and very self-explanatory. So I think it will be very good for the kids when they are revising the topics.
Yes, ma'am. Yes, ma'am. Ma'am, there are a few more questions if
Yeah, sure.
Dr. Anshu can
Yeah,
answer.
Yeah.
One of the delegates is asking, is KCL mandatory for fluid strategy in pediatrics during maintenance fluids?
Like in as I have mentioned, like in HOPS, we have lots of fluid loss due to the vomiting persistent. So what is happening is we replace it with balanced salt solution, and we add potassium chloride when we see that adequate urine output has been achieved. After that, we add KCl to the fluid.
Okay. And another question, ma'am, how to do fluid management in a patient in gastroschisis when dehydration is already present? How to calculate the fluid?
See, the formula remains the same, but we have to watch for the, like we will replace with the same strategy as we do in any other neonate. But the only thing we have to be vigilant is that we have to see the signs of adequate hydration. Like we have to see the skin turgor and the adequate urine output. We have to monitor persistently and watch for the signs that adequate hydration has occurred. And this is the time we consider that hydration has occurred. And we manage with the same strategy.
Okay, ma'am. And is rapid sequence induction being done in these patients?
Which gastroschisis?
Gastroschisis, yes.
Yeah, rapid sequence induction is very, very much done in these patients, as we consider them as full stomach, as there are contents in the umbilical cord, and these are to be considered as full stomach. So we consider our RSI in these patients.
Okay. And another delegate is asking, is the narrowest area subglottic or cricoid? Because in the previous lecture, I think it was mentioned as cricoid. So what is to be told in the viva?
See, definitely it is the subglottic area, which is the narrowest area. And that is why we always recommend to use smaller size tubes. Whatever we can see while intubating is not the diameter we require for intubation. See, we always tell postgraduates to use the tube which is smaller than the glottic opening. So it is definitely a subglottic area. It's given very well in Miller and other standard textbooks.
Okay. So that's all the questions. Aparna ma'am, do you want to conclude the session, ma'am?
Yeah, I think we can conclude the session. So I think
Dr.
congratulations to
Aparna,
both the speakers, because I think both the topics are
Dr.
Ma'am,
Anupama,
Dr.
I
MD.
would like
significant
to
and
add a
so
point.
important from examination point of view also.
Yes, ma'am. Yes,
And
ma'am.
of course,
Dr. Aparna
compliments to
ma'am,
the
sorry to interrupt you.
organizers,
Actually,
Dr.
Dr.
Kaur.
MD ma'am
Yeah.
wants to say.
Yes, yes, please. Yes, ma'am.
Yes, ma'am.
Sorry to interrupt. Actually, whenever we have resuscitated a child after, like Dr. Aparna told you that the electrolytes are being corrected or have come to the correct level, then I just want to add a point that whenever the child is resuscitated, hydrated, then child is active and normothermic. That is one thing which is very important. So
Yes.
whenever we are resuscitating a child, any child who has been resuscitated well would clinically be normothermic and playful and active. And in these are the situations where the child doesn't have any pain. So we generally can find out on the table that child is hydrated now, and you can take the patient.
Definitely.
Yeah.
Definitely.
Thank you, Dr. Aparna, for being
Thank
a part
you so
of
much,
the...
ma'am. And it is a beautifully organized event. So compliments to all of you, and everything, the help that we are getting from the organizers and their punctuality, and it is very well timed. Yes, definitely.
Actually, I must say that it is something God's will that otherwise humanly it is not possible. I myself I'm feeling very good about it that we are going.
Yes, because it's a teamwork and your team is doing very well.
Yes, yes. Thank you so much, and thanks to all the speakers also, and my best wishes to the postgraduate students who are our delegates.
Yeah, all the best to the PGs. Yes.
Thank you, ma'am.
Thank you.
Thank you.
Thank you, Dr. Thank you, Dr. Aparna ma'am, for your precious time for these lectures. Thank you. Thank you so much. So moving on to our next session. So we have, can we have Dr. Rama Vasan? Ma'am, so ma'am will be chairing the next session, which is a lecture pediatric emergency series on torsion phlebotomy and obstructed hernia. Madam is professor and consultant and ex-HOD in the Department of Anesthesiology and Intensive Care in Vardhaman Medical College and Safdarjung Hospital. She is also a postgraduate teacher and a guide, very academically oriented. She is a postgraduate examiner for Delhi and other state universities. She has various publications in national and international journals, and her areas of interest are pain relief, simulation, and obstetric anesthesia. Over to you, ma'am.
Thank you. Can you hear me?
Ma'am, please.
Thank you. Can you hear me?
Yes, ma'am, we can hear you.
Okay.
Yes, of course, ma'am, we can hear you.
Okay. I thank the organizers for giving me this opportunity to chair this session. And could we have the CV slide for the presenter? For the presenter. Now, this is a session in which we'll be talking about some of the other emergencies that we come across in pediatrics. And Dr. Anita Malik, who is an ex-professor and HOD in King George's Medical University of Lucknow, and her area of interest is pediatric anesthesia. So I'm sure all of you will gain a lot from her lecture. So I welcome Dr. Anita Malik to start the session.
So today's lecture is pediatric emergency surgeries, and I'll be covering up laparotomy, obstructed hernia, and torsion testes. First of all, I'll take up the laparotomy. The case scenario is a 6-month-old 5 kg male child, which is brought to emergency with a history of vomiting, diarrhea, mucoid, and blood-tinged stools. for the past 2 days. Baby is irritable, crying, lethargic with sunken anterior fontanella, sunken eyes, dry oral mucous membranes, tachycardia, and the saturation is 95% with minimum urine for the past 8 to 12 hours. On USG, intussusception was diagnosed, and the baby was scheduled for emergency exploratory laparotomy. Intussusception is 1 in every 2,000 live births, mostly infants less than 1 year in its male predominance. As the prolapsing portion called the intussusceptum enters the receiving portion, the intussuscipiens, the lymphatic, venous and arterial blood flow to the intestine becomes compromised. And if at this stage it's not relieved, the bowel steadily becomes gangrenous. The classical triad of symptoms of intussusception, abdominal pain, bloody stools, and vomitings, they are present in less than 50% of patients. In X-ray, we can notice a crescent shape. This crescent shape, which is in the left upper quadrant, this is the invaginating intestine, which is going inside the air pocket of the large intestine. Here also a round structure is seen. This is also a part of that intussusception, which is gut inside gut, but this is not very clear in plain X-rays. That's why ultrasonography is being done. And in ultrasonography, the target sign, this is the target sign or bull's eye or donut sign, gut inside the gut. It is there in the whenever you do the ultrasonography. So ultrasonography imaging is the method of choice. There are so many causes of intussusception, but in all of them, the formation of a lead point on the intussusceptum is the one which instigates the process. Normal bowel contains gas, food, salivary, gastric biliary secretions, and the intrinsic or extrinsic bronchus of the small bowel. It causes the secretions to accumulate, and when the proximal part of that obstruction increases in size, the intraluminal pressure is more than the capillary and venous pressure in the bowel wall. The intestinal absorption and lymphatic drainages, they decrease, and the bowel ischemia, inflammation, and overgrowth of fecal bacteria is there, which may lead on to perforation. This is known as bacterial translocation because bacteria will pass into the peritoneum, and when they enter the circulation, they cause septicemia, and a cascade of events which impacts almost every system is there, which poses many challenges to the anesthetists. Preoperative assessment in this particular patient, there's severe abdominal pain, vomiting, diarrhea, distended abdomen, and dehydration, which is very important for us. Dehydration is there with tachycardia and tachypnea. Of course, in investigation, serum sodium is 126 millimoles per liter and potassium 3.1, while hemoglobin is 8 gram percent. So assessment of dehydration hypovolemia is very important in patients of intussusception. So assessment and appropriate resuscitation is essential preoperatively. Now, intravascular volume, whenever it decreases, it stimulates renin, angiotensin 2, aldosterone 1, and along with all these activities, the tendency is to increase the intravascular volume and to increase or maintain the blood pressure, which is a normal tendency for the body under the threat of this intussusception. There are different clinical signs of dehydration, and mild, moderate, and severe if the weight of the baby is less than 10 kg, which is applicable in this particular case. Then the mild dehydration is 5%, 10%, moderate, and severe is 15%. However, in babies more than 10 kgs, 3, 6, and 9% is applicable. So in this particular baby, the dehydration is almost 10% because the signs, baby is lethargic, fontanella is sunken, and when fontanella is sunken, there are 3 criteria. If the fontanella is flattened, it's normal, almost normal, but when it is depressed and it touches the lower edge of the bony scalp, then it is almost 5%, and if it's more sunken beyond that the bony edge, then 10% or more of that dehydration is there. So in this particular baby, the signs are more tachycardia, then this blood pressure is almost normal. It all goes in favor of the moderate dehydration. So 10% water dehydration means baby has lost 100 ml per kg of the fluid. Now, in this case scenario, the child is also demonstrating the hyponatremia, and this hyponatremia might have been because of the electrolyte loss inside the distended bowel, or it may be that inappropriate use of 5% dextrose in the initial resuscitation might have been infused, which caused this hyponatremia. Potassium is low, but they should be monitored, and potassium is added to the maintenance fluids after surgery if it is required. Now, whenever we deal with a case of obstruction in small babies as well as in adults, rapid sequence induction is required. So rapid sequence induction is recommended for children with a full stomach to quickly secure the airway to minimize the risk of aspiration. But there are complications of RSI also, because if improperly performed RSI is there, that means excessive cricoid pressure, which distorts the airway anatomy and it creates difficulty in securing the airway. Then problems are there and a normal airway may become difficult. Secondly, poor selection of patients means known difficult airway, and we are again pressing the airway with the cricoid, making it more difficult. So neonates and infants, they may develop hypoxemia also because they have higher baseline oxygen consumption as compared to adult, and the apneic FRC is very much reduced as compared to adults. Controlled RSI technique using low insufflation pressures has also been proposed in 2013. An article showed that almost 1,000 patients were retrospectively studied, and they came to the conclusion that controlled rapid sequence induction and intubation technique with gentle face mask ventilation prior to intubation may be a safer and more appropriate approach to pediatric patients. So in other ways, one can do this also, that not from the beginning you do the gentle ventilation. You can attempt it. If the first attempt at tracheal intubation fails or the child desaturate in limits during laryngoscopy, the cricoid pressure which is already being maintained may allow bag mask ventilation to restore oxygenation without increasing the risk of regurgitation. Now, regarding the muscle relaxant for RSI, succinylcholine remains useful for this. However, with the advent of this rocuronium, which has rapid onset, it has dramatically reduced the use of succinylcholine in elective surgeries because with succinylcholine, there's risk of hyperkalemia after this in children, especially males less than 8 years with undiagnosed neuromuscular disease. Inability to intubate and prolonged paralysis may present serious possible life-threatening problems in case rocuronium is being used and one is not able to intubate. So there is some risk, but this risk is tackled where Sugamadex is available. So then we can straight away go with the rocuronium. Otherwise, succinylcholine for rapid sequence induction in full stomach is advisable. Regarding nasogastric tube, Presence of a nasogastric tube may decrease lower esophageal sphincter tone, increase the risk for reflux, and it decreases the ability to clear the distal esophagus contents. So it may be reasonable to apply suction to the nasogastric tube, evacuate all the gastric contents, and then remove the nasogastric tube before inducing anesthesia. Because it is unclear whether cricoid pressure, even if properly applied, it prevents wicking of the gastric contents along the path created by the nasogastric tube. And even with a well-placed nasogastric tube, it never guarantees that the stomach has been completely emptied. Monitors, all the routine anesthesia monitors along with end-tidal volatile agent, if available, NMT if available, they are always helpful, but core temperature is very important. So circulatory volume status is assessed with pulse oximetry. Capillary refill should be less than 2 seconds. Warmth of the peripheries, then amplitude of the heart sounds can be heard through the precordial stethoscope, and urine output should be at least more than 0.5 ml per kg. Temperature should be well maintained. There are 6 W's, you can remember that. Warm OTs, IV fluids, irrigating fluids, towels wrapped around the head and extremities, warm saline, soap pads which cover the exposed guts, which is a major cause for hypothermia. And of course, heat and moisture exchange filters if they are there. Regarding anesthesia, vascular access definitely is required at 2 places. But if the baby is hemodynamically unstable, then arterial and central venous catheters are to be there. Then adequate pre-oxygenation is required because distended bowel, it compresses the diaphragm, atelectasis, and inadequate lung associated with expression is there, and desaturation happens after induction. But it's a bit difficult to adequately pre-oxygenate a small baby. But it has to be done. Then nasogastric aspiration, RSI is done with induction agent, either thiopentone or propofol. If baby is hemodynamically unstable, then ketamine or etomidate, and muscle relaxant, of course, succinylcholine or rocuronium. In patients of bowel obstruction and accompanying sepsis or moderate dehydration or severe dehydration, rather, I'll say, ketamine and etomidate, they are helpful because they maintain the hemodynamic status. But if hypotension is there because of severe hypovolemia, they may not be helpful. But still, arterial blood pressure is much on the lower side when ketamine or etomidate is used as compared to thiopentone or propofol. So the importance of normalizing the intravascular volume as much as possible before the induction of anesthesia cannot be overemphasized. Maintenance of anesthesia is with SIBO or isoflurane with muscle relaxant, or rocuronium or etrocuronium or rocuronium can be used. Nitrous oxide should be avoided because it increases the bowel lumen volume and increases the intra-abdominal pressure and may cause difficulty to the surgeon. Regarding fluid management, immediately after induction of anesthesia, vascular sympathetic tone may be attenuated, leading to sudden hemodynamic instability. So one has to be very careful. So fluid resuscitation is very important both before and after induction of anesthesia. And the volumes of fluids should be the sum of early maintenance requirements, pre-existing deficits, and ongoing losses. This is the list of various intravenous fluids which are being used. Lactated ringer is more advantageous than this isotonic saline because the quantity of sodium is a bit less than this, but simultaneously chloride is less. With persisting use of this saline, there are chances of hyperchloremic acidosis, which can be avoided with lactated ringer. But to deal with the dehydration, we can use isotonic solution, which may be lactated ringer or saline. Plasma light is also being used. And isoprolite P is not being used because though it contains dextrose, it's all right to deal with the hypoglycemia, but simultaneously in small babies, sodium quantity is very low. And as you see that during surgery, ADH is there, ADH is secreted, and because of that, chances of hyponatremia are more. So isolite P precipitates it. That's why it's not being used nowadays. The type of fluid is dependent on the existing electrolyte imbalance in blood glucose levels. So early maintenance fluid requirement is based on Holiday-Segar formula. Additional volume of 6 to 10 ml kg per hour should be added to compensate for evaporation from an open wound, and further boluses depend on the extent of bowel trauma and according to the sepsis or the condition of the patient. Maximum allowable blood loss has to be calculated beforehand. Now, if blood is required, then a formula is there that whole blood, which is 8 ml per kg, raises hemoglobin by 1 gram%. Now, this baby is having a hemoglobin of 8 gram%, and desired hemoglobin should be 10. So, baby requires 16 milligram per kg of the whole blood. Similarly, if PRBC is to be used, then PRBC is as 4 ml per kg and baby's weight is 8 kg. So it would be 8 ml of PRBC per kg can be given. Now regarding pain management, acetaminophen, fentanyl, and once the baby comes out, dexmedetomidine can be given. And regional anesthesia, depending upon the surgical approach of the patient and the clinical condition, can be given. TAP block is very successful, and epidural block in the form of caudal block is very appropriate. Post-operatively, after surgery, the endotracheal tube is left in place until the patient is awake, and muscle relaxant is reversed, aspiration is done, adequate analgesia is established, and intravenous fluids should continue until oral intake is re-established. And particularly in this case, because it's having moderate dehydration, so for the initial post-operative first 12 hours, we can reduce the formula of Holiday-Segar to, instead of 4:1, to 2:1.5, and then we can resume to 4:1 after checking the electrolytes. Now we'll come to obstructed inguinal hernia. The obstructed inguinal hernia case scenario: 10 months, irritable, crying boy presenting with slight distended abdomen and scrotum filled with loops of bowel. Investigations are almost normal, and the diagnosis of obstructed inguinal hernia was confirmed, and the child was prepared for surgery. The majority of hernias in children, they occur in the groin. Inguinal hernias are always indirect, more common in boys, often bilateral. And the trapped bowel through the weakness in abdominal wall can produce symptoms of severe pain, nausea, vomiting. Blood supply of the trapped bowel, if becomes compromised, then irreversible ischemic damage to the bowel may happen, and emergency surgery should proceed. Fluids, the resuscitation initially should consist of fluid boluses of either isotonic crystalloids, which may have a normal saline or ringer lactate, with 20 ml per kg in particularly. Say if the baby, suppose, I'm not talking about this, but if the baby is 8 kg, then you can give 160 ml bolus. Now, improvement in clinical signs are improved infusion, reduced capillary fill time, reduced heart rate, and child becomes more alert. In preoperative assessment, duration of symptom is very important. Last meal taken is very important. Past medical history and other important things like cough, URTI, past medical conditions, and the other assessment is important apart from history of allergies. In investigation, full blood count, especially hemoglobin, then serum electrolytes, sodium, potassium, blood for cross-matching, and blood glucose is important with serum creatinine. Monitoring is the same as we did in the intussusception. Then gastric emptying is delayed in obstructed hernia. So even if the child has been starved for 6 hours or more, they should be treated as if they have a full stomach. So the management would be after considering this case as a full stomach case. Nasogastric intubation, nasogastric aspiration should be done. Atropine is given 20 microgram per kg, adequate pre-oxygenation, and modified RSI with the application of required pressure before securing the airway with a tracheal tube. Thiopentone or propofol, ketamine or etomidate for induction is used, and succinylcholine for intubation, and patient is kept on IPP with rocuronium, atrocurium or vacuronium with SIVO or ISO. Isotonic crystalloids are preferred. Blood is required, then it's given. Otherwise, in this case, baby is having almost normal hemoglobin, so no need of giving blood. So volume of fluid should be the sum of hourly maintenance requirement, same application of holiday cigar, and in between fluid boluses of 10 to 20 ml has to be repeated. And we always assume that the baby has been already well resuscitated, but if the condition is not like that, blood pressure dips, then this 10 ml per kg of the bolus should be repeated. Analgesia, of course, with acetaminophen and fentanyl 1 to 2 microgram. Caudal or ilioinguinal block, it would provide appropriate analgesia for inguinal hernia repair, and both should be performed once the child is anesthetized prior to the start of the surgery. Post-op management, child should be warm and pain-free, maintenance fluid calculators and 4-to-1 formula. And additional potassium may also be required after checking it. So it is essential that fluid and electrolyte balance is closely monitored. Now comes to the torsion testis. Case scenario, 1-year-old 10 kg male with sudden onset of acute scrotal pain in the absence of trauma, which is very important and requires immediate investigation and possible surgery to preserve a potentially viable testis. DD of this may be torsion of testicular appendix, spermatic cord, epididymitis, or incarcerated hernia. Diagnosis is confirmed by Doppler, ultrasonography, or suspected on clinical ground. And the majority of testes can be saved if surgery is performed within 6 hours of onset of pain. But the salvage rate of the testis decreases to 50% if the surgery is undertaken 6 to 12 hours after the onset of the pain. Children with suspected acute testicular torsion should be considered an acute abdomen and assumed to have a full stomach. These children, otherwise healthy or have stable medical conditions that do not require more than a careful history, physical examination, or a review of the child's medical record. With anesthesia, atropine 20 microgram per kg to avoid bradycardia prior to succinylcholine. Modified RSI because we are considering this patient as full stomach. Thiopentone or propofol for induction. Succinylcholine or rocuronium for endotracheal intubation. IPP with rocuronium, atrocurium, or vacuronium. And with SIVO or ISO. When the surgeon pulls the testis during surgery, laryngospasm may occur if the depth of anesthesia is inadequate. If the baby is well settled with relaxants, then this laryngospasm doesn't occur. But by chance, if the baby is in that situation where the effect of this muscle relaxant is wearing off, at that time it may happen. So anesthesia can be deepened most rapidly by IV bolus or propofol, increasing the inspired concentration of inhalation anesthetic. And of course, you have to repeat the relaxant if it's there. Pain management, acetaminophen, ketorolac can also be used. Regional anesthesia, caudal with ropivacaine can be given, or ilioinguinal or iliohypogastric nerve block under ultrasound guidance may be given. Scrotal infiltration, if surgical incision is confined to scrotum, and upon emergence, dexmedetomidine 0.5 to 1 microgram per kg upon emergence can be given. Thank you.
So Dr. Anita, ma'am, can we have the questions? Dr. Anita, you need to.
Yeah.
Dr. Anita,
Yes.
you need to unmute yourself. Yes, ma'am. So, ma'am, can I read out the questions to you?
Yeah, sure.
So, the first question is, can you please explain how to assess or quantify how much cricoid pressure should be given to small babies?
Actually, there is controversy and regarding this cricoid pressure. Rather, it should be cricoid manipulation in pediatric patients particularly, and that's why it's been reduced just to pediatric population with aspiration, danger of aspiration pneumonitis. Normally, in adults, when you apply cricoid pressure, the force they say it should be 3 to 4 kg or say 30 newtons. But this is not applicable in small babies. There the force has been even reduced to 5 newtons, and they say that this much force is sufficient to press the esophagus. One has to hold this initially before making the baby under. You have to palpate for the cricoid, because this is a very crucial step. Once the baby is induced, you apply it with a thumb on one side and this middle finger on the other side of this. And with this index finger, you have to press. And this pressure should go straight forward, because it's only the slipping of that cricoid cartilage which causes the failure of this application. Burp method is there, backward, upward, right, but you have to go straight backward with this, not with much of force. And when you apply this, because in pediatric patients, the vertebral bodies, they are not very uniformly structured, the anterior surface of that. And of course, esophagus has to be pressed against those vertebral bodies. So that's why there are more chances of larynx slipping to either of the side of this, and one is not able to apply it properly. So actual, it should be 5 to 10 newtons of force with index finger, and that I think that should be sufficient. But it's a lot of controversies are going on. People are applying this cricoid pressure with different maneuvers. That's why modified RSI with this cricoid manipulation is there.
Okay, ma'am. There are other questions. What is the dose? Why is the dose of etomidate higher in adults? You told 2 milligrams per kg. Why is it less in neonates, in children?
In neonates, we have to induce whenever we start with induction in hemodynamically unstable patients, because the etomidate, the main controversy regarding this dose was in septic patients, or when used, it was used in critical care patients where adrenal suppression is there. So keeping these things in mind, that it may hamper that we are using it for a better purpose of stabilizing the patient. That's why the dose is like this in pediatric patients.
Okay. Okay, ma'am. And one delegate is asking, generally we put dextrose fluid in the maintenance fluid. How to calculate this? And is it to prevent intra hypoglycemia? And what is the consensus of that?
Okay. Dextrose is not always, it's not always put in the maintenance solution. Recommended is 1 to 2% of dextrose is sufficient, because if dextrose is more in the maintenance solution and dextrose is being utilized, so then it remains plain water. So in those patients where we don't want water to be overloaded, like in neurological patients or the patients of sepsis, where the leakages, capillary leakage is there, in those patients we may not use it. But of course, in neonates, in those patients who are more prone for hypoglycemia, there it is a must. But otherwise, not more than 1% of that is advised.
Okay. And another question, Macintosh versus Miller blade preference in recent practice for infants and neonates?
Still, controversy is still there. It's not established. Debate is still going on. But in small babies, say if we talk about infants, with Macintosh, there are definitely chances of slipping of the tongue. Definitely, because the tongue is large as compared to older children, right? Where it is very convenient. So if a Miller blade is put inside, it's straight, and it, you know, even if you go straight, like you go in video laryngoscopy, you go straight and then you start withdrawing, automatically the large epiglottis, it comes under surface of that flange, and you have a tunneled view. At least this view is unhampered. In case of Macintosh, the view is hampered many a times because there are so many factors. Those factors are applicable in Miller laryngoscopy also. But here, because that channel is a straight one, so it's very convenient and easy. But definitely you have to focus for that channel view. So it's, I mean, this is my view, which I'm compiling.
Okay, all these things. Okay, ma'am. And one more question, how to put nasogastric tube before RSI, and won't Dexmed cause bradycardia in children? The two questions.
Okay, so if you say Dexmed causing bradycardia, it is dose dependent. What we have seen and what literature also says, it's mostly it's dose more than 0.7. Otherwise, if you use with the 0.5, 0.25 is almost non-existent. 0.5, it's sufficient. But most of the literature, they are using 1. And one should be prepared for bradycardia in that case. Second is nasogastric tube. In nasogastric intubation, in this nasogastric tube for aspiration. Nasogastric tube for aspiration, it's most of the time it's already there, but if you have to pass it, in small babies, it's difficult, very small babies, it's difficult to, feel for which nares is patent. So you have to take the tube which has blunt end, and then you add inside, put it inside one of the nostrils with a rotating movement. Sometimes you can warm up this in this boiled saline so that it becomes softened, and then you try to enter this through either of the nares, which is a patent, and you can then aspirate. And if it's not successful, you can do oral suction also by passing this nasogastric tube through oral route.
Sure, ma'am. Dr. Rama, ma'am, do we have your expert comments on the above questions?
Yeah. I would like to add in that question for the addition of dextrose to the fluids. What we practice in our setting is that if the patient, the child has been on preoperative fluids, dextrose containing fluids, then we definitely give the child dextrose containing fluid with either 1% usually, in 100 ml of ringer, say 90 ml ringer and 10 ml of 5% dextrose we add to that. Okay, and this is what we continue, because the child who has been on dextrose preoperatively is more prone to having hypoglycemia intraoperatively because his insulin is already stimulated. Also, I would like to add a comment on this hernia, obstructed hernia. It is very common, in premature infants. So that prematurity and the risks of course, the child that madam presented was a little older child, but otherwise, this bilateral hernia, and this is more common with premature children who are born premature gestational age. So, they should be electively, taken up for surgery at the earliest possible so that they do not land up with obstructed hernia. And of course, the problems with premature children, as we know that we have to look for post-operative apnea and all, we have to monitor them, rigorously for at least 12 to 24 hours before we shift them. And rest, I think it has been a very good presentation. Another thing in laparotomy patients, especially, though madam has presented intersusception, another emergency I would like to say is volvulus, which is dangerous and can cause gangrene if not taken up early. So these are the things to be kept in mind. And would madam like to comment anything on the neurobehavioral changes that the child can have, or any emergence delirium in children, receiving this sevoflurane or this thing?
Yeah, it is there, but it's not very high, because dexmedetomidine is being used frequently nowadays. So that tackles a lot, because
are you using sorry to interrupt, but are you using to treat it or to prevent it?
It varies from anesthetist to anesthetist. Actually, speaking it that way, it's not established. It's not established.
Yeah,
it's not established.
Thank you very much. It has been a very good discussion, and I'm very thankful to Dr. Mohandeep Kaur and all your team for doing a very great job and benefiting all the postgraduates. All the best for the postgraduates. Thank you.
Thank you, ma'am. Thank you, Dr. Anita, ma'am. Thank you, Dr. Rama, ma'am, for your taking time out. Graduates. Thank you, ma'am.
Thank you.
So we'll have a short tea break. and we'll resume the session after the tea break. Before the tea break, we can have quiz questions for the postgraduates, and it will be displayed on the screen. You will have to answer the questions in the chat box. It will be displayed for 5 minutes. I can see Dr. Ramkumar sir, you have logged in, so we are running a little late. So we'll be resuming the session after the tea break, sir.
And how long is the tea break, Anupama? How long is the tea break, Anupama?
So 10 minutes. 10 minutes.
Okay, right.
Yes, sir. So 10 minutes. We'll be resuming at 10:45.
Thank you. I'll be back.
Thank you, sir. Thank you, Ayata. Thank you. So for the postgraduates, these are the 2 questions. Please answer in the chat box, and we'll resume the session at 10:45. So we'll resume at 10:45.
Hi, doctors. We are live now.
Welcome back, all the delegates. So let's begin with the next session. So we have two lectures on adenoid tonsillectomy and tonsillectomy, and the second lecture is on pediatric regional anesthesia, followed by case presentations. So for the first lecture, I would like to invite Dr. Ramkumar, sir. It's such an honor to have you, sir. I've been very fortunate to have been trained under sir. I've learned the ABCs of anesthesia under his guidance during my PG days. I welcome you, sir. Sir is a former professor and head of anesthesiology at Kasturba Medical College, Manipal. His area of interest are airway management, neuroanesthesia, respiratory care, and medical simulation. Sir is also a trustee of SMILE operation. I welcome you, sir. Please proceed with the session, sir. Over to you.
Thank you, Anupama. So we are already running a bit late. So I would first start with my thanks to the team of APEC 2021 for having me as part of this wonderful program. We are on day 5, midway, halfway through the program. So it's now we're over the peak. So I can see Anupama already smiling that half the program is over. So we have a first lecture, as Anupama said, by Dr. Pradeep Bhatia, who's a professor and head of anesthesia at AIIMS Jodhpur, one of the newer AIIMS in the series, having more than 2,200 beds. And Dr. Pradeep Bhatia's interest is in critical care. However, he'll be speaking to us today on a pediatric topic, a 5-year-old child scheduled for adenoidectomy and tonsillectomy. Over to Dr. Pradeep, please.
Good morning, everyone. So in this session, we'll be discussing anesthetic concerns for adenotonsillectomy. A 5-year-old child was brought to the ENT OPD, and the parents gave the history of snoring and sleep apnea for last 4 years, which got worsened in the past 2 weeks. On examination, he was found to have very high inspiratory efforts with subcostal retraction. The saturation was 98% when awake, but fell down to 82% when he was asleep. He was found to have enlarged tonsils and adenoids, so he was posted for adenotonsillectomy. Tonsils and adenoids, they are lymphoid tissue, and they are part of Walde's ring encircling the pharynx. They appear on second year of life and attain largest size between 4 to 7 years of age and then regresses. Their enlargement can cause nasal obstruction. It can cause recurrent infections of tonsils and adenoids. It can block Eustachian tube and can cause dysfunction, can decrease hearing, secretory otitis media, and also can cause obstructive sleep apnea. Tonsillectomy with or without adenoidectomy is one of the most common surgical procedures in children. And 40 years ago, the majority were performed for infections. But with the advent of good antibiotics, that indication is not there nowadays. And obstructive sleep apnea is now the most common cause of adenotonsillectomy for over more than 75% of cases. So what are the indications of tonsillectomy? Enlarged tonsils with features of upper airway obstruction, dysphagia, sleep disorders due to tonsils, peritonsillar abscess, tonsillar hyperplasia, and in patients with valvular heart disease, there is a risk of endocarditis due to recurrent tonsillitis. So the tonsils should be removed to prevent endocarditis. Adenoidectomy is generally accompanied with tonsillectomy, and the other causes of adenoidectomy are purulent adenitis despite adequate medical therapy and recurrent otitis media with effusion secondary to adenoidal hyperplasia. So what are the goals for anesthetic management? The goals are same as they are with any other surgery, that the induction should be smooth and atraumatic. Airway should be protected during surgery from aspiration of blood and secretions. You should care for postoperative analgesia. You should prevent postoperative nausea, vomiting. Smooth, rapid recovery of airway protective reflexes to decrease the incidences of postoperative respiratory complications. Avoid respiratory obstruction and respiratory depression, particularly in the postoperative period. Airway management in these cases is challenging. Because the airway is shared between anesthesiologist and the surgeon, it must be protected from blood and secretion aspiration to lungs. The incidence of laryngeal spasm is very high. than compared to other surgical procedures. And there is a high risk of respiratory complications in the postoperative period. So during the pre-anesthetic evaluation, one should evaluate the patient for the possibility and the severity of obstructive sleep apnea, which if is for very long duration can cause pulmonary artery hypertension, hypoxia, and even cor pulmonale. Upper respiratory infection is very frequent in children, and recent URI increases the risk of perioperative adverse complications in children. Airway hyperreactivity may persist even after several weeks of the URI. But we can continue with anesthesia and surgery if infection is mild. But in case there is leukocytosis, there is thick mucopurulent secretion, and there are associated lower respiratory tract infection, it's better to postpone the surgery till the patient recovers. Missing tooth must be noted because there can be trauma to teeth while doing laryngoscopy, intubation, and while the surgeon puts the mouth gag. Patient should also look into the history of bleeding disorders. Patient should be investigated for complete hemogram to see if there is anemia or polycythemia, which can occur in chronic hypoxia because of obstructive sleep apnea. Differential leukocyte counts to rule out active chest infections. Coagulation parameters should be monitored. XHS generally is not required unless there are signs of recurrent pneumonia, bronchitis, and cor pulmonale. 2D echo may be required in patients with obstructive sleep apnea. These young patients may be very anxious and particularly because parents are also anxious, and which is associated with behavioral problems. Oral midazolam 0.5 milligram per kg is generally safe and reliable. Other pre-medications which have been tried and are being used in different institutes are intranasal midazolam, fentanyl lollipop, clonidine, dexmedetomidine. But one should carefully titrate anxiolytics and sedatives in patients with obstructive sleep apnea because they are more prone for airway obstruction and when they are sedated. One should always monitor saturation when the patient is sedated and given some sedative as a pre-medication. Tonsillectomy is a short surgical procedure, and the residual effect of any sedative given pre-operative period can prolong the recovery room stay and can cause sedation in the post-operative period. For pre-medication, distraction techniques like toys, videos, tablet computers, virtual reality devices, music stickers, parental presence during induction, these measures can also be tried to avoid any sedatives. Pre-medication should also include glycopyrrolate. Then the role of inhalation of short-acting beta-2 agonist like salbutamol 200 microgram for the patients who are at very high risk of post-operative respiratory complications, for example, children with moderate to severe obstructive sleep apnea or recent upper respiratory infection or history of eczema, asthma, hay fever, or exposure to passive smoking. In these patients, preoperative inhalation of salbutamol will be safe, it is well tolerated, and it is particularly indicated when the V's are present on chest auscultation. Salbutamol reduces the likelihood of perioperative respiratory complications. Not only it is a bronchodilator, it also inhibits the release of inflammatory mediators from mast cells and suppresses cough. The operation room should be properly prepared, and availability of anesthesia and emergency drugs should be ensured. Airway equipment should be there, including appropriate size flexometallic endotracheal tubes and LMAs, conventional endotracheal tubes, south pole endotracheal tube, oral airways, suction. The patient should have a good IV line. Monitoring includes ECG, non-invasive blood pressure monitoring, saturation, end-tidal carbon dioxide, which also detects endotracheal tube obstruction by mouth gag and displacement intraoperatively. The surgery is performed in supine position with the neck extended, and with the extension of neck, there is always a risk of accidental extubation. So ETCO2 becomes much more important monitoring. Induction can be inhalational or intravenous. In very young children, particularly if IV line is not there, inhalational induction can be preferred. But once patient is induced, one should get IV line as early as possible after induction because inhalational anesthetic agents, they reduce the pharyngeal muscle tone and increases the susceptibility of airway collapse. IV induction is preferred in older, hemodynamically stable children. In children with high risk of airway complications during induction, like severe obstructive sleep apnea, uncontrolled asthma, recent upper respiratory infection, and craniofacial abnormalities, in these children, IV induction is preferred. Propofol 2 to 3 milligram per kg with lidocaine provides rapid onset and short duration. It attenuates the airway responses to intubation, and propofol, as you all know, is also an antiemetic. Neuromuscular blocking agents, tonsillectomy is a short procedure, generally lasting less than 30 minutes. So low dose rocuronium or citracurium generally is sufficient in these patients. Succinylcholine generally is not given, but it can be considered, it should be given when rapid sequence induction is done in tonsillar bleeding. FDA has issued black box warning against succinylcholine because there can be an undiagnosed case of muscular dystrophy, which can cause rhabdomyolysis and hyperkalemia and subsequently cardiac arrest. So succinylcholine should not be used routinely. Remifentanil, which is not available in India, with propofol and paralate, provides excellent intubating condition even without relaxant. Oropharyngeal airways may be necessary to ventilate during nasal obstruction. The airway is shared by anesthesiologist and the surgeon, and the airway device, that is the endotracheal tube, which can be either southward tube or a flexometallic tube or a laryngeal mask airway, generally should be placed in the midline and is taped to the lower jaw before the mouth gag is placed. The mouth gag is positioned and opened carefully to avoid kinking or accidental extubation. Curved endotracheal tube is most commonly used. So now the debate of endotracheal tube versus laryngeal mask airway. Can these surgeries be conducted under laryngeal mask airway? Cuffed endotracheal tube has its own advantages, that it provides definitive airway control. It rarely needs to be replaced. It seals the trachea properly, prevents aspiration of blood and secretion. Cuffed tube also prevents the leakage of high concentration of oxygen into the airway, thus reducing the risk of airway fire with electrocautery. It also prevents OT pollution with volatile anesthetic agents. And endotracheal tube provides good access to the surgical site, and effective resection is possible. And you can also use flexible laryngeal mask airway, and the advantages of flexible laryngeal mask airway is it is less stimulating to the airways, and extubation is much smooth as compared to endotracheal tube, with less coughing and distraining. There are less perioperative respiratory complications for children with upper respiratory infections, but disadvantages are also there. Because LMA takes much more space in the mouth and surgical exposure is difficult, and there is less effective resection. It is difficult to be placed if the tonsils are large, and kinking and laryngeal spasm in response to noxious stimuli are also possible if LMA is used. The studies comparing endotracheal tube versus laryngeal mask airways are mostly small retrospective studies in selected patient population. So most of these studies, the findings cannot be extrapolated to the general population. In many cases, there was a need to convert from mask airway to endotracheal intubation in 4 to 17% of cases because of kinking or obstruction of laryngeal mask airway, or inability to place laryngeal mask, or because of inadequate surgical exposure. But this conversion rate to endotracheal tube from LMA was low, less than 1% in non-obese children with normal airway without obstructive sleep apnea. LMA failure is less likely in adenoidectomy without tonsillectomy. So in adenoid surgery, we can use LMA. There are conflicting results with regard to laryngeal spasm, coughing, gagging during surgery, operative time, and operating room time if you use LMA instead of endotracheal tube. So there is no conclusive evidence of the benefit of laryngeal mask airway. The French Association for Ambulatory Surgery and French Society for Anesthesia and Intensive Care, they recommend curved endotracheal tube for tonsillectomy and extubation after complete awakening. So maintenance of anesthesia, sevoflurane is most commonly used because of it is not respiratory irritant, and recovery is quick. For an occasional child which has a significant history of postoperative nausea, vomiting, or risk factors for postoperative nausea, vomiting, propofol-based TIVA can be preferred. Remifentanil, which is not available here in India, but remifentanil and propofol combination provides profound analgesia without prolonged apnea, and propofol has antiemetic effects. And you also avoid inhalational agents, thus reducing the chances of postoperative nausea, vomiting. In India, instead of remifentanil, we can use fentanyl along with propofol for TIVA in patients susceptible for postoperative nausea, vomiting. One should also ensure adequate depth of anesthesia prior to mouth gag placement, because sudden noxious stimulation of opening of the mouth gag can result in movement of the patient, laryngeal spasm, breath holding, or gagging. Intraoperative analgesia should be multimodal, paracetamol commonly used, in addition to dexamethasone with low dose opioid like fentanyl. Opioid doses should be further reduced in children with obstructive sleep apnea. As an antiemetic, dexamethasone is used along with ondansetron. Intraoperative dexamethasone in children undergoing tonsillectomy provides decreased incidences of postoperative nausea, vomiting, decreased time to first oral intake, and decreased postoperative pain. As per few case reports, dexamethasone may be associated with the hemorrhage, but the risk of clinically important hemorrhage with dexamethasone in tonsillectomy is low. But yes, dexamethasone should be avoided in suspected tonsillar malignancy because of the risk of cancer lysis and risk of hyperkalemia. Promethazine as an antiemetic are having problem because of the risk of sedation and risk of respiratory depression. During recovery from anesthesia, there is a high risk of laryngeal spasm and increased airway reactivity. So to prevent it, the blood should be properly suctioned out from the oropharynx before emergence. Stomach should be emptied with orogastric tube. Patient should be extubated and positioned in tonsil position, which is lateral position with neck extended, so that the secretions drain away from the oropharynx. Jaw thrust and oral or nasal airway placement may be required in some cases. Another controversy about awake and deep extubation. Awake extubation provides the return of airway tone and airway protective reflexes. It reduces the risk of post-extubation, airway obstruction, and laryngospasm. And in patients with difficult airway or with obstructive sleep apnea, awake extubation is always better, because you may have to otherwise re-intubate the patient, which could be very difficult if you extubate the patient in deep plane of anesthesia. But yes, deep plane of extubation in deep plane of anesthesia can be preferred in reactive airway asthmatic patient with risk of bronchospasm, and to minimize coughing for surgical reasons that the clot may get dislodged and patient may bleed. Supraglottic airway devices are mostly removed when the child is still deeply anesthetized, but awake removal may be preferred if there are copious secretions and blood, if the patient is of obstructive sleep apnea or there is anatypical airway obstruction. The patient should be transported to the recovery area with supplemental oxygen by face mask or nasal cannula. Lesser palatine and glossopharyngeal nerve block can be given along with general anesthesia. It improves the operative conditions, provide excellent postoperative analgesia. The extubation process is much smoother. Sometimes adrenaline is given in combination with local anesthetic agents, but there are risks of arrhythmias and hypertension, particularly if you are using halothane. The risk of arrhythmia is much less with the newer anesthetic agents and also in children. The maximum doses in adults is 1:1 lakh concentration over 10 minutes, and maximum 3 doses, that is 30 ml of 1:1 lakh concentration during any 1 hour. One should always avoid hypoxia and hypercarbia to decrease the risk of arrhythmias. Postoperative analgesia after tonsillectomy, there is moderate to severe postoperative pain in many children, which can lead to reduced oral intake and dehydration. Children with obstructive sleep apnea, they are very sensitive to sedative and respiratory depressant effect of opioids. So a multimodal approach is preferred. With intraoperative paracetamol and dexamethasone, we can add NSAIDs, which are as effective as opioids without postoperative nausea, vomiting, sedation, and respiratory depression. But then there can be a risk of increased bleeding because of the antiplatelet action of NSAIDs. So COX-2 inhibitors like pericoxib and celecoxib can be used. Intraoperative low-dose ketamine infusion also has opioid-sparing effects, which provides good postoperative analgesia, but can also cause postoperative agitation and secretions. Dexmedetomidine infusion is analgesic and sedative without respiratory depression, and also reduces emergence delirium in children. Local anesthetic agent injected into the tonsillar bed during tonsillectomy for postoperative analgesia can also be used, is often used, but the role is controversial, that how effective it is. Other postoperative complications, most surgeries are done as an outpatient settings. Children at high risk of complications like age below 3 years of age, those with Down syndrome, neuromuscular disorders, airway anomalies, and history of severe obstructive sleep apnea. They may remain admitted overnight to watch for the respiratory complications. Laryngospasm has a very high incidence after tonsillectomy and adenoidectomy in the immediate postoperative period, but it can be self-limiting in many cases, but it can cause in some cases negative pressure pulmonary edema, hypoxia, and cardiac arrest. So to prevent it, topical lignocaine spray or IV 2% lignocaine 3 minutes before extubation can be given. Propofol 0.25 to 0.5 milligram per kg IV can be given. To break the spasm, Larson's maneuver can be used, or in refractory cases, you may require to use succinylcholine 0.5 to 0.8 milligram per kg. Other problems post-operatively can be pain, throat discomfort, post-operative nausea, vomiting, restlessness, emergence delirium, and bleeding. Now coming to post-tonsillectomy hemorrhage. It is infrequent but potentially life-threatening complication of tonsillectomy. Primary hemorrhages, where it occurs within 24 hours after surgery, and secondary hemorrhage commonly occurs within 5 to 12 days after surgery. It is a surgical emergency, has to be taken in OT as early as possible. And it has severe challenges to the anesthesiologist because patient may be severely hypovolemic, which can cause severe hypotension during induction. Patient may be full stomach because of swallowed blood and there is risk of aspiration. The intubation may be difficult because of tissue swelling and blood in the oropharynx, and patient may be anemic as well. So what are the plan of anesthesia? We should quickly look to the past anesthesia record, including detail of airway management, vital signs, and history. You must always call an additional anesthesia personnel because it can be a life-threatening problem. Laryngoscope should be available, a stylet, cuffed endotracheal tube of various sizes. 2 suction apparatus should be available because there is a risk of blockage of suction catheter with the blood clots. The routine monitoring include non-invasive blood pressure, ECG, pulse oximetry, but sometimes invasive blood pressure monitoring may also be required. Good IV access is very important for volume resuscitation with crystalloid colloid and blood prior to induction. Induction should not be done until resuscitation is complete. Pre-oxygenation is done in lateral position with head down tilt to allow drainage of blood away from pharynx. Rapid sequence induction and intubation is done with reduced doses of propofol or with ketamine or with etoposide, immediately followed by succinylcholine and cricoid pressure. The procedure is brief, the surgery is generally brief, not very painful, and one should aim for rapid recovery of airway reflexes, so the long-acting opioid should be avoided. Recovery should be done when patient is fully awake, relaxant's effect is reversed, patient is able to protect the airways prior to extubation. The oropharynx is suctioned, stomach is emptied with the tube, extubation is done in lateral position, patient is transported to the recovery room with supplemental oxygen. Adenoidectomy is most often done along with tonsillectomy, but in some cases, adenoidectomy is alone also done when there is recurrent infection. Patient usually is discharged to home on the same day, except for patients who are having obstructive sleep apnea or those with increased risk of postoperative respiratory complications, like patients with Down syndrome, neuromuscular disorder, syndromes with craniofacial anomalies. Adenoidectomy is a short and less painful procedure, may be performed using a laryngeal mask airway. The paracetamol and NSAIDs are sufficient to provide intraoperative analgesia without the need of long-acting opioids or opioids for postoperative pain. So that was all about the anesthetic concerns with tonsillectomy and adenoidectomy.
Thank you, Professor Bhatia, for that excellent presentation and very concise in the time allotted to you. There are a few questions in the chat box. Dr. Anupama, may I go ahead and ask the questions to Professor Bhatia?
Sure, sir. Please go ahead.
Right. So, Professor Bhatia, the first question was, how can an LMA be used for tonsillectomy?
So I have not recommended LMA, use of LMA in tonsillectomy. What I have quoted is few retrospective studies have been done in which LMA, flexometallic LMA has been used. In some selected patients in which tonsils were not very large size, but that doesn't mean that it can be used in every case. No, it is neither it is recommended nor it could be wise to use. In just select cases, even in those patients, the conversion rate to endotracheal tube was there in some of the patients. It is generally difficult to place, particularly if the tonsils are large size. So it is not a recommendation. It's what I had mentioned is just small series retrospective cases.
Thank you, Dr. Bhatia. And Anupama, am I still audible?
You're audible, sir. Very much audible.
There's some change on my screen here, but just let me know, okay? Thank you, Dr. Bhatia, for clarifying that question. The doubt must have been, I think, the space available for the surgeon. And I would like to add that, depending on your surgeon, the understanding between surgeon and anesthetist, the LMA might become an issue in some cases because surgeon may not want to operate, especially if the tonsils are large. The second question, Professor Bhatia, is can NSAIDs be given for post-op pain in tonsillectomy, keeping in mind the bleeding issue? I think you've already answered it. Can you please clarify it?
Yeah, it is generally used because it is considered as effective as narcotic opioids, and the pain is generally moderate to severe. So it is generally used. But yes, concerns of antiplatelet activity is there, but that doesn't mean it is not being used. It is mostly used.
Right. I'd also like to add on, Professor Bhatia, that when we give NSAIDs for longer than 3 to 5 days, that is when actually the bleeding becomes an issue. But for short-term use, it's not a problem. I hope that question is answered. And then there's a last question for you. What is reactionary hemorrhage vis-a-vis primary or secondary hemorrhage?
Reactionary hemorrhage occurs during the surgery, during or immediately after surgery. Reactionary primary is up to 24 hours, and then secondary from up to 5 to 6 days, which occurs because of dislodgement of clot after 5 to 6 days. So reactionary hemorrhage, to be very specific, it is during the surgery. Because it is a very vascular tissue. It is a very vascular tissue. Though it is rare, it is not very common, but yes, it still can occur.
So thank you, Dr. Bhatia. In fact, to be honest, I wasn't aware of that term myself. Thank you for clarifying that. Okay.
Thank you.
So two more questions are there. So 2 more questions are there.
Yeah, I've lost my chat box for some reason. I may have to read. Can you ask the question, Anupama?
Yes, I'll ask the questions. So please, what in post-tonsillectomy bleed immediately within 30 minutes after extubation? And then when we intubate and maintain the muscle relaxation with non-depolarizing muscle relaxants, does the residual effect of the reversal agent act because it acts by competitive inhibition?
What is the question? Residual effect of relaxation?
The residual effect of the reversal agent would be there because it acts by competitive inhibition.
Okay. Normally, the reversal agent, the duration is not very long. And secondly, at the most, the effect of non-depolarizing muscles could be a bit less, and higher doses may be required. That's it, nothing else. You can very well use non-depolarizing agents after reversal, 30 minutes after. Yes, you can.
Okay, sir. And there is one more question, one of the faculty.
But I would like to add, but if the patient is hemodynamically unstable and the rapid sequence induction is required and cricoid pressure is used, then very often succinylcholine is given in spite of the reversal agent being given 30 minutes prior to the succinylcholine. It is being given. What will happen? Ultimately, if there is a mixed block, the duration will increase at the most. You just may have to ventilate, not more than that.
So
do you want to add something, Dr. Ramkumar?
Yeah, I don't think there's anything more to add, Dr. Anupama, because in a post-tonsillectomy bleeding, the urgency is to secure the airway before aspiration. And as Professor Bhatia has rightly put it, the only issue would be a prolonged action, and we can always ventilate them post-op. So the question is completely answered.
Okay, sir. So there is one more question. One of the faculty members, I think, is asking, please, can you comment on the throat pack?
On
the role of throat pack. Throat pack.
A role regarding discomfort, it can cause a bit of discomfort, but then if the surgeon feels it's necessary, definitely he will put it to prevent bleeding and to compress it. Then we have to always be vigilant regarding any kind of respiratory obstruction with the throat pack. And particularly while removing throat pack, the risk of hemorrhage, if it is there. So we have to be vigilant with this. If the surgeon feels it is important to put the throat pack to compress the bleeding vessel, then we have to be vigilant for obstruction of obstructed breathing.
Yes, sir. Ma'am, do you want to say something, Dr. Amrita, ma'am? Ma'am is our HOD anesthesia.
Thank you so much, Dr. Ramkumar, for chairing the session, and Dr. Pradeep Bhatia for being with us in the program. Thank you so much.
Thank you, ma'am.
Thanks for the invite, ma'am. Thanks for the invite.
And I wish
my pleasure. It's my pleasure.
Dr. Anupama, if I can just add on 2 more very small points.
Yes, sir.
Essential because this is a postgraduate assembly. Postgraduates need to know what's the recovery position following tonsillectomy. Because that is what picks up post-operative bleeding very easily. And also any small collection of blood drains out of the mouth. So they must know about recovery position for post-tonsillectomy. And
I have mentioned it in my presentation.
I'm sorry, sir. I missed that. Sorry. Yeah. Thank you.
I have mentioned the recovery patient should be put in the tonsillar position, lateral position with neck extended, so that the secretion blood drains out.
Perfect. I'm sorry I missed that. Thank you very much for a wonderful presentation. Thank you.
Post-tonsillectomy. Thank you. And it was, I think the PGs must have gained a lot from the your presentation. And thank you so much for being a part of the program, Dr. Bhatia and Dr. Ramkumar. Thank you. And all the best to PG. Yes.
Thank you, ma'am.
It's one of the expected questions in your theory and practical, both. So, thank you.
Yes.
Yes.
So,
it's also bread and butter once you finish your course. Yeah.
Yes, sir. So, can we move on to the next lecture? Thank you, ma'am. So, we have Dr. Poonam Motiani. Sir, can you please introduce ma'am?
Sure. So, Dr. Poonam is an associate professor of anesthesiology at the Super Specialty Pediatric Hospital and PG Teaching Institute at Noida. I've been lucky to visit your institution, Dr. Poonam. It's a wonderful institution. I understand it's got 400 beds with practically 25% reserved for critical care patients. Poonam is a much authored anesthesiologist. She has more than 35 papers in national and international journals. She's written chapters in 8 books. And we look forward, Dr. Poonam, to your book that is in press on core cases in pediatric anesthesia. I'm sure it will be very useful for all postgraduates, especially those intending to follow up specialization in pediatric anesthesia. Dr. Poonam also was responsible for 2 landmark issues at the institution where she worked. She started the Pediatric and Neonatal Anesthesia Fellowship in 2015, and more recently, the IAPA, the Indian Academy of Pediatric Anesthesiologists Fellowship Program in February 2020. Thank you for accepting to talk to us on pediatric regional anesthesia. Over to you, Dr. Poonam.
Respected organizers, respected chairpersons, senior faculty members, and my dear students, a very good morning to all of you. At the outset, I would like to thank the organizers for inviting me to be a part of this academic extravaganza. This morning, I shall be talking about pediatric regional anesthesia. Now, pediatric regional anesthesia is gaining a lot of popularity with its use as a sole anesthetic or in combination with general anesthesia for neonates, infants, and children. The Pediatric Regional Anesthesia Network, the PRAN network, is a collaborative group of institutions and investigators. It was founded in the year 2007 by the Society of Pediatric Anesthesia. At present, it has about 21 participating centers, and it has accrued more than prospective data on more than 1 lakh blocks. Now, what is it? It is a data repository for research and quality improvement. It serves as a framework for organizing future studies. It collects benchmarking data to compare one practice with peers across the world. Basically, it is envisaged as a critical tool for data-driven improvement of regional anesthesia practice in children. Now, what are the advantages of regional anesthesia in children? For the patient, it offers superior analgesia. For the anesthesiologist, since we are able to deliver a lower MAC, there is less risk of deep general anesthesia, there's a smoother emergence, there's earlier return of appetite of patients. Because of this, there is also decreased propensity to cause neurotoxicity. Hemodynamic stability is there. It offers early extubation. Regional anesthesia also obtains the hormonal stress response. There are studies which have shown that it also decreases the intraoperative blood loss and leads to improved GI function. And in certain patients, it can even avoid general anesthesia. For the hospital, what does it include? It includes pain-free children who are easier to nurse, who have a less requirement of post-op ventilation, and because of delivery of a less MAC, can be a rapid discharge of these patients from the recovery room, and overall, they have a decreased length of stay in the hospital. Now, how do children differ from adults? There are various aspects. There is anatomical, physiological, pharmacological, psychological aspects. Now, of these, which are the ones which are important to us when we talk about pediatric regional anesthesia? Coming to anatomical differences, the dura mater ends at S3 to S4 in children as compared to S2 in adults. And the implication for this is that one has to rule out a dural puncture during a caudal block. The spinal cord ends at the level of L3 or L4 as compared to L1 in adults. And the implication for this is that an epidural below the level of L3 is much safer. Further, there is delayed development of spine curvature. The cervical lordosis appears at 3 to 6 months and lumbar lordosis at 8 to 9 months. Therefore, the same orientation of epidural needle can be maintained at all levels for children less than 6 months of age. Further, there is increased fluidity of epidural fat. Because of this, epidural catheters can be threaded long distances and caudal local anesthetic spread well. Vertebrae are cartilaginous. Implication: sharp needles can damage the ossification nuclei. Also, they offer easy ultrasound penetration. Further, the SCM cartilage, the sacrococcygeal membrane, is cartilaginous at birth. Also, the sacral hiatus decreases in size with age. What is the implication? Caudal block becomes technically more difficult in children over the age of 8 years. Myelination is not complete till 12 years of age. Implication for this is that it offers better local anesthetic penetration and decreased concentration of the local anesthetic are required to achieve the same level of block. Facial attachments around the nerve are loose. The implication: the block spreads wide, duration is decreased, larger volumes are required for epidurals and smaller volumes are required for peripheral blocks. Now, physiological differences: there is a reduced resting sympathetic tone and smaller vascular bed in peripheries in children. Because of this, hypotension following a central neuraxis block is rare. Also, volume preloading and vasopressors are not required. Children have a higher cardiac output. Implication: it leads to a shorter duration of the block. Pharmacological differences: there's a larger ECF volume, there's a lower plasma protein content, and there's an immature hepatic metabolism. Because of these, larger initial local anesthetics have to be given. Accumulation occurs on repeat dosing. There's a higher unbound local fraction in the blood, leading to greater peak levels and increased risk of local anesthetic toxicity. Now, what are the psychological differences? Children are more anxious. It's more difficult to elicit cooperation from them. They have a limited understanding of paresthesias. So, implication for this is that other localization techniques are also required, as paresthesias are not recognized and they are not elicitable in children. And further, deep sedation or general anesthesia may be required for giving these blocks. Now, there are various studies which have looked at the safety of regional anesthesia in children. And one such study, the ADARPEV study, which was a prospective one-year study of the French Language Society of Pediatric Anesthesiologists, concluded that there is a safety of regional blocks under deep sedation or general anesthesia in children. Further, they also said that the complications in children who were aged less than 6 months was more than 4 times the complications in children who were older than 6 months. And they also noticed a trend away from central neuraxis block towards the peripheral neural blocks. Now, coming to the contraindications of the regional anesthesia procedure, the absolute contraindications include lack of parental consent, skin infection at the site of needle insertion, coagulopathy, sepsis, meningitis, true local anesthetic allergy, abnormal anatomy. Relative contraindications: progressive neurologic disease. The specific contraindications to a peripheral nerve block are the risk of compartment syndrome. Now, coming to the choice of local anesthetics, the main local anesthetics that we use in our practice are bupivacaine, levobupivacaine, ropivacaine, and lignocaine. We'll not go to the details of these, just touch the basics. Bupivacaine is most cardiotoxic, maximum dose 3 ml per kg. Duration of action is about 2 to 6 hours with or without epinephrine. The levobupivacaine, which is the levoenantiomer of the drug, reduces cardiac and CNS toxicity. Ropivacaine offers the same duration, similar dose, and it also reduces the cardiac and CNS toxicity as seen by bupivacaine, and also further leads to decreased motor block, which is why it is preferred in ambulatory anesthesia. Lignocaine maximum dose is 5 milligram per kg, and it has a very short duration of action. There are certain adjuvants which have been tried with these local anesthetics, which include opioids in the form of preservative-free morphine, hydromorphone, fentanyl. All these improve the quality of analgesia due to spinal and central analgesia offered. But however, they carry the risk of delayed respiratory depression, which is why observation and monitoring for more than 12 hours has to be continued. Other adjuvants such as clonidine, which is an alpha agonist, has been tried. Again, they lengthen the duration. They are not associated with any respiratory depression, pruritus, or urinary effect in the dose of 1 to 2 mics per kg. Side effects like hypotension, bradycardia, and sedation, which are dose dependent, can occur at higher doses. Certain other adjuvants such as ketamine, diazepam, neostigmine, dexamethasone, dexmedetomidine have been tried, but there are still two schools of thought, and there are certain unresolved issues with respect to these adjuvants. The questions are whether these are potentially neurotoxic. There are ethical issues related to the unlicensed routes of administration of these drugs. There are concerns about the long-term safety of these drugs, the effects of developmental age on the potential for neurotoxicity, and also one of the unresolved issue is the role of preservatives as a cause for neurotoxicity with these adjuvants. There's a current ongoing debate whether adjuvants really add to the clinical benefit, or do they merely complicate the procedures and introduce a risk for medication error. Now, techniques for localizing neural structures. Our aim here is to correctly position the needle tip in the perineural sheath prior to injection of the local anesthetic. This can be elicited by the facial pops, by the elicitation of paresthesia, which is relatively difficult in children, by the perivascular or the transarterial injection, by electrical nerve stimulation, or by the use of direct imaging with the help of computerized tomography or ultrasonography. Now, ultrasound is a relatively new technique, and however, it is very well recognized, and now one has started recognizing the benefits of using the ultrasound techniques for aiding regional anesthesia. It offers direct visualization of nerves in the vascular structure, so there is less risk of intraneural or intravascular injection. You can visualize the needle real time. It's beneficial in patients with distorted anatomy. Smaller doses of local anesthetics can be used, so there is less risk of toxicity. Further, they also improve the quality, the time, and the success rate of the block. Now, coming to the basics of ultrasound, it's very important to have the appropriate transducer. Now, for children, we tend to use a linear transducer, a high frequency transducer, which is 6 to 8 millihertz for superficial structures. And for smaller children, a hockey stick shaped linear transducer is usually used. Depth, you start by using the maximum depth to identify the anatomical structures. Gain controls the brightness of the image on the ultrasound screen, and it is used to obtain a darker or a lighter screen. Now, depending on the relation of the needle with the transducer, there are certain terminologies which are identified. One is the in-plane needle. When the needle lies parallel to the plane of the transducer, then it is known as an in-plane needle. And what you see is usually the long axis. And with an out-of-plane needle, where the needle lies perpendicular to the long axis of the transducer, there you see the short axis view, which is the view of the transducer in relation to the tissues. So depending on the reflection of the ultrasound waves on the tissues, either the tissues may be anechoic, that is, there is no reflection, black images would be seen, as is seen with fluids and blood. Or the tissues may appear to be hypoechogenic. That means they have a weak reflection, that is seen in solid organs. Then, or else the structures can be appearing to be hypoechogenic, wherein they have a strong reflection and brighter images are seen as seen with bone. Now, what is the equipment that we need to get ready? The equipment includes the tray. The tray contains the local anesthetic solution drawn up in a syringe. You have a short bevel needle. It can be a cannula, it can be a short bevel needle. There we can have catheters as required. Then you have the ultrasound linear probe, which is a small linear probe with a small footprint of about 40 millimeters and a sterile probe cover and gel. Now, prior to excuse me, prior to giving the block, make sure that you have the informed consent in hand. Ensure that there are no contraindications to the block. Full resuscitation facilities and the intralipid 20% should be immediately available. One must have an established IV access and attach the appropriate ASA monitoring. Confirm the correct side of the block and ensure that their appropriate aseptic precautions are taken. Now, coming to individual blocks. Now, the caudal epidural block is the most commonly used block for children. Indications of this block are intraoperative and postoperative analgesia for surgery below the umbilicus. They may include all urological procedures, lower abdominal surgeries, orthopedic procedures. It can also be used as a sole anesthetic technique in certain group of patients. For example, in ex-premature infants who are at risk of postoperative apnea, for a surgery like inguinal hernia repair, it can be used as a sole anesthetic technique. Now, there are certain considerations with this block. In patients who have sacral malformations, for example, a meningomyelocene and open spina bifida, this block would be contraindicated. In certain other patients where we have sacral deformities in the form of cutaneous anomalies, as in you have a tuft of hair or a nevus, or you have a sacral dimple at the site, these patients may have an underlying spina bifida or a T3 cord. So they may require further radiological examination. Then other conditions where the patient has progressive neurologic abnormalities, again, these blocks are to be viewed with caution, as postoperative progression of neuropathy can occur because local anesthetics are also neurotoxic drugs. And if at all new deficits arise, then imaging has to be done postoperatively to rule out any complications. Now, coming to the anatomy of the caudal block, there is an equilateral triangle formed at the back of a patient, which is formed by the two posterior superior iliac spines and the sacral hiatus. And what is the sacral hiatus? Sacral hiatus is the failure of the posterior arches of S4 and S5 to fuse. And this sacral hiatus is bounded by the sacral conove. It forms an inverted V and it is covered by the sacrococcygeal membrane. With age, the sacrum fuses, there is posterior fusion of sacral nibs completed, and the sacrococcygeal membrane ossifies at the age of more than 8 years. This canal contains areolar connective tissue, fat, sacral nerves, lymphatics, phylum terminale, and a rich venous plexus. Now, how is the block done? After attaching the appropriate monitors, the patient is positioned either lateral or prone. And after strict asepsis, the appropriate size needle, which can be a hypodermic needle, it can be a caudal stiletted needle, it can be a 23 gauge butterfly needle, or a 22 gauge IV needle for older cannula can be used. The skin is punctured 45 to 60 degrees at the apex of the sacral hiatus, and the needle is advanced slowly till we have a distinct pop or a give as the sacrococcygeal membrane is pierced. Further, the needle is advanced about 1 to 3 millimeters in a plane which is parallel to the spinal axis. And after you have aspirated to have a negative dural puncture, the local anesthetics is injected in aliquots. Now, the methods to confirm localization of caudal space include give or pop of the needle, free flow of local anesthetic solution. There should be no subcutaneous swelling after the injection. The swoosh and the whoosh test have been tried by various authors. Electrostimulation has been tried by various other authors using a stimulating current of 1 to 10 milliamperes and looking for anal sphincter activity. And ultrasound with the high frequency linear probe has also been tried. Now, with the use of ultrasound, what are the images that one gets? On a transverse view, this is the image that is seen. In this image, one can identify the sacral conway bilaterally. We can identify the sacrococcygeal ligament and the posterior surface of the sacrum. And here, since this is an out of plane view, the needle puncture is seen as a small dot. And here, and this view is likened to the face of a frog, which is why this is also known to elicit the frog sign. Now, on a longitudinal view, the same thing. When we view it, we see the posterior surface of the sacrum here. We see the sacral conway, and we see the sacrococcygeal ligament. And since this is in the shape of a beak of a bird, this is also known to be the bird beak sign. And here we can see that the needle, this is an in-plane technique. So the whole length of the needle can be seen in the longitudinal view. And the drug is deposited into the sacral canal. Now, what is the volume of local anesthetic that one must inject? For a sacral block, it's about 0.5 ml per kg. For a thoracolumbar block, the dose is 1 ml per kg. For a mid-thoracic block, the dose is about 1.25 ml per kg. Now, coming to the complications, in addition to the usual complications, which can include venous puncture, intraosseous injection, local anesthetic toxicity, a dural tap, neural injury, epidural abscess, there are certain other complications which are specific. You can have a total spinal block. If you puncture the dura and you deposit the drug intrathecally, then you can have a total spinal block in these patients. Postoperatively, some of these patients might have a motor block. Therefore, for ambulatory surgeries, it is preferred to use ropivacaine. Children may also present with urinary retention and rectal penetration postoperatively, and also epidural hematoma has been seen. So coming to the next important block, that is the lumbar epidural block. Now, lumbar epidural block, what are the major indications? Major indications include major abdominal, thoracic, spinal surgeries. It is also used for long-term pain management in children. Anatomical considerations we have already discussed. Epidural, it is safer to give below the level of L3. Same orientation of needle for all levels in children less than 6 months. Caudal epidural catheters can be threaded long distances, and a midline approach is safer as the ligamentum flavum is the widest there and there is lower risk of vessel puncture. Equipment, various sizes of Tuohy needles are available. 18 gauge, 19 gauge, 20 gauge. The 19 and the 20 gauge needle also comes in smaller lengths. So this is a pediatric epidural set where this needle is about 7.8 centimeters and the metallic portion of the needle is about 5 centimeters and it is marked every 5 millimeter. The technique for the block is similar to that for adults. Both the loss of resistance to air as well as loss of resistance to normal saline technique have been used. However, the Society for Pediatric Anesthesia recommends the use of loss of resistance to air technique, as this is supposed to be much safer for children. The depth of the skin to epidural space, these are the calculations. A test dose must be injected because most of these patients will be either deeply sedated or under anesthesia. With the injection of the test dose, one must look for a rise in heart rate more than 10 beats per minute and the ST wave changes. And once we are convinced that the drug is not intrathecal or the dura is not punctured, the volume of the drug is injected as per this calculation. Coming to the next important neuraxial block, spinal anesthesia. Now, there are various indications for spinal anesthesia, and these are certain indications that have been given by these authors, and they include surgery on lower part of the body, It can be used as a sole technique in certain certain group of patients, such as high-risk preterm neonates undergoing inguinal hernia, children with recent URTI, children with a difficult airway, children with full stomach, and those with associated comorbidities. Now, spinal anesthesia, the technique is technically similar to adults. It is not very commonly practiced in neonates. What we use is a 1.5 gauge, 25 to 26 gauge needle, and this is injected in a space lower than L3. Dose is 0.3 to 0.6 milligram per kg body weight. 0.5% bupivacaine heavy is given. And one must note that the higher the age, the lower is the dose. Complications, as in adults, PDPH, backache, and transient neurological symptoms. Various adjuvants have been tried in spine as adjuvants to local anesthetics in spinal anesthesia. Now coming to peripheral nerve blocks. Now peripheral nerve blocks are important tools in multimodal analgesia for surgery on the extremities or on the abdomen for children. They may reduce the deep GA exposure. They reduce the perioperative pain and morbidity. And also, in limited resource settings, it is a safe way to improve the pain control in wards. Now we'll deal with a few commonly done blocks. The abdominal wall blocks. We'll talk about the transversus abdominis plane block or the TAB block. Now, what are the indications for this block? It is used in lower abdominal surgeries. It is used as an alternative in patients with spinal anomalies, preventing the use of central neuraxis blocks. This block blocks the segmental nerve T9 to L1 between the transverse abdominis and the internal oblique muscles. The landmark when it is given is the lumbar canal of Petit, and the technique is, once the needle is injected in this triangle, 2 pops are elicited. The first pop is with the puncture of the external oblique muscle, and the second pop is with the puncture of the internal oblique muscle. The dose of the drug given is 0.3 to 0.5 ml per kg per side of 0.25% bupivacaine. Duration of the block is variable, may last 8 to 12 hours. Complications include peritoneal injury, bowel injury, and vessel puncture. Now, when this block is done with the use of the ultrasound, this is a child in which the probe is placed transversely. It is placed midway in the mid-axillary line. It is placed midway between the iliac crest and the costal margin. And with the transverse orientation of the probe, this is the view that we get. We see the subcutaneous layer, then we see the external oblique muscle, the internal oblique muscle, and the transverse abdominal muscle. So after elicitation of 2 pops, one is with external oblique muscle and the internal oblique muscle, the drug is deposited right here in between the internal oblique and the transverse abdominis muscle. And this is the in-plane technique, and this arrow indicates the trajectory of the needle. Now coming to another important abdominal block, the rectus sheath block. The indications for this block are umbilical, epigastric hernia surgery, pyloromyotomy, and other midline incisions. And this block blocks the terminal branches of T9, T10, and 11 intercostal nerves. The dose is 0.1 ml per kg per side of 0.25% bupivacaine. The landmark is the plane between the rectus abdominis muscle and the posterior rectus sheath. So once you have placed the probe transversely right next to the umbilicus, this is the view that we get, and the drug is deposited in between the rectus abdominis muscle and between the posterior rectus sheath. And this is again an in-plane technique, and the needle, the whole length of the needle can be seen, and the needle preferred is a short bevel. In-plane needle is preferred. The complications again include peritoneal entry and a bowel injury. we'll be dealing with a few lower extremity blocks. The first block that we'll be talking about is the femoral nerve block. Now, femoral nerve block blocks the femoral nerve, and it is indicated for surgery on the anterolateral thigh, the hip, the knee, and the ankle joints. Now, distribution is L2 to L4 roots. And what is now the technique of the block? Now, at the level of the transverse, the inguinal ligament, the femoral nerve lies right lateral to the femoral artery. And here it lies deep to the fascia lata and the fascia iliaca. So using a 22 gauge blunt needle, 2 pops are elicited, one with the puncture of the fascia lata and the second is with the puncture of the fascia iliaca, and the drug is deposited right here. And the dose is about 0.4 to 0.5 ml per kg, and the duration of block is about 8 to 12 hours. Complications include intravascular injection or a nerve injury. The same is seen using an ultrasound, and we can see that the needle is being inserted in lateral to the linear probe using the in-plane technique, and a catheter is being threaded in. So at the level of the femoral crease, the view that we get on longitudinal axis is, this is the femoral artery. The femoral nerve lies lateral to the artery, and it lies just below the fascia iliaca and above the iliopsoas muscle. And here the drug is deposited just below the fascia iliaca. And from lateral to medial, at the level of femoral crease, the mnemonic to remember is navel, femoral nerve, artery, vein, empty space, and lymphatics. Now coming to another important block, or the fascia iliaca block, or also known as the 3-in-1 block. This is a block of the lower limb in which we block the femoral nerve, the lateral femoral cutaneous nerve, and the obturator nerve. And this block is indicated in hip surgeries. Now, how to do this block? So this is a schematic diagram of the same, and we see that the femoral nerve here is lateral to the femoral artery, and it is below the fascia lata and the fascia iliaca, and this is the location of the lateral femoral cutaneous nerve. So at the inguinal ligament, if it is divided into 3 halves, so at the junction of the lateral second and third half, 1 to 1.5 centimeter below this, if you insert a needle, and you will generate 2 pops. One is with the puncture of the fascia lata, and another is with the puncture of the fascia iliaca. And after you have punctured, you will deposit the drug in the dose of 0.7 ml per kg, 0.25% bupivacaine, and exert pressure caudally, so that the drug that is injected is spreads laterally, medially, and caudally. And the complications of this technique include intravascular injection and hematoma. This is the same when seen on ultrasound in the longitudinal view. Again, we see that the needle, this is an in-plane needle, and the drug is deposited right below the fascia iliaca, and the drug spreads laterally and medially. Now coming to another important block of the lower limb, the popliteal sciatic block. This is a block which is indicated for foot and ankle surgeries. The dose of the block is 0.3 to 0.5 ml per kg. Distribution is from roots of L4 to S3. It is used to block lower extremity below the level of the knee, except for the medial leg and foot. Complications include intravascular injection and nerve injury. Duration of action is 8 to 12 hours. Now, at the level of the popliteal fossa, the relation of the popliteal vein lies just superficial to the popliteal artery, and further superficial lies the tibial nerve and the common peroneal nerve, which are the branches of the sciatic nerve at this level. And on a longitudinal view again, we see that this needle, this is the trajectory of the needle. needle is inserted and the drug is deposited between the common peroneal nerve and the tibial nerve, but more superficial to it. And this shows the trajectory of the proposed trajectory of the needle. Now coming to certain upper extremity blocks, the most common upper extremity block that is used with ultrasound guidance is the supraclavicular block. Now, supraclavicular block is also known as spinal of the arm. It is indicated for all intraoperative and postoperative procedures, analgesia for procedures on the upper extremity not involving the shoulder. How is the patient to be positioned? The patient is to be positioned supine with the arm by the side, the head turned towards the contralateral side, excuse me, and consider elevating the head by 30 degrees, and in very small patients, elevate the shoulders. The dose to be given, the dose of the drug is 0.2 to 0.4 ml per kg. So, just to look at the anatomy, at the level of the first rib, the structures from lateral to medial are the middle scalene muscle, the brachial plexus, the brachial plexus, the subclavian artery, the anterior scalene muscle, and the subclavian vein. So this is the relationship at the level of the first rib. So here we note that the brachial plexus lies just lateral, it lies just supralateral to the artery. Now on ultrasound, this is the view that is seen. One must identify the subclavian artery, the first rib, the pleura, and the brachial plexus, which lies just supralateral to the artery. And this is likened to a bunch of grape or a cluster of bubbles. Now, how is the procedure done? So the patient is positioned here. It is the right side that we are approaching. So using the left hand, the non-dominant hand, the ultrasound probe is held, and it's placed in the just above the clavicle, and using an in-plane needle, we direct the needle just from the lateral end of the transducer, and this is the view that we see. We have the subclavian artery, and just supralateral to it we have the brachial plexus, and this is the needle, this hyperechoic needle that we see, and on this view we can clearly see the first rib and the lung. So this needle is inserted and a pop is felt as the needle passes through the brachial plexus sheath, and the local anesthetic should be injected. Thereafter a negative aspiration, and it should spread around the hyperechoic circles, causing hydrodissection of the planes. Now, in addition to the usual contraindications, the general contraindication, there are specific contraindications that have been proposed by the American Society of Regional Anesthesia. They say that since this is a non-compressible or a deep block, one must consider a superficial block for patients on anticoagulants. Additional caution is to be exerted in patients with severe pulmonary disease. It should never be given bilaterally. Potential complications include pneumothorax, a phrenic nerve block, Horner syndrome, unintended vascular punctures, and neurological injuries. Now coming to certain other blocks, one is the paravertebral block. A paravertebral block blocks the intercostal nerve, its dorsal rami, and the sympathetic chain. Now, it is indicated for perioperative analgesia for chest wall, thorax, and abdomen surgeries, and also for chronic pain management in non-surgical patients. Now, what is the relevant anatomy? Now, there is this wedge-shaped area which is alongside the vertebral column, which is bounded anteriorly by the parietal pleura and posteriorly by the costotransverse ligament. So the drug has to be deposited in this wedge-shaped area. Now, how is the patient positioned? The patient is positioned lateral. The most prominent, the spinous process is identified, and the probe, the ultrasound probe is placed right lateral to it. So once the ultrasound probe is placed, and this is the view that we see. And after you insert the needle using the in-plane technique along the lateral border margin of the linear probe, and once you contact the transverse process, you walk off slightly towards the cephalad margin and you inject the drug. And the dose is about 0.5 ml per kg of bupivacaine, and the complications include vascular puncture, pneumothorax, and a block failure. And here on the ultrasound image, you can see the drug being deposited right below the internal intercostal muscle and above the pleura. The erector spiny plane block, it's a facial block. It targets the spinal nerve. Indications are similar as for paravertebral block, rib fracture, thoracic and high abdominal surgeries. It has a good safety profile as is a significant distance from the block site to the spinal cord or to major vessels. Dose is similar, 0.5 ml per kg per side of 0.25% bupivacaine. Distribution, it blocks the ventral and the dorsal rami of spinal nerves by diffusion. Complications include pneumothorax. Duration is about 8 to 12 hours. When you use the ultrasound, we can see that the probe is placed right next to the most prominent spinal process. And just here we can identify the transverse processes and the erector spiny muscle. And this arrow shows the trajectory of the needle, and the drug is deposited right above the drug is deposited just at the facial plane, which is deep to the muscle, just above the transverse process. And one must make sure that the drug spreads laterally and medially along this plane, and there it causes hydrodissection. If it does not cause hydrodissection and it gets into the muscle, the body of the muscle, then the needle has to be repositioned so as to observe this hydrodissection as seen here. This is just a table summarizing the various blocks that we've discussed. And so to conclude, I would say that regional anesthesia in pediatrics can be an important tool in multimodal analgesia, allowing reduced exposure to general anesthetics, opioid sparing, and improved pain control postoperatively. And a thorough understanding of the anatomy of each block and the use of adjuncts may lower the risk of complications. Thank you for patient hearing, and greetings from my institute. Thank you.
Thank you, Dr. Poonam. That was a very concise presentation. There is so much to talk about in pediatric regional anesthesia, and you've done a wonderful summary of everything. Thank you so much for giving us such a lot of information in a nutshell. Anupama, there are 3 questions on chat. Can we quickly take them? There is a
yes,
we are just on time for the session. The first question, Dr. Poonam, talks about is it safe to use clonidine in caudal anesthesia for the neonate?
So it's not recommended for the neonate as yet, sir, but there are, it's the only local anesthetic. It's the only adjuvant which has been recommended as of yet. The other ones are still under, there are a lot of schools of thought which talk about ethical concerns because they have not been licensed for use. So clonidine is one of the drugs which has been licensed, but however, not yet for neonates.
And what would it be? Would you do any dose adjustment or the same dose as you would use for older children?
Older children, we go from 1 to 2 mics. We might like to go down on the dose, but we have never done it with neonates, sir.
Okay, so yeah, so unless you really push for it, you wouldn't use it, right? Okay. The second question is on they want a clarification between the Armitage and the modified Armitage rule or formula for calculating doses for caudal anesthesia. They want to know that basically they want to know what is the modified Armitage dosing.
Yes, sir. So according to the Armitage, the original one, it was 0.51 and 1.25 for sacral, thoracolumbar and mid-thoracic. The modified Armitage has, so I'll have to get back on this. It has, initially it was ml per kg. Now they have modified it to also include it according to the dermatome. So I'll have to get back on this. The modified Armitage, what we follow is 0.51 and 1.25.
Okay.
So what
Right.
would your views be on this, sir?
No, the thing is, the only modification we sometimes do, depending on the build of the child, is when we want a higher block, we don't use 1.25, we just go for 1 itself. So we might just lower the dose. Again, we know that the spread can be high, and that's the only modification. But specifically this question, I also don't have an answer. Maybe you can get back. The person who has asked the question, hopefully will be available later also. So once
Yes,
you get
sir.
the answer, you can post it on the chat.
I'll find out, sir, and I'll get back.
Thank you. And the last question is, again, it's a question about preterm babies. And when a preterm baby has an inguinal hernia, the question is, why do we need to take a risk and take up this child for surgery? Why don't we wait for the child to grow up?
No, if it's a hernia which is at the risk of obstruction or strangulation, then we would have to go ahead with the surgery. Because even in our PSC clinic, we try and counsel not only the parents and the child, but we also try and counsel the surgeons. We literally discuss the pros and cons with them as to whether we should be taking up preterm patients for surgery, and can they not wait till they are a bit older. But if it's a hernia which is at risk of strangulation, obstruction, then naturally we will have to take that risk and go ahead and get the surgery done.
I think you're lucky, Dr. Poonam, to be working in a specialty hospital where the pediatric surgeon understands the issues. But I think the question has come from somebody who practices pediatric anesthesia occasionally, and maybe the surgeon is, compelling them to take up the case. So you can quote Dr. Poonam on this and say that we should probably wait longer if we can. But if it's going to be a problem of getting obstructed, well, go ahead. That's the gist. Thank you. And I think we are no more questions on the chat. I actually had one question myself, which was any special recommendations for preemies as far as the ex-preemies rather, because that's a group that we generally consider more use of regional blocks because we are worried about respiratory complications in the post-op period. So do you have any dose adjustment for ex-preemies until they are 44 weeks post-gestational?
So we go slightly lower on the doses.
Okay.
Because it is said that you modify the doses, make it 50% of the dose, because they have immature blood-brain barrier, they have immature hepatic metabolism, and then because the spaces are going to be wider, there's going to be more local anesthetic absorption, myelination is poorer. So 50%.
50% reduction is
yes.
Would be good. Okay. And do you combine local anesthetics? Two different local anesthetics?
We don't.
Thank you. I think it used to be commonly done when I was doing my residency, but I think over the years it has come down, and now I think we use only single. But safer anesthetics.
That or with adjuvants.
Yeah, we have ropivacaine and all these newer drugs available. They don't really need to combine drugs. Thank you so much, Anupama. Thank you, Poonam. And if Dr. Bhatia is still there, thank you very much for a wonderful session. And
thank you. Thank you, sir. Thank you, sir. Thank you, Dr. Poonam. Thank you, Dr. Ramkumar, sir. It was lovely having you. So moving on to our next session. Thank you, ma'am. So moving on to our next session, it's the most awaited session of the day, is the live case presentation, which has been very popular over the last few days. So today we have a case on a 3-month-old child with hydrocephalus and meningomyelocele. The case, the internal moderator for the internal examiner for the case is Dr. Sushmita Das. She is an assistant professor in our hospital, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RMS Hospital. Her area of interest is pediatric anesthesia. And can we have the next slide? The case, the external examiner for the case is Dr. P.S. Bhatia, a well-known face. He's a professor and consultant in Safdarjung VMMC and Safdarjung Hospital under IP University. His area of interest is trauma. Over to you, sir. And the case was presented by third-year resident of our college. She is Dr. Rajita. So this will be a live interaction between the PG and the external examiner, as happens in a practical case viva. Over to you, sir, and Dr. Rajita.
Thank you very much for the introduction. I'm Dr. Bhatia here, and greetings from VMMC and Safdarjung Hospital. So I'll be discussing the case with Dr. Rajita, a third-year postgraduate student at RML, and I'll be helped by Dr. Shashmita for this. So, hello, Dr. Rajita. Good morning. Okay. So can you go ahead with your case presentation, please?
Rajita, please unmute yourself.
Rajita, please unmute yourself.
Yes, ma'am. Good afternoon, everyone. I'm presenting a case of 3-month-old female child who is a resident of Bihar, has been brought to the pediatric emergency department by her parents with the chief complaints of increased head size since birth, vomiting on and off after feeding since 2 days. History of present illness. As per the informant mother, the child was born with a big-sized head, which is progressively increasing in size since birth, associated with history of irritability, history of vomiting on and off after feeding since 2 days, which was non-bilious and projectile in nature. History of lethargy present and history of poor feeding is also seen. The child has also 4 episodes of abnormal movements of the body associated with a rolling of eyeball and frothing from the mouth at the age of 2 months, and last episodes was 2 days before admission. There was no history of fever or rashes over body, no history of bluish discoloration of skin, no history of nasal flaring, no history of any recurrent respiratory tract infection or urinary tract infection, no history of regurgitation of feces, no history of persistent crying, no history of mouth breathing or snoring, no history of sweating during suckling, no history of stridor or apnea, and there was no history of decreased urine output, no history of any cyanotic spells in the child, no history of swelling in spine. Moving on to antenatal history.
Okay, Rajita, hold on. Rajita, hold on.
Yes,
You have ruled out a lot of things by saying no history. Now you specifically mention no history of mouth breathing.
Yes,
I'd like to know from you, children are normally breathing from mouth or from nose? What is the...
So normally children are obligatory nasal breathers, sir.
What's the reason for that? Why are they obligatory nasal breathers?
So there are various reasons. One is that the oropharyngeal muscles are not well developed in children, and also because of the large tongue and because of the cephalad position of epiglottis, which comes in contact with soft palate during respiration.
Okay. So they are obligate nasal breathers. Okay.
Yes,
now you
sir.
also mentioned history of no cyanotic spells. I would like to
Yes,
know some congenital heart diseases in which you have cyanotic spells.
So cyanotic spells are seen in right to left shunt lesions, like tetralogy of Fallot, tricuspid atresia, total anomalous pulmonary venous circulation, sir.
Okay, so you have to rule out with the history of cyanotic spells and congenital heart, various congenital heart diseases. Okay, go on.
Antenatal history. She was a 36-year-old unbooked primigravida married to a cousin. First trimester, conceived spontaneously, confirmed by a urine pregnancy test. There was no history of iron and folic acid intake, no history of fever with rash, no history of bleeding or spotting per vagina, no history of burning sensation while passing urine, no history of drug abuse or radiation exposure during pregnancy, and there was no history of morning sickness. Second trimester, fetal movements were first perceived at 16 weeks. No ultrasound scan was done during her pregnancy period. No history of swelling of limbs, breathing difficulty or palpitations. No history of tetanus toxoid injection. Third trimester, there was progressive increase in the size of the abdomen. Increased frequency of micturition was noted. Perception of fetal movements was seen. And there was no history of swelling of any abdominal pain, blurring of vision or headache. No history of shortness of breath or palpitation. Birth history. A 2.6 kg female child.
Rajita,
Yes, sir.
Rajita, hold on. You mentioned in third trimester, you mentioned no history of abdominal pain, blurring of vision, headache. What are you trying to rule out with this history?
Sir, any preeclampsia during her pregnancy times.
So you're ruling out the preeclampsia. Okay, fine.
Yes, sir. Yes, sir. Birth history. A 2.6 kg female child was born in emergency by cesarean section at 37 completed weeks under regional anesthesia due to non-progressive labor.
The weight
The
of
child
is 2.6. What is the normal birth weight in a child in Indian circumstances?
Sir, in Indian population, it is around 2.8 kg, sir.
Okay, so it is almost a normal birth weight of this child. Okay, he's 3 months old. Go on.
Yes. Child cried immediately after birth. There was no history of NICU admission, no history of bluish discoloration of extremities or oxygen requirement. There was no history of stridor at birth or apnea. Neonatal history of poor feeding was seen, history of lethargy present, child passed urine and stools, no history of yellowish discoloration of eyes or skin. There was no history of regurgitation of feeds, limb abnormalities or malformation. Immunization history. The child has been immunized according to age. Past history. No previous history suggestive of any tuberculosis, pneumonia or diarrhea. No history of any previous hospital admission or previous history of surgery. Family history was non-significant. Developmental history. There were delayed milestones according to age.
Hold on, Rajita, hold
Yes,
on.
sir.
You mentioned, suppose a child has a history of regurgitation and some bluishness after the feed. What will you suspect in that case?
So mostly this will be seen as syndromic anomalies, sir. So certain syndromes are associated like Vactal anomalies, sir. So any tracheoesophageal fistula can also be associated with this hydrocephalus, sir.
Okay, go ahead.
Developmental history, delayed milestones according to age, like neck holding, cooing, social smile, and visual fixation were absent. Socioeconomic history belonged to a lower socioeconomic status according to modified Kupasamy scale. General examination. After getting consent from parents, examination was done with the child by the side of the mother. General condition. Child was lethargic with jitteriness present. Shrill cry was seen. Abnormal movements of the eye were present and there was no abnormal posturing. No pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy, any rise in GVP or skin lesions. Vital parameters.
Okay.
Heart rate was 130.
Rajita,
So,
hold on.
yes, sir.
You mentioned no clubbing. Can you mention a few conditions in
Yes.
which clubbing can be present in general?
Sir, in children, it is most commonly associated with congenital heart diseases, sir. And also any respiratory conditions like empyema, bronchogenic carcinoma, any abscess.
Okay. And we can have even in bronchiectasis. Okay, go ahead.
Yes, sir. Yes, sir. Vital parameters. Heart rate was 134 beats per minute, heard with the bell of the stethoscope. Respiratory rate was 31 per minute, regular thoraco-abdominal type. Peripheral pulse was palpable. Temperature was 98 Fahrenheit measured in the axilla. Skin turgor was normal. Saturation was 98% in room air. Capillary refill time was less than 3 seconds. Anthropometry. Head
Okay.
circumference was 52 point. Yes, sir.
Hold on. You mentioned about temperature. Where the temperature was taken in this case?
So in this child, temperature was measured in the axillary region, sir.
Okay, so it was peripheral temperature. Where all do we look for central
Yes.
temperature?
So central sites of monitoring are tympanic membrane, distal 1/3 of esophagus, nasopharynx, and also in pulmonary arteries, sir.
Okay, go ahead.
Anthropometry, head circumference was 52.5 centimeter, length was 51 centimeter, weight was 4.9 kg. Head to toe exam.
What is
Yes,
that?
sir.
Should have been a normal circumference. This is a case of hydrocephalus, as you mentioned earlier. What is the normal circumference at this age of the head?
Sir, at the age of 3 months, it must have been somewhere around 40 to 41 centimeters, sir.
Okay, so you are increased by almost 11 to 12 centimeters, right?
Yes, sir.
Okay, go ahead.
Head to toe examination. With the child on mother's lap, head was enlarged, distal scalp veins were seen, anterior fontanelle was open, rhomboid, bulging and non-pulsatile. Posterior fontanelle was closed, eyes were bulging and eyeball displaced downwards. Interpupillary and intercanthal distance appears normal. Ears were normal in size and shape. Thorax was normal in shape and movements. Abdomen was non-distended, no visible defects. Genitalia appears to be normal. Spine, normal curvature with no visible defects. Peripheral venous axis visible in the dorsum of hands. Airway examination.
Okay. I have 2-3 questions on what you just said. You mentioned that anterior fontanelle are open, right? So normally at what age does the anterior fontanelle close?
So by 16 to 18 months. Sir.
And what about the posterior fontanelle?
Normal closure is by 2 months.
Okay. So in this case, you mentioned that anterior fontanelle is, you mentioned it's bulging and open, and the posterior fontanelle is closed. Fine, go ahead.
Yes, sir. Yes. Airway examination, large sized head seen, mouth opening and Mallampati class not able to assess. There was no external facial abnormality such as any Mongolian slant, depressed nasal bridge, or low set ears. Local examination of cranium. On inspection, anterior fontanelle was widened. There was impaired upgaze, that is setting sun sign positive, dilatation of scalp veins present, and broad face with frontal bulging seen. On palpation, head circumference was 52.5 centimeter. Anterior fontanelle was soft, bulging, and non-pulsatile of size 4 centimeter. Posterior fontanelle was closed. On percussion, crackpot sound present. On auscultation, there was no bruit. Systemic examination of central nervous system. GCS was E4, B3, and M3. On motor system examination, on inspection, there was no wasting or atrophy, no particular posturing. On palpation, muscles were soft and flabby. Power was 5/5 in bilateral upper limbs and 2/5 in bilateral lower limbs. Reflexes, deep tendon reflexes, biceps and triceps reflex present. Knee jerk was present. Ankle jerk was sluggish, grade 1. Superficial reflexes, plantar was bilaterally upward. Moro reflex, sucking reflex, and rooting reflex were present. Spine, there was no deformity, no midline tenderness. Examination of respiratory system on inspection. Yes, sir. So,
what was the GCS score in this patient?
So it was 10, sir. 10 upon 15, sir.
10 upon 15. Okay.
Yes, sir.
And you okay. And what was the power in the upper limb? You said it was 5/5, and the lower limb was 2/5, right? And the reflexes in the upper limb are normal, but in the lower limb they were sluggish, right?
Yes, sir.
Okay, go ahead.
Examination of respiratory system. On inspection, trachea appears to be in midline. There was no chest deformity. Chest movements appear bilaterally symmetrical, and there was no accessory muscle use of sternal retraction, no audible wheeze or stridor, no visible swelling, scar, or pulsation. On palpation, inspectory findings are confirmed. No tactile fremitus. Chest circumference was 41 centimeter, measured at the level of nipple in mid-inspiration. On percussion, it was resonant on both sides. On auscultation, bilateral air entry present, normal vesicular breath sounds were heard, and there were no added sounds. Cardiovascular system. On
what additional, you said there was no additional sound. What additional sounds you are looking for?
Sir, any adventitious sounds like wheeze or ronchi, sir.
Okay. So in pediatric cases or in other cases, so you want a chest to be clear before you take up for surgery. Okay, that's what you are trying to say. Okay, go on.
Yes, examination of cardiovascular system. On inspection, there was no precordial pulse or visible pulsation, scar, or sinus. On palpation, apex beat is felt in the left fourth intercostal space at the mid-clavicular line. There was no parasternal heave or no palpable thrill. On percussion, cardiac borders are well defined and dull on percussion. On auscultation, heart rate was 139 per minute. First and second heart sound were heard. There was no murmur. On abdomen examination, inspection.
You mentioned in your cardiovascular examination there was no parasternal heave. Suppose we have a parasternal heave. What does it indicate?
Sir, any right ventricular hypertrophy in the child?
Yeah, a parasternal heave will indicate right ventricular hypertrophy. Okay, go on, please.
Examination of abdomen. On inspection, abdomen was non-distended. Umbilicus appears to be central and inverted. Bilateral hernial orifices appear to be free. There were no dilated veins or scar marks. On palpation, Abdomen was soft, warm, and non-tender. There was no organomegaly. Bilateral hernial orifices are free. On percussion, normal tympanic node present. On auscultation, bowel sounds were heard. To summarize, a 3-month-old female child with increased head size, irritability, lethargy, vomiting, and poor feeding, suggestive of raised intracranial pressure and developmental delay with no signs of dehydration, probably a case of congenital hydrocephalus.
Okay, so the way Rajita has summed up, it's a case of 3-month-old with a presented with an enlarged head. So we are dealing with an hydrocephalus. Okay, so now we'll go on to discuss hydrocephalus. Okay, Rajita, what is basically hydrocephalus? What do you understand by it?
So hydrocephalus is the abnormal accumulation of cerebrospinal fluid. So it can be either in the ventricles or within the subarachnoid space. And this mainly happens due to any increase in production, decrease in absorption, or any obstruction to the CSF flow.
Okay, so what you're saying is increased fluid of CSF and problems can be either in production or in circulation or in reabsorption. So can you tell me what is the normal circulation of CSF?
So normally CSF is produced by the choroid plexus of lateral ventricle. From the lateral ventricle to the third ventricle, it flows to the foramen of Monro. And from the third to the fourth ventricle, it goes through aqueduct of Sylvius. From the fourth ventricle, it will take 2 pathways, a median pathway and 2 lateral pathways. Median pathway is through the foramen of Magenty and the lateral pathway is through foramen of Vrishka. From there, the CSF will be picked by the subarachnoid granulations towards the superior sagittal sinus.
Okay, so you have told the normal circulation right from lateral ventricle down to where it is finally reabsorbed. Okay, what's the normal pressure of CSF in a child?
So in infants, it is 4 to 7 millimeter of mercury, sir.
This is in which position?
So in supine position, with respect to supine position.
That's important. Yeah, CSF pressure will change with posture. So in supine position, it is 4 to 7 millimeters of mercury. Okay. What are the common causes of CSF fluid circulation blockade, which can lead to hydrocephalus?
So there can be congenital cause and acquired causes, sir. Congenital cause, the most commonly seen is aqueductal stenosis, sir. That is between the third ventricle and the fourth ventricle, sir. Apart from this, we have also Arnold-Chiari malformation and Dundee-Wacker syndrome, sir. And acquired, so.
Okay, go on. Acquired, go on.
So acquired causes can be due to any infection such as meningitis or encephalitis. It can even be due to tumors like any choroid plexus papilloma, pilocytic astrocytoma, sir. And then another commonly seen is vascular malformations like arteriovenous malformation or any aneurysms.
Okay, what happens in one of the common problems of Arnold-Chiari malformation? What is the problem in that?
Sir, in Arnold-Chiari malformation, there will be downward displacement of the cerebellum and the fourth ventricle, sir.
Okay, and it may also involve brainstem, right?
Yes, sir. Yes, sir.
So the problem happens, it can permeate through the foramen magnum and cause problems of the blockage. Okay. Any other way you can classify hydrocephalus besides what we have told me just now?
Yes, so based on the mechanism of hydrocephalus formation, we can classify them as communicating or absorptive and non-communicative or non-absorptive hydrocephalus.
Okay, so that's another classification. Okay.
Yes.
So what happens when this fluid starts accumulating in your ventricle? What does it finally lead to? What happens basically? Now this child came up with symptoms of irritability, vomiting. So what happens with this accumulation of CSF?
So in infants, normally the fontanelles are open, sir. So it can accommodate up to a certain volume, sir, according to the intracranial pressure volume compliance curve. So there won't be much rise in intracranial pressure in infants. But once the threshold point is crossed, there will be signs and symptoms of intracranial pressure even in a child, sir.
Okay, so finally, it leads to the features of increased ICP. Okay.
Yes, sir.
Okay, so hydrocephalus is normally is an isolated problem, or you can have some associated anomalies with it.
So there are various associated anomalies, sir.
Can you list a few common ones?
Most common anomaly is meningocele or meningomyocele, sir. Apart from that, as I already said before, like aqueductal stenosis, Arnold-Chiari malformation, Dandy-Walker syndrome, all these can be associated
In other words, whenever you are encountering a patient of a hydrocephalus, you have to keep in mind associated anomalies with it, and they have to be looked for and ruled out. Okay. What's a typical clinical presentation? Can you just repeat for the students? What are the typical clinical presentation?
Sir, in infants, the typical signs and symptoms would be like the cranial enlargement will be more than that of the facial growth, sir. Apart from this, child will also present with signs of developmental delays, sir, with poor feeding, irritability, lethargy, vomiting, even seizures, with poor head control as well, sir.
This particular patient of 3 months old, we have all this typical symptomatology, right?
Yes, sir.
Increased head circumference and vomiting and lethargy. Okay. So how do you diagnose this condition?
So diagnosis, again, based on history, physical examination and investigation, sir.
Okay. In clinical examination, you mentioned about the head circumference. Anything else can be done?
Yes, sir. We can also look for setting sun sign in this child, sir. Like it is present in this child.
Examination you mentioned. Okay. Any radiological investigation you will ask about this?
Yes, CT scan can be done. So sorry, sir.
Any radiological investigation you will ask to confirm your diagnosis?
Yes, sir. CT scan can be done, sir, to find the etiology and the site of obstruction, sir.
Right. So CT scan can be done.
Yes, sir.
Confirm our diagnosis. Okay. Now this child comes up with, he has a increased head circumference. He's complaining of vomiting. So can we do anything to manage it medically?
Yes, sir. There is medical management to decrease the production of CSF, sir. Like we can give acetazolamide, sir, like in a dose of 2.25 mg per kg per day can be given to decrease the production.
How does it work?
So it is a carbonic anhydrase inhibitor, sir. So it will decrease the production of cerebrospinal fluid formation, sir.
Okay, so it will decrease the production of, okay. Anything else besides acetazolamide?
We can also give diuretics, sir, like furosemide 1 mg per kg per day, sir.
Okay, where does furosemide act?
Sir, on the distal convoluted tubule and the distal limb of loop of Henle, sir.
So how does it decrease, how does it decrease your CSF?
So
how does it decrease your, how does it help in head?
It will increase the secretion of water and the electrolytes from the body, sir. And it will reduce the bicarbonate ions as well, sir.
Okay, so if you're using a diuretic, what problem you will find this child?
So child can present with signs of dehydration because of water loss, as well as electrolyte imbalance might be seen in the child, sir.
So you might have hyponatremia, you might come up with hypokalemia and loss of fluid. Okay. So is medical treatment good enough or something else has to be done?
So definitive management is always surgery, sir.
Okay. So what surgeries are normally done to relieve this hydrocephalus?
So usually we perform ventriculoperitoneal shunt, sir.
What is the idea of this surgery? What are we trying to do? What are we trying to achieve?
So basically these shunts are mechanical devices, sir. So it will help in diverting the CSF flow from the site of production towards another potential space. Say for example, peritoneum, pleural cavity or atrial cavity, sir.
Okay, so we have a diversion of CSF from the ventricles to one of the absorptive surfaces. It can be either a peritoneum or a pleura or into the atrium. Okay, can you tell me what are the components in a shunt which you put out?
Yes, sir. It is composed of 3 parts, sir. It has a proximal part, a valve, and a distal end of the catheter, sir. Proximal part is where it lies in the ventricle, sir. It has multiple fenestrations, sir, in order to absorb the CSF. And there is also...
Normally in which ventricle? Normally where is it put? In which ventricle? You mentioned lateral, third, fourth. Normally where is it?
Yes, sir. In the frontal horn of lateral ventricles, sir.
Okay. So it is fenestrated, the proximal part is there, right? And the distal part goes in?
It will be in the potential space, sir, like in peritoneum, where we are planning to shunt the CSF, sir.
Okay. So you can put a shunt, as you mentioned, in the lateral ventricles, and distal part is one of the absorptive surfaces. Okay. Now we have decided to take this patient up for surgery, right? So what investigations you will do before this patient is taken up?
So I would like to ask for a complete blood count, including hemoglobin, total leukocyte count, and platelet, along with kidney function test, serum electrolytes, chest X-ray, urine routine, and microscopy, sir.
What is the normal hemoglobin at this age?
So this is a 3-month-old child, sir, so approximately 12 to 14 gram per deciliter.
What is normally a newborn as what is the hemoglobin?
So in a newborn, it will be on higher side, like 16 to 18 gram per deciliter.
And in a 3-month-old, normal, what's the normal hemoglobin?
So 12 to 14 gram per deciliter, sir.
Okay, so it's by 3 months the hemoglobin starts coming down. Okay.
Yes, sir.
Now you told me this child, we have done these basic investigations, and now you want to, any optimization you would like to do, because you told me this child was vomiting, which was non-bilious in nature, and he was lethargic. Any optimization before we take him up for surgery?
Yes, sir. Because of vomiting, child might have dehydration, though it is not present in this child. So if there is any sign of dehydration, I would like to start the child on IV fluids, sir, preferably Ringer lactate solution.
Okay, and what about electrolytes? Any management would be required to correct the electrolytes?
So depending on the electrolyte levels, since I've asked for a serum.
You mentioned to me you have been giving furosemide. So you
Yes,
might
sir.
be having some electrolyte imbalance. You will like to correct it.
Yes,
Why electrolyte imbalance needs to be corrected? For example, say he's having hypokalemia.
sir.
Is it important for us to correct it before surgery?
Yes, sir.
Why? Suppose you are giving child is hypokalemic and you have given him a general anesthesia. Any problems with reversal can occur
Yes,
because
sir.
of hypokalemia.
Sir.
The muscle tone will be less, right? So you have problems with the reversal. Okay.
Yes, sir.
Now okay, how will you pre-medicate this child?
Sir,
The
I
child
would
was a little bit lethargic, you told me, not very active. So what
Yes.
pre-medication you would like to give?
Sir, I would like to avoid pre-medication in this child, sir, as the child is already obtunded, sir, with a decreased
Child is
GCS.
obtended, so we would like to avoid giving any pre-medication. Okay.
Yes, sir. Yes, sir.
Okay. Now you're going to take a 3-month-old child who is not very active to the OT for a surgery, a ventriculoperitoneal shunt, which is likely to take say 45 minutes to 1 hour. So how will you prepare your OT suite before you take up this patient for surgery?
Yes, sir. So I would like to prepare the child as well, sir. Like I'll see if IV access has been secured in prior or not. If the IV access is IV line is already not present, I'll look for sites of visible IV access, and on that particular site, I'll like to apply 5% EMLA cream, so utetic mixture of local anesthetic cream.
What is the composition of EMLA?
So it is composed of 2.5% lignocaine with 2.5% trilocaine, sir.
Okay, so you will imply, when will you put this EMLA cream to be really effective?
Preferably it has to be done at least 45 minutes before the planned surgery, sir, with an occlusive dressing applied.
Okay, because it takes that amount of time before it's
Yes,
really effective. Okay. So my question was, we are still outside the OT. What, any special OT preparations you will do for this 3-month-old child before you bring the child inside?
Yes, sir. I would like to set a OT temperature of at least 80 to 90 Fahrenheit or 26 to 28 degrees
So
Celsius, sir.
your concern is about hypothermia, right?
Yes, sir. Yes, sir.
What all measures you will take
So
so
first
that
thing is,
you don't get hypothermia?
yes, sir. First I'll set the
One you
OT.
told. Okay, anything else?
Yes, sir. And I'll keep a radiant warmer near the OT table, along with a temperature controlled warming mattress spread over the OT table. And I'll also make sure that fluid warmers are available.
Okay, so you told me OT temperature and anything to cover the child.
Yes, I'll also cover the child with cotton sponges, especially the head end.
Okay, so you will take these 4 or 5 measures so that the child doesn't become hypothermic. Okay.
Yes,
now coming to what circuit you utilize
Sir, I would like to
before you
use
give the child to the
Jackson-Ray's modification of Iris TP circuit, sir, pediatric circuit.
Okay, if you go by Mapleson classification, this is good. Which type? A, B, C, D, E. What type of circuit is this?
So it is type F circuit, sir.
Okay. What's the difference between type E and type F?
Sir, type F will have a reservoir bag, sir, at the expiratory limb. This will help in venting of the excess gases.
Bag, it becomes a Mapleson. Okay,
Yes, sir.
fine.
Yes, sir.
Okay. Any preparation about the endotracheal tube?
Yes, sir. I would keep 3, 3.5 and 4 millimeter uncuffed endotracheal tubes, sir, with Miller's blade 0 and 1, sir, with pediatric airway, preferably 000 and 00 and 0 size.
Okay. So why do you want to go for an uncuffed tube? It is good enough?
Yes, sir. It is good enough, sir.
Anything to do with the anatomy of the trachea in child versus adult? In adults, we are putting children, we can manage with an uncuffed tube.
Yes, sir. Because the tracheal cross section, sir, it is circular in infants, sir, whereas it is V-shaped in adults. So even an uncuffed tube will prevent leakage in infants, sir. So we can go with an uncuffed tube itself, sir.
So both are round. Your endotracheal tube is round, your trachea is round. So if you put a correct size, there will be leakage. Okay. What about the cannula? Which size?
So pediatric IV cannula set has to be kept ready, sir. Preferably 24 gauge IV cannula, sir.
Any specific preparations about the IV set to be used?
Yes, sir. I will try to avoid adult IV set. I would go for a burette set, sir.
What is the advantage of a burette set?
So the flow per ml is very less, sir. It is somewhere around 60 microdrops per ml, sir. So we can avoid any fluid overload, and we can also titrate the fluid, sir.
Yeah, so you can give a calculated fluid. Okay. So
And
any
apart-
precautions about any specific precautions?
Yes,
With
sir.
the
I
IV
will
set
also,
preparation?
I
You
will
said
also
you-
try to.
Right.
I will try to avoid any air bubble in the IV set, sir, and I'll make sure that all the drugs,
Yeah, that's very
drugs.
important because
Yes,
you might have a small ASD, VSD, which is missed. So there's a danger of systemic air embolism, right? So you'll have no air in the system. Okay. Now, and extension as well, right? Okay. And any precaution about giving drugs, IV drugs? What are you trying to inject?
Sir, I'll keep the preload syringes ready, sir, with the calculated dosage, sir, preferably 1 ml syringes, sir.
Okay. Okay, now you mentioned to me your OT preparation, right? Now this surgery you have to, will you do some preparation for the positioning of the patient in which, this surgery is done in which position?
The supine position, sir.
Supine?
Supine position with head towards the opposite side.
Head shifted to the opposite side. Okay. Now in this patient, we have a big hydrocephalus. So positioning for intubation is going to be a problem.
Yes,
So any
sir.
instructions about that?
Yes, sir. Since this child is having a big size head, sir, so I would like to use a bolster, sir, in order to compensate for the size of the head, so that the oropharyngeal arrangement.
Where will you put the bolster?
It has to be kept beneath the shoulders till the toes.
Right. So it's right from your shoulders to the toes. And anything to do about the thickness, how thick it should be as compared to the hydrocephalus?
So the size should be in such a way that it should compensate for the size of the head, sir, so that the oropharyngeal laryngeal axis will be in plane.
Right. So they should come at the same symmetrical level so that the head is not hanging down and there is no position problem in intubation.
Yes, sir.
Okay. What about nitrous oxide? You would like to use nitrous oxide, or you would like to avoid nitrous oxide?
Sir, I would like to avoid nitrous oxide, sir, in this case.
So you would like to use oxygen here, right?
Yes, sir. 50% oxygen with 50% air, sir.
What's the problem with nitrous oxide, using nitrous oxide?
So there are various reasons, sir. First of all, the effect of nitrous oxide on cerebral hemodynamics, sir. It can lead to increase in cerebral blood flow, thereby leading to increase in intracranial pressure, sir. The second reason is that it can even cause pneumocephalus since the child is about to undergo a closed space surgery, sir. And it has also an emetic effect. So I wanted to avoid any emesis in this child. And it can even lead to an expansion of air embolism in other cases.
Okay. So you just mentioned to me regarding cerebral blood flow. Okay. So let me know what's the relationship between cerebral perfusion pressure, mean arterial pressure, because this becomes very important in a patient who's having any neurosurgical intervention.
So cerebral perfusion pressure is the pressure which is required to auto-regulate the cerebral blood flow, sir. So it is basically the mean arterial pressure minus the intracranial pressure, sir. So we have to avoid any increase in ICP as well as we have to prevent any decrease in the mean arterial pressure, sir.
Okay. Now, suppose your mean arterial pressure in this age group, what is the pressure you expect systolic and diastolic?
Systolic will be somewhere around 90 to 95 mmHg, sir. Diastolic will be 50 to 55 mmHg.
Even lower than that, around 70, 80.
Okay.
Okay. And suppose he starts, as you said, we'll maintain the mean arterial pressure. The pressure starts coming down. So what are you going to do to maintain the mean arterial pressure?
So to maintain mean arterial pressure, we can give IV fluids. And if there is no response, then I would like to go for some inotropes or vasopressors.
So you are trying to maintain the mean arterial pressure.
Yes,
Second thing you mentioned was regarding the intracranial pressure, right?
Yes, sir. Yes,
what measures can be taken intraoperatively to keep the ICP low so that the CPP is maintained?
So first, there are pharmacological as well as non-pharmacological methods, sir. So the non-pharmacological method would be 30-degree head and position can be maintained, sir, to improve the cerebral venous drainage.
Yeah, it aids in your central veins getting drained away. So
Yes,
that okay.
Yes,
Go on.
apart from that, hyperventilation can be done, sir.
Okay, how much you do a mild
Hyperventilation, sir.
So you want to be PCO to which level?
30 to 35 millimeter of mercury.
Okay, so you want to do mild hypoventilation. Okay, what else?
We can also go for
the ICP is still high. Anything else can be done?
Then I would go for pharmacological methods. I would like to give mannitol 0.25 to 0.5 gram per kg. And I'll try to increase the depth of anesthesia. I'll provide good analgesia also for the patient.
Okay. So to keep the ICP under control, we can have a gentle hyperventilation as well as make use of mannitol, good analgesia to the patient, and good sedation. Okay. So now you have all these things in your mind, and you have prepared your OT, you have prepared your IV lines, you have decided not to use nitrous oxide. So now we go on to the induction part, right? So you like to induce this patient with IV or inhalation? What is the advantage, disadvantage?
Sir, I would go for IV induction in this child, sir.
Okay. So what IV induction agent you will use?
So before starting with the induction, I'll give a small dose of opioid, like in the dose of 2 mics per kg, along with injection glycopyrrolate, 10 mics per kg, sir. And I would like to use injection thiopentone for this patient in a dose of 5 mg per kg, 5 to 6 mg per kg, sir.
Okay, your OT technician says thiopentone is out of stock. He is giving you ketamine. Are you happy with it?
No, sir, I'll try to avoid ketamine.
Okay. So what other drug can you use? Thiopentone is not available. Ketamine, you don't want to use any other IV induction agent?
So graded doses of propofol can be given, sir, injection propofol.
You can use propofol. So you have done an IV induction, and what muscle relaxant you would like to use? Or do you not like to use a muscle relaxant?
So before, soon after giving the induction agent, I'll look for loss of eyelash reflex if I'm giving thiopentone, sir. And after that, I would like to ensure the ventilation of the child by giving small positive breaths, sir. And if I make sure that I'm able to ventilate the child, then I would go for muscle relaxant, sir.
Which muscle relaxant preferably you like to use?
Sir, injection atracurium, sir, 0.5 to 0.6 mg per kg, sir.
Why atracurium? Why not something else? Why specifically atracurium?
So because the metabolism of atracurium is not dependent on any renal or liver function, sir. It is through Hoffman elimination.
Okay, as a newborn, 3 months old, his hepatic and renal systems are not very mature. So with atracurium, preferably use, less reversal problems are going to be there. Okay, so you have put an intubating dose and you have intubated size you mentioned to me 3.5 uncuffed tube. Okay, okay. Suppose no thio, no propofol. We decide upon an inhalational induction. What agent you will use?
Preferably sevoflurane, sir.
So the technician says, sir, nahi dawai aayi hai desflurane. The person was after me, use desflurane. So any problem with using desflurane?
So desflurane has to be avoided during induction, sir, because since it has a pungent odor, it can irritate the pediatric airway, sir. This will lead to the child going for any spasm.
Not interested in using desflurane. Okay,
No,
then
sir.
he gives you isoflurane. What about isoflurane?
So even that I'll try to avoid, sir.
Okay, CO not available. You said CO now. So what are you left with?
Halothane.
So you can jolly well use our age-old halothane.
Yes, sir.
Okay, so you have done an inhalational induction. You have intubated. Okay. Now, what monitoring you will be doing on this patient?
So after induction, I'll go for standard ASA monitoring, sir, like ECG.
Okay, what all?
ECG, non-invasive blood pressure, pulse oximetry, capnography, and temperature monitoring, sir.
Okay. So you will do what you mentioned, these 4 monitors, 5 monitors you will put up, and a lot of people go for even putting up a precordial stethoscope or a esophageal stethoscope is also put up to monitor. Okay. So you have intubated, you have started your monitors and maintenance. How are you going to maintain this patient?
I'll be maintaining with 50% oxygen with 50% air, sir, with inhalation agent, sevoflurane of less than 1 mAc. And I'll also give intermittent bolus of atracurium if the child comes out.
Okay, so you are going to have a controlled ventilation because
Yes.
you are given a relaxant. Okay.
Yes.
So positioning, you mentioned already, right? What positioning can you repeat?
So child will be maintained in supine position with head turned towards the opposite side.
What IV fluid you will be using?
So ringer lactates, sir.
You'll be using ringer lactate. Okay. So normally, how long does it take for this surgery?
So usually within 45 minutes to 1 hour, sir.
Okay. The surgery went on without any hiccups, and the surgeon has done. Anything about intra pain relief you mentioned about fentanyl? Anything else can be done now? The patient, we are heading towards the extubation part.
Yes, sir. Sir, I'll be giving IV paracetamol injection, sir, in a dose of 15 mg per kg during the intraoperative period. And also I can infiltrate the surgical site, sir, with local anesthetic 0.25% bupivacaine 4 ml, sir.
Okay. Now, when you are trying to put IV paracetamol at the end of surgery, you have lost the vein. There is a swelling. You remove the drapes. Any other route you can give paracetamol?
Yes, sir. It can also be given as a suppository dose, sir.
Okay. So you can even use it as a suppository if you have lost your IV line.
Yes, sir.
Okay. So when you have there is some amount of spontaneous respiration has come up, you have loaded your reversal agent, right?
Yes,
now,
sir.
when can you extubate this child? When is the child ready for extubation?
So when the child starts breathing.
Very thing, because a lot of times, if you are extubating the child not in a proper plane, you end up with a laryngospasm. So it's very important when you extubate this child.
So when the child starts breathing spontaneously, that is when the child's hand starts reaching the endotracheal tube, child will show grimaces, strong grimace. There will be spontaneous eye opening and along with hip flexions. And at that point, I'll try to extubate the child, sir.
Okay, so when the child shows some purposeful activity, as you mentioned, that hand going towards the endotracheal tube or strong grimacing is there, eye opening, then you will extubate the child. Okay, and then shift to the recovery. Okay. So I think we are done with the hydrocephalus part, right? So in our mandate, we have also to discuss meningomyelocele. So actually, we have covered most of the part of anesthesia with this hydrocephalus. Now will be a few questions about meningomyelocele so that our topic can be completed. Okay. So we shift gears to meningomyelocele. Okay. So Rachita, what is the basic problem in meningomyelocele?
The basic problem, there will be failure of neural tube closure, sir, which will lead to a defect in the posterior vertebral arches, sir. And this can lead to the protrusion of meninges with or without neural tissue.
So basically, it's the protrusion to the posterior arches. So if there is a neural tissue, it becomes a meningomyelocele, and if there is no neural tissue, it's only becomes a meningocele. Okay. So what do you understand by spina bifida occulta?
So spina bifida occulta is one of the neural tube defects, sir, in which there will be failure of neural arches, sir. So this will be seen without any protrusion of meninges or neural tissue. And it will be covered with a layer of skin, sir.
Is any marks are there on the skin which will tell
There can be a skin dimple, tuft of hair. We can even see certain cutaneous angiomas, nevus.
Okay. So all these telltale signs are there, and we can suspect the child is having a spina bifida. Okay. Now, what is the usual etiology? Why does this meningomyelocele occur? Of course, it will be multifactorial. What are the usual causes in history which we like to ask the patient?
It's a multifactorial etiology will be there, like especially during antenatal history, mother will give history of folic acid. The mother has not taken any folic acid during her antenatal period, and it can also be associated with certain insulin-dependent diabetes mother, or use of any anticonvulsants during pregnancy. It is also associated with certain chromosomal abnormalities like trisomy 13, trisomy 18. Sir.
So it has been found to be associated with folic acid deficiency and drugs like anticonvulsants, which can lead to meningomyelocele, which we take up in the patient's history. How do you go about diagnosis meningomyelocele?
So it can be diagnosed in the antenatal period itself, sir. Like we can go for an ultrasound anomaly scan, which is normally done at 16 to 18 weeks of gestation, sir. And apart from this, we can also go for maternal alpha fetoprotein levels or amniotic fluid alpha fetoprotein or acetylcholinesterase level. So this will be elevated in case of neural tube defects.
Okay. Any associated anomalies? One we have already been discussing, hydrocephalus. Any other associated anomalies which you normally rule out with the meningomyelocele?
Yes, most common anomaly is vectoral anomalies, vertebral, anal, cardiac, tracheoesophageal, any renal or limb anomaly. And there can also be associated hydrocephalus, anal cherry malformation, clubfoot can also be seen, sir, and also neurogenic bladder.
So the carry home message is whether we have hydrocephalus, whether we have meningomyelocele, we have to rule out multiple other anomalies which might be associated with this condition. Okay. So if you are examining, what are the various sites in which meningomyelocele can occur?
The most common site is lumbar meningomyelocele, sir. Apart from this, we have also occipital encephalocele can be seen. It can also be seen only in the sacral region, sir.
Okay. Now, what is anencephaly? It's also an anomaly which is associated.
Yes,
what is anencephaly?
In which the cranial vault will be absent, sir. So we can see the protrusion of brain, sir.
Right. Child born in with this are usually incompatible with life.
Yes,
okay. So meningomyelocele, the diagnosis is very obvious. You have some protrusion of the meninges or of the spinal cord, and you can very easily diagnose it. Okay. Now, what are the investigations you will do? Because any medical management?
Sir, I can't hear you. Sorry.
Medical management for meningomyelocele?
Yes, so there are certain conservative managements till the child is taken up for surgery. So we can cover the lesion with saline soaked sponges, and we can also give antibiotics to the child. And if at all the swelling goes for rupture, then we have to look the child for signs and symptoms of meningitis. That is, if there is any neurodeficit in the child, sir.
Right, that's very important. If the meningomyelocele ruptures, the CSF leakage can start, and the child can land up with meningitis, which can be a life-threatening condition, right? So that's very, very important that that is taken care of. Okay. What investigations you do in this child?
So routine blood investigations like complete blood count, including hemoglobin, total leukocyte count, and platelet. Apart from that, kidney function test, serum electrolytes, chest X-ray, urine routine and microscopy. And in this patient, I would like to ask even blood grouping and cross-matching, since I'm expecting blood loss during surgery. Apart from that, 2D echo, sir.
Right, 2D echo to rule out any cardiac anomalies, which can be very commonly associated. And blood grouping and cross-matching is important because meningomyelocele can result in blood loss. Okay. Now, when do you plan out for surgery for this child?
So ideally, surgery has to be done as early as possible, sir, but preferably within 24 to 48 hours, sir.
As early as possible before any rupture takes place, because otherwise added complications can be added. Now, suppose a child is having both hydrocephalus as well as a meningomyelocele. So what do? You operate both of them, one of them, or one after the other? What is the normal protocols we follow?
So ideally, it has to be done together, sir, like a VP shunt followed by MMC repair, sir, in a single sitting, sir, if possible.
Suppose child has both. I only repair a meningomyelocele. Is it all right or no, or something wrong with it?
Sir, no, sir, because if a VP shunt is not performed in a child with hydrocephalus along with meningomyelocele, and if we repair only the MMC, then because of the increased CSF pressure, after MMC repair, it can go for breakdown, sir.
Yeah, because of if there is a hydrocephalus, CSF pressure is high, and if only meningomyelocele is repaired, the sutures can give away, and the whole thing will be undone. Okay. I'm not going to ask you anything about the pediatric anesthesia since we have covered it. Now, something specific about meningomyelocele I'll be asking, right? Now, let's go. What is the position in which for intubation and for surgery? Let's talk about intubation first. Any problems with intubation for a meningomyelocele?
Yes, the positioning can be difficult during intubation, sir. The swelling can even go for rupture if we are not taking precautions to protect the swelling, sir. So what we can do is we can keep a donut-sized gel-padded donuts can be kept, sir, on the site of location of that meningomyelocele. And another thing what we can do is we can even go for a right lateral intubation, sir, if we don't have adequate size donuts available.
Okay. So the idea is to prevent any rupturing of the meningo. That is the idea. During intubation, you put bolsters so that the meningo, there is no pressure on the meningomyelocele, and then the intubation can be done. Okay. Now this meningomyelocele is normally repaired in which position? Surgery is done in which position?
Surgery will be done in prone position, sir.
Okay. So what are the problems you anticipate, and how you will take care of the positioning of the patient in a prone position?
Yes, sir. Before shifting the patient to prone position, we should ensure that we have disconnected all the lines and our endotracheal tube is properly secured with an adhesive, sir. And after shifting to prone position also, we should ensure that there is no extreme flexion or extension of the head, sir. Because this can lead to the displacement of our endotracheal tube. And we should again ensure that the tracheal tube is properly secure.
Okay.
And
suppose after putting the prone position, you do not hear any air entry on the left side. What has happened?
So endobronchial intubation, sir, like displacement of the tube due to flexion, sir.
More likely the tube goes on the right side or left side?
So right side, sir. Right side.
Why it is more commonly goes on the right side?
Yes, sir. So
you said the tube is more likely to go in the right bronchus. I'm asking you why it is more likely to go in the right bronchus.
So because the right side bronchus is more in line with the mainstem bronchus, sir, at an angle of less than 25 to 30 degrees, sir. So there is more chance of the tube migrating towards
the right side. Okay, so if you have to ensure that the tube is properly secured and you check for ventilation of bilateral equal air entry after putting in the prone position. Okay. Anything about the boosters in the prone position?
Yes, sir. We should avoid any abdominal pressure, sir. So we have to keep adequate size bolsters with the upper side of the bolster placed below the clavicle, and the lower end of the bolster should be above the iliac crest, sir. So this will prevent any abdominal compression, sir.
Okay, why are you trying to avoid abdominal compression? What are we trying to safeguard?
So when there is increase in abdominal pressure, it can lead to increase in intrathoracic pressure, and this will again lead to increase in intracranial pressure in the child. So one reason. And another thing is that because of this abdominal compression, it will lead to increase in the epidural venous pressure. So this will lead to increased bleeding during surgery, sir.
Okay, so basically you are trying to avoid IVC compression, increased bleeding can be there. It can inhibit the free movement of the diaphragm. So all these precautions have to be taken when the patient is put in the prone position. Anything about protection of the pressure points?
Yes, sir. Adequate padding of the pressure points has to be taken, sir, to avoid any nerve compression or even skin abrasions.
Okay. Anything about the eye protection?
Yes, sir. Eye has to be adequately padded, sir, or else because of the compression, child can even turn out with post-operative vision loss, sir, because of the venous compressions.
So to sum up, the prone position should be such that abdomen is free for the excursions. The tube should be bilaterally nicely good entry, and all the pressure points should be covered up nicely so that there is no intra-op complications.
Yes, sir.
Okay, I think we have completed the subject, and now I'll ask Dr. Shashmita to sum up both cases.
So before summing the session up, there's few questions which delegates want to know. One second, sir. The first question is, what is the ideal mode of ventilation in raised ICP?
No, we can, since it is a child 3 months old, we will go for a controlled ventilation. And the advantage of controlled ventilation will be, we can have a gentle hypocapnia between 30 to 35 so that the ICP is controlled.
Okay, sir. The next question is, what can succinylcholine be used for intubation in difficult airway?
Yeah, succinylcholine can be used. If there is no hyperkalemia, dose of 1 to 1.5 milligram can be used. There is no contraindication.
Can scalp block be given for both intra-op and post-op analgesia?
So we mentioned that where the surgeon, we can give a block with bupivacaine 0.25%. That's the usual mode. And plus, we can also give a block where the subcutaneous tunneling can be given, local infiltration can be given. These are the local blocks, and we can supplement it with intra-op fentanyl, and we can start a suppository of paracetamol right after induction, or we can make IV paracetamol.
Okay, sir.
We generally tend to avoid long-acting narcotics because of the children are obtunded and they tend to hypoventilate and desaturate.
All right, sir. Any specific considerations if the child is posted for meningomyelocele for MRI and we are called for giving anesthesia in the outside?
Usually, if the child coming for an MRI, we have to be careful about sedation. Usually, sedation is good enough. No need of a general anesthesia. We have with the bonited anesthesia care. It can be taken care of.
Okay. How to assess GCS in pediatric patients?
It is a problem. Yes, I agree. The GCS scale is also different. Instead of 15, we have 14. Yes, problem is there over the experience who are doing pediatric cases. I think they are able to do it. It is problematic. I agree.
Okay. And especially if it's a cervical meningomyelus, any special consideration that we have asked? Especially if it's cervical meningomyelocele for MRI, the difficult airway.
The difficult airway, you have to be, experience helps. You have to be very judicious with the dosage which you are using. And obviously we supplement with oxygen. And as I mentioned, monitored anesthesia care. And we have all the resuscitation equipment at handy. So it's a delicate balance which we have to maintain.
And there's one more last question. Why urine routine microscopy is needed?
You see urine, when I say routine microscopic albumin sugar, right? If there's a UTI, it will show up in your, with pus cells in microscopic examination. And usually in pediatrics age group, how do you put up I'm not specific for this, how do you put up a juvenile diabetic, right? Sugar positive, you put up a juvenile diabetic. So I'm always insisting on a urine albumin sugar in all the pediatric age group. This is how you pick up a juvenile diabetic. So we insist on a urine albumin sugar.
All right, sir. So there are many more questions answering. Your lecture was very popular, I think. In children, right and left bronchi are at the same angle from midline. What are the chances of endobronchial intubation? Is the chance equal on both the sides?
I think it's still more on the right side. You are right; they are equal, but it's still the instance is more on the right side.
Okay, sir. And post-op pain management in such a case?
You mentioned you can continue with IV paracetamol, right? If there's acute pain, we can give small doses of fentanyl as well. No long-acting to be used. Paracetamol is quite effective.
Yes, sir. How to prevent persistent tachycardia generally seen with tunneling of the shunt?
You can give a top-up of fentanyl. You can use. You can increase your inhalational anesthetic. You can give a small dose of propofol. It will take care of the tachycardia at the time of tunneling. Yes, tunneling is a painful procedure, but if you have retained a good depth of anesthesia before tunneling is started, this problem will not be there.
If there is associated cardiac anomaly, how will it change our anesthesia plan?
You see, depending on what is the cardiac anomaly, right? I already said that important thing is to have to rule out your associated ASD, VSD. We can't give a generalized answer. In general, it is first main precaution in all pediatric age groups is to prevent any kind of an air embolism, right? Because of a small ASD or which has gone unnoticed, it can give to systemic air embolism. Obviously, then depending on a particular lesion, all those precautions will have to be taken.
Okay, sir. Choice of sedation, propofol versus dexmedetomidine. Yes.
Dexmedetomidine in a 3-month-old, I have never used. And what is the need of IV sedation that way? I think if you're giving good analgesia, the child is already obtunded. He had anesthesia for 1 year, for 1 hour. So I think IV paracetamol should be good enough, or a small dose of fentanyl.
Yes.
Will take care of it.
Can supraglottic device be used for intracranial surgery in infants?
I have never used it. I don't recommend it.
Dorsalis pedis artery cannulation in a pediatric, in an infant, is it how?
Why do you want to go for a dorsalis pedis?
Yes.
I don't
No.
think it is indicated. No.
Can ketamine be used for sedation in MRI in a meningomyelocele case?
Yes, it will cause rise in ICP. I know sometimes it is being used, but if you can avoid it, it will be better.
Okay, sir. So I think those are all the questions that we have till now. We may have a few more. Dr. Sashwata, Assistant Professor, she will summarize the case which we just listened to, all the important points.
ठीक हो गया? मेरा रोल खत्म है ना? हाँ, I don't mind.
Good morning, everyone. Good morning, everyone. Welcome to EPIC 21. Now, let's discuss something about hydrocephalus and meningomyelocele and the concern and the anesthetic management in this. So, first we'll discuss about hydrocephalus. So what is hydrocephalus? Hydrocephalus is a condition where there is an increased volume of CSF. So CSF can be increased due to an increased production of CSF, or due to obstruction to the flow of CSF, or due to a reduced absorption of CSF. All these three factors will ultimately lead into increase in the volume of CSF and leading to hydrocephalus, and which will ultimately lead to rise in ICP. So normal ICP in term infants are 1.5 to 6 mmHg, and in the children is 3 to 7 millimeter of mercury, and in adults it is 7 to 15 millimeter of mercury. The total volume of CSF in adult is approximately 150 ml, which is produced at a rate of 20 ml per hour. Out of this entire volume, only 20% is present in the ventricle, and rest is present in the subarachnoid spaces in the cranium and the spinal cord. Now let's see how CSF is circulated. CSF is produced from the choroid plexus of the lateral ventricle, and from where it passes into the third ventricle through foramina of Monro. From there, then it flows into the fourth ventricle through aqueduct of Sylvius. From fourth ventricle, it flows into the subarachnoid spaces of cranium and spinal cord through a medial foramen, which is called the foramen of Magenty, and through two lateral foramina, which are called as foramina of Lashkas. This CSF is then reabsorbed into the venous sinuses present in the cranium. Types of hydrocephalus. Hydrocephalus can be divided into non-communicating, communicating, normal pressure hydrocephalus, hydrocephalus ex vacuo. The non-communicating hydrocephalus, the main cause for this is the obstruction. And these non-communicating or the obstructive hydrocephalus are the most common type of hydrocephalus that we see in our clinical practices. Hydrocephalus ex vivo is due to compensatory enlargement of the CSF spaces in response to brain parenchymal loss, which is usually seen in after a trauma or in patient with schizophrenia. Depending on the etiology, the communicating and non-communicating can have congenital or acquired causes. Coming on to communicating type, there are many congenital causes, but for example, achondroplasia. In the acquired causes, there are subarachnoid intraventricular hemorrhage, choroid plexus papilloma or carcinoma, or due to after some infection. The non-communicating, the congenital causes are many. The most common is aqueduct stenosis, and the acquired causes are tumors, post-inflammatory adhesions, or any cerebral hematoma. The diagnosis can be made depending on the signs and symptoms the child may present. So they usually present with some vague signs and symptoms. They may present with headache, nausea or vomiting, irritability, poor feeling, lethargy, increased head circumferences, bulging frontal nail. And on examination, we can find out a few signs like sunset sign. We can also elicit lower motor deficits and also signs of raised ICP. On investigating the patient, on doing a CT scan, we can see dilated ventricles, which appears like which gives a sign, Mickey Mouse sign. The treatment for this is shunting of the CSF, which can be done either through a shunt surgery or through endoscopic third ventriculostomy. The various types of ventricular shunts are available. For example, ventriculoperitoneal shunt, ventricular atrial shunt, ventricular pleural shunt. Shunt can be classified into low pressure shunt, medium pressure shunt, and high pressure shunt. And the indication for this ventriculoperitoneal shunt can be an elective, like in case of any chronically raised ICP, or the child can present in emergency with acute rise, with features of acute rise in ICP. Coming on to the anesthetic consideration, in the preoperative assessment, we have to take a detailed current and past medical history, history of any allergies, history of any previous anesthesia exposures. These patients usually are on many medications, like they can be on anticonvulsant, diuretic, acetazolamide. So we have to properly take a current history of current medication. These child may have many comorbidities. So history related to comorbidities should be taken. These childs have High possibility of congenital or genetic disorders. They also have few respiratory system disorders and also CNS abnormalities. Thorough examination should be done to rule out any airway signs of any airway obstruction, serious system, respiratory or neurological system. The NPO status should be inquired. And on investigation, we have to see hemoglobin and clotting parameters should be available, urea and electrolyte. ABG and chest X-ray can be done in case we are suspecting any pulmonary pathology. And other investigation can be done depending on the comorbidity and the condition of the patient. Pre-medication should be avoided if there are signs of raised ICP. For allay the anxiety in older children, midazolam can be used, but it should be used only under observation. Intraoperatively monitoring, all the standard monitoring should be used. And if there is any other congenital abnormality or any comorbidities, specific monitoring can be used. While inducing anesthesia, we have to keep in mind to avoid any acute rise in intracranial pressure or any fall in cerebral perfusion pressure. Therefore, we have to prevent hypercarbia and hypotension. So the anesthetic concerns in this case are mainly related to age, since these are pediatric age groups, related to hydrocephalus and related to the surgery itself. Coming on to the concerns, first the age related. Already this age is pediatric, the airway in the pediatrics is usually difficult, and with this big head, it leads to a more anticipated difficult airway. So we can manage it through while positioning the patient for intubation. We can put roll below the shoulders so that and also we can keep the head beyond the edge of the table, which will be supported by an assistant. The intubation can also be done in lateral position. While choosing the anesthetic agent, intravenous induction is always preferred if the features of raised ICPs are present and an IV access is present. In the intravenous induction, we avoid ketamine since ketamine leads to increase in the intracranial pressure. And in inhalation, we try to avoid isoflurane and desflurane since these two also leads to increase in the intracranial pressure. For analgesia, any short-acting opioid should be used. For muscle relaxant, non-depolarizing muscle relaxants are preferred, but in case of emergency, we can also do rapid sequence induction using scoline. Airway to be secured with the endotracheal tube. The fixation should be nicely taken care of because there are high chances of migration of the tube while the surgery and also during the positioning of the child. The proper padding for the eyes should be used. While positioning the surgery is taking place in supine position with neck turned to the opposite side. While turning the neck, we need to take care of the neck position. It should be done very slowly to avoid any sudden increase in the intracranial pressure. Also, roll should be placed below the shoulders to facilitate turning of the shunt. Throughout the surgery, throughout the positioning, and also during the surgery, we have to always keep checking our endotracheal tube position. And we need to cover the patient as much as possible to avoid any hypothermia to the patient. While maintaining the anesthesia, our goal should be to avoid fall in BP and cerebral perfusion pressure, and also to avoid any rise in intracranial pressure. To maintain this, the inhalation agent should not be used more than 1 MAC, and the nitrous should be avoided since nitrous increases the cerebral blood flow and thus cerebral blood volume, which will ultimately lead to increase in the intracranial pressure. And short-acting opioid can be used and non-depolarizing muscle relaxant. To summarize, the intraoperative managed during the different steps. So while tunneling of the shunt catheter, there is an increase in the sympathetic response. There's increase in the heart rate and increase in ICP. To avoid this, we need to increase the depth of anesthesia, or we can give additional doses of opioids. There's a high chances of patient going into hypothermia. So since there's a large area exposed, we need to use warm fluids, cover as much as possible, and warming devices should be used. While fluid management, our goal should be meant to maintain the cerebral perfusion pressure. Normal saline is commonly used in these cases. Dextrose containing fluid should be avoided since they also lead to increase in the ICP. While extubation, our goal should be to rapid recovery and rapid recovery. An early neurological examination should be done to see the prognosis for this patient. Postoperative pain, local infiltration, and also paracetamol IV or per-rectal can be used. Opioids, the small can be used, but only under observation. Standard post-op monitoring should be done. So this is the slide which showing the proper preoperative assessment should be done to rule out any anticipation problem related to the airway. To identify the signs of raised ICP, difficult airway, and comorbidities, the goal should be to maintain the cerebral perfusion pressure. For doing that, we have to avoid hypercarbia and hypoxia, prevent hypothermia, and also maintain volume, electrolyte, and glucose level. Post-operative care should include an early recovery and extubation, monitor vital parameters, pain control should be taken care of, and neurological examination as soon as possible post-surgery. Coming on to meningomyelocele. So meningomyelocele is a condition where there is a failure of closure of the neural tube. So a neural tube closes usually around 28 days of gestation. So how a neural tube is formed? Neural tube is formed through neural crest. These neural crests deepens and make neural groups. Ultimately, this neural groups then covers it and forms the neural tube. So coming on to the classification of the neural tube defects. First, we have anencephaly. Anencephaly is there is a defect in the anterior closure of the neural groove. The brain and skull is poorly developed. And anencephaly, the defect is in the cranium part. So the brain herniates through the cranial defect. Spina bifida cystica, there is a fusion. There's a failure of fusion in the midline, so leading to the vertebral column is absent in these. It can be a meningocele or meningomyelocele. In meningocele, there is only herniation of meninges, whereas in the meningomyelocele, there is herniation of meninges and also neural tissues. Then spina bifida occulta, where there is an absence of spinal process. Wherever the skin is normal, there's normal and there's no associated lesion. This is a diagram showing meningocele, where only the meninges are outpouching with no neural tissues. And this is an occipital encephalocele, and here is a diagram showing frontal encephalocele. So coming on to etiology, females are more prone than males, and few environmental factors are also associated with this. The main and most common factor is the deficiency of folic acid during the periconceptional period in mother. Some few drugs are also related, like valproate and carbamazepine during the antenatal period. This is mostly seen in the low socioeconomic patient. The pathology, depending on the severity, it can manifest as neurological, motor, or sensory deficit. Or they may have brainstem dysfunction. The patient may present with stridor apnea, sleep disorder, difficult breathing, aspiration, vocal cord paralysis, lack of coordination, spasticity. They can also be present with raised signs of raised ICP like headache and lethargy, irritability, vomiting, and ophthalmoplegia. The complications can be, if there is a leak of CSF, it can lead into infection. So patient may present with fever, unconsciousness, or altered sensorium. Diagnosis can be done during the fetal period. There is while doing the amniotic fluid study, we can find increased acetylcholine esterase level and alpha-fetoprotein. And prenatal diagnosis are very good option available nowadays. Let's see what are the anesthetic concerns. Here also the concerns are related to the age, related to the pathology itself, and related to the surgery. Age-related pathophysiology, since there's a pediatric age group, the airway is difficult. They are very prone to hypothermia, and there are increased chances of blood loss and fluid loss during the surgery. Related to pathology itself, so because of the meningomyelocele, there's a difficulty in positioning while intubation. So while intubation, we can do the intubation in semilateral position with the head in midline, or we can put folded towels or donuts for resting of the for meningomyelocele. If it's present at the cervicothoracic, the babies are very much prone to postural hypertension. In the frontal encephalocele, they may have airway obstructions. These childs are also present with many coexisting diseases. So they might have some features of meningitis due to infection. They might have motor deficits. In this, we have to be very careful while using succinylcholine. And comorbidities like Arnold-Chiari syndrome is also very common. They have they may present with increased features of ICP. These meningomyelocele and these lesions are very much sensitive to latex. So we need to take care while examining the meningomyelocele. We need to be wearing a latex-free gloves. Related to surgery, this surgery is done in a prone position. So while doing the positioning, we need the abdomen should be free. So for this, we can use two bolsters. One bolster is below the clavicle and the other below the pelvis. Also, so that your abdomen, and also all the pressure points should be padded properly to avoid any deformity to our injury to nerves or deformity and eyes are also should be padded properly to avoid post-operative blindness. There's a risk of blood loss in this. The blood loss, also there is a shift of CSF dynamics while the surgery. So when we take a patient for meningomyelocele, in the pre-anesthetic examination, we have to first take a detailed history related to antenatal history of drug ingestion, similar defects in siblings, birth history, rule out any seizure or history related to any increased precordial activity. Limb movements should be, history should be taken properly. And while back examination should be done nicely, we need to know the defect location, size, shape, and whether there is any CSF leak or not. Curvature of the spine is also very important. And while examining the back, we should use latex-free gloves. Neurological examination and airway examination should be done properly, keeping in mind all the risks related to the meningomyelocele. Associated history of any associated congenital anomaly should also be ruled out. And investigation with the routine investigation, we can also ask for CT or MRI if indicated. In the pre-anesthetic management, pre-medication should be avoided. If needed, anxiolytics can be given in the older children. Injection atropine and glycopyrrolate can also be given. While induction, proper positioning, pre-oxygenation, IV or inhalation agent depending on the situation. And succinyl, we have to keep in mind while choosing this muscle relaxant. Amla can be used before cannulating the patient. For maintaining non-depolarizing muscle relaxants should be used with short acting narcotics. Low doses of muscle relaxant should be used. Oxygen and inhalation and nitrous can be used in these cases, keeping in mind that there is no features of raised ICP. For ventilation, controlled mode of ventilation is preferred. And IV fluids, RL or NS with 1 to 2% of dextrose can be used in these cases, and we have to replace blood for blood. Monitoring, all the standard monitors should be attached, and post-operative pain can be covered using IV or per-regnal NSAIDs. Thank you very much and all the best.
One second, please. Thank you, Dr. Sashmita. That was a very interesting gist of the whole scenario. And one last question for Dr. P.S. Bhatia, sir, is what is the role of TIVA in a case of if it just needs to be done in a TIVA in an infant from meningomyelin or hydrocephalus?
I have personally no experience of getting a 3-month-old done under TIVA, so I can't really comment. I never got it done under TIVA.
Okay, sir. IV sedation in a case outside in an MRI situation, or isn't local anesthesia supposed to cause delayed wound healing?
Local anesthetics delayed wound healing.
Wound healing.
I think
not really.
Not really. Not important. Not important.
Thank you, sir. I think MD ma'am wants to say a few words. Over to you, ma'am. Ma'am, you have to unmute yourself. Ma'am, you are muted. Please unmute yourself, ma'am.
Okay, okay. Am I audible now? Thank you so much, Dr. Bhatia. Very nice case.
Ma'am, you have to unmute yourself.
I've already unmuted.
Yes, ma'am. Yes, we can hear you.
Yeah, you're audible now.
Yeah. Thank you so much, Dr. Bhatia, for taking out time for this very nice case discussion, elaborate case discussion. And this is a very commonly asked case in the examination, both as a short case and as a long case. And also, you know, there is a theory question also about it. And for the PGs, you know, I think we have chosen very calculatively that what all cases are there in most of the institutions, and very commonly we find that this hydrocephalus and meningocele, mostly two associated conditions or separately, may be asked as a short case. And so this discussion was very pertinent to the PG discussion, PG for their examination. And thank you so much, Dr. Bhatia. And with this, I give it over to
for
Dr.
giving me this
Anupma.
opportunity. Thank you so much.
Thank you. Thank you, sir. Thank you, madam. Thank you, Dr. Sashmita. Thank you, Rajita, for such an interesting case session. So before we break for the lunch, we have the last last lecture before lunch. That is we have a lecture on local anesthetics by Dr. Subida Sood. And the chairperson for the session is Dr. Professor Vijay Nagpal. Sir is a consultant and a professor at ABVIMS Hospital and Dr. RML Hospital, and his interests are cardiac anesthesia and pediatric anesthesia. So,
thank you, Dr. Anupma, for introducing me. I now wish to hand over this presentation to Dr. Subida Sood, who is a professor and HOD of anesthesia at ESI Faridabad, and has done fellowship in interventional pain management, runs a pain clinic in her own hospital, and she is a senior professor and a PG teacher of a long duration. I fondly remember her when she was with us at RML Hospital, and
Yusuf, can we have the video, please?
morning, everybody. Good morning, everybody. Let me on the outset thank the organizers, Dr. M.D. Kaur, Dr. Abhishek, to having given me the chance to give a talk on the topic of local anesthetics. I hope you all will understand it and enjoy the lecture as well. Okay. So let us start. What are the contents of my today's lecture? One, a short historical background. I'll talk about the history of local anesthetics. Then secondly, what is the definition of local anesthetics? Third is methods of inducing local anesthesia, like how do you inject local anesthetics, by what all methods into the patient's body. Then what is ideal local anesthetic agent, the classification of local anesthetics, the mechanism of action of local anesthetics, and relationship with pH. The last one is very important. Okay. Now, what are the physicochemical characteristics of local anesthetics affecting its function? What are the pharmacokinetics of local anesthetics? What are the side effects of local anesthetics, their uses and clinical applications? What are the contraindications of local anesthetics? What are the vasoconstrictors which are added to the local anesthetics and their effect of local vasoconstrictors after being added? And little bit I'll talk about individual local anesthetic agents, and in the last I will talk about the new techniques. Now, the history, as I mentioned, cocaine was the first and foremost local anesthetic agent isolated by Niemann in 1860 from leaves of coca tree. Its anesthetic action was demonstrated by Karl Koller in 1884. The first effective and widely used local anesthetic agent was, however, procaine, produced by Ian Horn in 1905 from benzoic acid and diethyl aminoethanol. Its anesthetic properties were identified by Bieberfield. The agent was introduced into clinical practice by Braun. Lidocaine was first discovered by Lofgren in the year 1948, and discovery of the anesthetic properties of lidocaine was followed in 1949 by its clinical use by T. Goethe. Now, what is the definition of local anesthetics? Local anesthesia is drug-induced reversible local blockade of nerve conduction in a specific part of the body that does not alter consciousness. Now, very important is the consciousness of the patient is not altered. Is a drug-induced reversible local blockade, drug-induced reversible local blockade of nerve conduction. It acts on the conductivity of the nerve. So it doesn't, it is a very, to a specific localized part of the body, not to the entire body like general anesthesia. It doesn't affect the entire body. What are the methods of, how does it affect the body? To which the patient's body, to which local anesthetic agents are injected. First of all, it lowers the body temperature. It causes little bit of mechanical trauma to the patient. It may cause anoxia, and neurolytic agents such as alcohol or phenol can be also used as a substitute of local anesthetic agents. Now, properties of ideal local anesthetics. It should not be irritating to tissues to which it is applied. It is by the word instead. See, it should not be irritating to tissues to which it is applied. It should not cause any permanent alteration of nerve structure. This is very important. The nerve should not get altered or damaged by the local anesthetic injected. Its systemic toxicity should be low. The time of onset of anesthesia should be short and rapid. It should be rapidly acting. It should be effective regardless of whether it is injected or applied locally to mucous membranes. It should be highly effective. The duration of action should be long enough to permit the completion of procedure. It should be longer acting and rapidly acting also. The duration of action should be long. The onset of action should be fast. It should have potency, high potency, which is sufficient to give complete anesthesia without use of harmful concentration of any solution. It should be free from producing any allergic reactions. It should be free in solution and relatively undergo biotransformation in the body. It should be either sterile or be capable of being sterilized by heat and without any changes in its chemical composition, that is without any deterioration. Now, what is the classification? All the local anesthetics can be divided into two groups. One is amide and one is ester. In the amide group, there is one aromatic ring, which is the lipophilic portion. As you can see, the amide ring, which is in the center, which is the main constituent of the molecule of the local anesthetic, and which has got the aromatic rings around its main nucleus of the structure of the local anesthetic. And there is an intermediate linkage also, which is present. Now, difference between ester and amide group is that in ester group there is one carbon. All the local anesthetics have one carbon atom, then oxygen, then carbon. And in ester, there is in the amide group there is one NH bond attached to the carbon, whereas in ester group there is an additional oxygen atom attached to the carbon. This is the difference. In amide there is one NH ammonium NH atom attached to the carbon atom, and in ester group there is one additional oxygen present between the two carbon atoms. This is the difference between ester and amide groups. I hope I'm making you understand. Is it understood to everybody? Okay. Now this is the classification. In amide group, we commonly use amide group of local anesthetics like lidocaine, mepivacaine, bupivacaine, nitidocaine, prilocaine, and the new latest local anesthetics like ropivacaine and levobupivacaine. In ester group, cocaine, procaine, chloropacaine, and tetracaine fall. Now, this is a comparative chart between ester and amide group. I'll enumerate a few of the differences. Esters are more easily broken. Ester drugs are less stable in solution, can't be stored for as long as amides. So esters are more stable as compared to amides. Amides are heat stable, can be autoclaved, whereas esters cannot be. Metabolism of esters result in the production of para-aminobenzoids, PABA, which can cause allergic reaction. Amides very rarely cause allergic phenomena. Amides are more commonly used than esters. As I told you, most commonly we use local anesthetics. These are amides and not esters. Now, this is the classification as far as the potency, the pKa, and the onset of action and duration of action, and maximum single dose which is used can be used for infiltration. Now, if we compare, we keep it the potency of procaine is 1. Chloroprocaine is 4 more times more potent. Tetracaine is 16 more times. And lidocaine, we keep the potency of lidocaine as 1. So bupivacaine is 4 more times. Levobupivacaine and ropivacaine also 4 more times more potent. As everybody can see, the pKa of lidocaine is 7.9. Beacane, levobupivacaine and ropivacaine, the pKa is also 8.1. So it is and the alkaline side. The onset of action of lidocaine is rapid, whereas bupivacaine, levobupivacaine is slow. I'm talking about the commonly used drugs only. That what is the duration of action is 60 to 120 minutes of lidocaine. Procaine is 45 to 60 minutes and bupivacaine is up to 480 minutes. Up to 8 hours, maybe more also. Ropivacaine and levobupivacaine also have similar duration of action. And how much is the maximum dosage which can be given? Procaine, we can give up to 500 milligrams, lidocaine up to 300 milligrams plain in a body, or 4 milligram per kg body weight in an adult, and up to 7 milligrams per kg body weight with adrenaline of lidocaine. Whereas bupivacaine is 175, levobupivacaine is also approximately 175, ropivacaine little more because it is less toxic. Now, what is the mechanism of action of local anesthetic agents? What it causes is disruption of ion channel function via specific binding to sodium channels. See, there is one sodium channel, as you can see. This sodium potassium channel, it causes blockage or disruption of obstruction to the flow of sodium potassium ions. So disruption of ion channel function via specific binding to sodium channel. It goes and binds to the sodium channel. So the sodium potassium channel gets disrupted and it holds the sodium channels in inactive state. Also, it causes disruption of ion channel function by the incorporation of local anesthetic molecule into a cell membrane. This is a direct action into the cell membrane. When injected or infused, it enters into the cell membranes and acts directly. Mechanism of action further, the following sequence. It is binding of local anesthetic molecule to the receptor site on the sodium channel only, and it thus causes blockade of sodium channel. It causes decrease in sodium conduction. Conduction of sodium potassium efflux influx is stopped, so that means there is no electric activity, and thus there happens a complete conduction blockade, whereby depression of rate of electric depolarization. There is no depolarization occurring and the action potential is not generated. So there is failure to achieve threshold potential. See, if the threshold potential is not achieved, that means there is no action, that means no action potential generated, no electric impulse is conducted in the nerve. So there is propagation of action potential doesn't occur. So complete conduction of complete blockade of conduction of a nerve impulse occurs after giving a local anesthetic agent. Understood? Now, what are the types of nerve fibers on which and how it acts on the different nerve fibers? On type A alpha, which are proprioception and motor fibers, and that with a diameter of 12 to 20 microns, which are heavy, thick myelinated. The conduction velocity is 70 to 120 meters per second. Type B, where which are preganglionic autonomic fibers, which are light, non-myelinated, are where the conduction velocity goes down drastically, and the sensitivity of block is inversely proportional to the thickness or the myelination. So the blockade conduction of the electric impulse is generated very fast in preganglionic autonomic fibers. So the impulse is quickly generated. So the action of local anesthetic also is very fast in preganglionic autonomic fibers. You can see it is inversely proportional. Sympathetic postganglionic fibers are also not myelinated. So the conduction velocity is also the sensitivity to blocks is also 4 more times as compared to the thick heavy myelinated alpha nerves. So now I come to the theoretical part. Small nerve fibers are more sensitive than large nerve fibers, as I told you. Myelinated fibers are blocked before non-myelinated fibers of the same diameter, or thus loss of nerve function proceeds as loss of pain, first of all, then temperature, then touch, then proprioception, then skeletal muscle tone goes. That is why people may still feel touch but not pain when using local anesthesia. See why small nerve fibers are more sensitive than large nerve fibers? Because they are thickly myelinated. The large nerve fibers are thickly myelinated. Myelinated fibers are blocked before non-myelinated because the nerve channel, it propagates on the myelin, on the wherever the myelin sheet, it just jumps from one point to another point. Here there is no diagram made, so I cannot explain it. You have to understand. See the nerve conduction, it jumps from one myelin, from one pinch of the myelin to the another one. So that is why myelinated fibers are blocked a little faster than non-myelinated fibers of the same diameter. Now, what are the pH, how it gets affected by local anesthetics? Now, as I told, all local anesthetic agents are weak bases. They exist in 2 forms, unionized bases and ionized bases. pKa of a weak base is defined as the pH at which both forms exist in equal amounts. That means the unionized fraction and the ionized fraction, they exist in the same, in equilibrium. As the pH of the tissue differs from pKa of the specific drug, more of the drug exists either in its charged or uncharged form. See, each drug will have a different pKa, and as the pH of the tissue, any tissue in any patient differs from pKa of the it is different from the pKa of the drug. More of the drug exists either in its charged or uncharged form. Now, pKa minus pH is equal to log of ionized form divided by the pK is minus pH is equal to log of the ionized form over the divided by the unionized form. This is the Henderson-Hasselbalch equation. This is very important. This it can come as a short note in the theory, or it can also be asked in the practical. It determines how much of local anesthetic will be in non-ionized or ionized form. Based on tissue pH and anesthetic pKa of the drug. Injectable local anesthetics are weak bases. pKa is equal to 7.5 minus 9.5. It can be. When local anesthetic is injected into tissues, it is neutralized. Part of ionized form is converted to non-ionized. Non-ionized base is what diffuses into the nerve. Now, this is a non-ionized form which diffuses into the nerve, not the ionized. Remember this thing. Now, this is the graphic representation of pH, pKa and local anesthetic agents. Bupivacaine, the pKa is slightly more alkaline than the pKa of lidocaine, as everybody can see. This is on the y-axis is the ionized fraction and pH is on the x-axis. So you can see the pKa of bupivacaine is slightly more than pKa of lidocaine. Now, effect of infection. If the area to which its local anesthetic needs to be injected is infected, so relevant feature, what happens? Infection has acidic pH. So relevant feature of infected tissue is more acidic environment than usual. As pH of the affected tissue is reduced, unionized fraction of local anesthetic gets reduced automatically. Consequently, the effect is delayed and reduced. So that is why they always say that try to avoid giving a local anesthetic agent into an infected tissue. Also, increased blood supply because of the swelling, the inflammation, there is increased blood supply to that part of the body. More local anesthetic may be removed from the area, will be washed out into the bloodstream, removed from the area before it can affect the neuron. Now, what are the physicochemical characteristics of a local anesthetic which affect its function? The aromatic ring structure, as I told, and hydrocarbon chain length will determine the lipid solubility of a local anesthetic agent. As I told you, there are aromatic rings around the main nucleus of the local anesthetic agent, which will determine its lipid solubility. More lipid soluble drug penetrates the cell membrane, obviously, and which is more easily to exert its effect. Thus, bupivacaine, which is highly lipid soluble, is approximately 4 times more potent than lidocaine because of its increased lipid solubility as compared to lidocaine. Now, what is the duration of action? Also related to length of intermediate chain joining the aromatic and amine group. The aromatic and the amine group, the longer length it is, it will depend upon the duration of action. The longer it is, more lengthier is the longer is the duration of action. Protein binding. Procaine is only 6% protein bound and has a very short duration of action, whereas bupivacaine is 95% protein bound and it has a longer duration of action. See, the higher the protein binding, the lesser the lesser free drug is getting available to the tissue. So longer duration, more longer is the duration of action. Now, what is the maximum dosage allowable for the administration of a local anesthetic agent? The maximum dose, plain esters, procaine, it is up to 5, as I told you, 5 milligrams per kg. The duration of action is up to 30 minutes. And with epinephrine, it is 7 milligrams per kg body weight. With epinephrine, its duration of action is maximum up to 30 to maximum 40 minutes. Whereas amides, lidocaine, it is 4 milligrams per kg, and plain lidocaine, the duration of action is up to, they can say 1.5 to 2 hours. Whereas with epinephrine, with additive agent, vasoconstrictors, the duration of action goes up to 7 milligrams per kg body weight, and duration of action can be up to 3 hours. Whereas bupivacaine and ropivacaine, the duration of action can go up to 3 to 8 hours, and without plain bupivacaine, the dosage is 2 milligram, up to 1 to 2 milligram per kg body weight, and it action lasts up to 4 hours. Whereas with the epinephrine, also it remains the same. The reason I'll tell you later. There is no advantage of adding any vasoconstrictor or epinephrine to longer acting agent, bupivacaine, ropivacaine, and levobupivacaine, because they are already longer acting. So further duration of action is not increased by adding any vasoconstrictors. Now, what are the pharmacokinetics? Uptake, injected. I hope everybody understands the meaning of pharmacokinetics. For the uptake, as a local anesthetic is injected into soft tissue, more local anesthetics produce dilatation of vascular bed, except cocaine, which causes vasoconstriction. Initially, it also causes vasodilatation due to the local effect, followed by prolonged vasoconstriction. Due to increase in the rate of absorption of the local anesthetic into the blood, local anesthetic cocaine into the blood, thus decreasing duration of pain control while increasing the anesthetic blood level and potential for overdosage. So it causes more and more of addiction. That is the reason. Oral load. Except cocaine, local anesthetics are poorly absorbed from GI tract. The absorption from gut is very poor, except cocaine. Most of them, because of the hepatic first bypass metabolic effect, 72% of the dose approximately of local anesthetics is biotransformed into inactive metabolites. Tokenide hydrochloride is an analog of lidocaine, which is effective orally. Topical route. It is absorbed at different rates via tracheal mucosa. Uptake is as rapid as with IV administration. Pharyngeal mucosa, it is slow uptake. Bladder mucosa, it is uptake is even slower. What is now eutectic mixture of local anesthetic, which is known as AMLA. AMLA is a cream which is developed to provide surface anesthesia for intact skin. It is a 5% mixture of two local anesthetics, lidocaine and pilocaine, 2.5% and 2.5% of each local anesthetic. AMLA consists of injection. Rate of uptake after injection is related to vascularity of injection site, vasoactivity of the drug. The more vascular the injection site, the more faster the local anesthetic drug will be absorbed, and more vasoactive the drug is, the more faster it will be, more rapid and more faster it will be absorbed into the bloodstream. IV administration provides most rapid elevation of blood levels used for primary treatment of ventricular dysarrhythmias, mainly lidocaine. Blood levels of local anesthetics after injection is intercostal is highest, caudal is further less, epidural is further less, brachial plexus further lower down, and sciatic nerve is the lowest because it is the very thick and myelinated nerve. I hope I'm clear to everybody. Now, rates at which local anesthetics are absorbed and reach their peak blood level, IV, the time is approximately 1 minute of after lidocaine. Topical, it takes approximately 5 minutes. IM, intramuscular, it takes 5 to 10 minutes approximately. Subcutaneous, it 30 to 90 seconds. Distribution. Once absorbed in blood, local anesthetics are distributed throughout the body to all tissues. Highly perfused organs such as brain, head, liver, kidney, lungs have higher blood levels of anesthetics than do less higher perfused organs. Local anesthetics then to do less perfused organs. Blood levels of a local anesthetic is influenced by the following factors: rate of absorption into the bloodstream, rate of distribution of the agent from the vascular compartment to the tissues, elimination of drug through metabolic or excretory pathways. That means rate of absorption, the faster the drug is absorbed, the faster it will be, its action will be. Rate of distribution of the agent from vascular compartment to the tissues. The more faster it goes from the blood to the tissues, the more faster and rapid will be the action. And also elimination of drug. See, this is the action. Then elimination, how long does it stay into the tissues? Elimination of drug through metabolic or excretory pathways also they will determine its duration and potency. All this is under pharmacokinetics. All local anesthetic agents readily cross the blood-brain barrier and placenta also. Metabolism. Now I'll talk about the metabolism of local anesthetic agent. Ester local anesthetics are hydrolyzed in plasma by enzyme pseudocholinesterase. Chloroprocaine, the most rapidly hydrolyzed and least toxic of all. Tetracaine is hydrolyzed 16 times more slowly than chloroprocaine, has the greatest potential of toxicity. Tetracaine is more toxic than chloroprocaine. Now, amide local anesthetics are more complicated than esters. Primary site of transformation of amide local anesthetics is liver. Entire metabolic process occurs in the liver for lidocaine, remember, etidocaine and bupivacaine. Prilocaine undergoes more rapid biotransformation than the other amides. All remember that. Prilocaine undergoes more rapid biotransformation than other amides. Excretion. Kidneys. Is the primary excretory organ. A percentage of given dose of local anesthetic drug is excreted unchanged via the kidneys. Esters appeared in only very small concentration as the parent compound is in the urine. Procaine appears as I told you, para-aminobenzoic acid 90% and 2% remain unchanged fraction. 10% of cocaine total dosage is found in urine unchanged, but amides are present in the urine as a parent compound in a greater percentage than esters. Now, what are the side effects of local anesthetic agents? As we all know, lidocaine is more neurotoxic than other local anesthetic, mild local anesthetic agents. CNS, effects of CNS causes excitation followed by depression, drowsiness to unconsciousness, and death due to respiratory depression. Cardiovascular system, mainly bupivacaine is cardiotoxic. The bupivacaine is more cardiotoxic, and lidocaine is more neurotoxic. Cardiovascular system, it causes bradycardia, heart block, and vasodilatation, and dysarrhythmias also. Mainly hypotension it can cause. Allergic reactions, allergic dermatitis leading to anaphylaxis is rare but reported and can occur more often than ester type of drugs as compared to amide group of drugs. Uses local anesthesia. First, it can be given to induce local anesthesia, regional anesthesia, ventricular dysarrhythmias, decrease hemodynamic response to tracheal intubation. Very important for induction of anesthetic agent. Systemic local anesthetics used as adjunct to amitriptyline and an anticonvulsant agent like carbamazepine in chronic pain also. 1 to 3 weeks may be required to observe a therapeutic action in neuropathic pain. Also, it can be used, but it has got a longer onset of action. And also, local anesthetics have poorly understood anti-inflammatory agents, but some of the local anesthetics, they cause anti-inflammatory effect, which contributes to pain control in chronic pain and neuropathic pain as well. Now, what are the clinical applications of local anesthetic agents? First is surface anesthesia. As I told you, mucous membranes and abraded skin, the surface anesthesia of local anesthetics, and also the mucous membrane of nose, mouth, bronchial tree, cornea, and urinary tracts. Infiltration anesthesia. They can cause direct injection into tissues to reach nerve branches and terminals. Also used in minor surgeries like incisions, hydrocele, radiography, etc., etc. There is an endless list. Field block. Injection of local anesthetic subcutaneously can cause field block. The aim is to anesthetize the region directly to the site of at the site of injection. Examples are forearm, anterior abdominal wall, scalp, and lower extremities. Then nerve blocks. Most important. Local anesthetic agent is injected around the nerve trunk or plexus, mainly brachial plexus. Area of anesthesia is large in comparison to the amount of drug used. The more the drug used, the more larger the area will be anesthetized. Last longer than the field or infiltration methods. Flooding technique for plexus block is most commonly used by the anesthesiologist. Example is trigeminal nerve blocks on the face, ophthalmic nerve blocks on the eyelids and scalp, supraorbital nerve block on the forehead. Then comes spinal anesthesia, very important. Site of injection is subarachnoid space between L3-4, L2-3 or L4-5. The site of action is nerve root in the chorda equina. Level of anesthesia is volume will be determined by the volume and speed of injection, the varicity of the drug solution with CSF as compared to the CSF, and the posture of the patient as well. The order of anesthesia is sympathetic is more faster to be blocked, nerves more faster blocked as compared to motor nerves. Uses are lower limbs, pelvis, lower abdomen, prostatectomy, fractures, etc., obstetric procedures, cesareans, and there is an endless list. Now, what can be the problems or complications? Spinal headache, post-dural puncture spinal headache, hypotension, bradycardia, respiratory depression, chorda equinal syndrome, nausea, vomiting, etc., etc. Epidural and caudal anesthesia. I'm talking about this. This is in continuation with the sentineural blockade. The site of injection is sacral hiatus, caudal or lumbar, thoracic or cervical region. And catheters are used for continuous infusion of a and often epidural injection. Regional anesthesia, it can be intravenous as well. Injection of local anesthesia in a vein of a tourniquet-occluded limb, mostly limited to upper limb, that is Bayer's block, and most often in for orthopedic procedures of the hand. Now, what are the contraindications of local anesthetic agents? If a patient has a heart block, 2nd or 3rd degree without pacemaker, or a severe sinoatrial block without a pacemaker, serious drug reaction, allergic reaction to lidocaine, or a mild local anesthetic agent. I hope everybody knows how to do a allergy test on the patient just on the day of surgery, before taking the patient in for surgery. You order a skin allergic test of local anesthetic. The wheel should be not more than 1 to 1.5 centimeters. Concurrent treatment with what is the treatment of severe the arrhythmias is with pharmacological agents, class 1 antiarrhythmic agents like procainamide, quinidine, etc., etc. Or it can be prior use of amiodarone hydrochloride also, because it takes 1.5 hours of duration of action. Hypertension, if hypertension doesn't occur due to arrhythmias, bradycardia also, and in case of accelerated idioventricular rhythm also, we can use amiodarone hydrochloride. Now, what are the vasoconstrictors added? They constrict into the local anesthetic, and how do they potentiate the effect of local anesthetic agents? Constrict the vessels. Vasoconstrictors obviously decrease blood flow to the site of injection, thereby decreasing the absorption of local anesthetics into bloodstream, producing lower levels, and they decrease risk of toxic or overdosage of a local anesthetic. So we can give a higher dosage for the same effect. And so that means the effect will be prolonged. If we give a higher concentration of local anesthetics, which remains high in concentration around the nerve, increasing the local anesthetic duration of action, obviously. The lower the toxicity and increasing the duration of action. If vasoconstriction is not used, plain local anesthetics will cause vasodilatation. Blood vessel in the area will dilate, increase, sorry. It will increase absorption of the local anesthetic into the cardiovascular system, which will cause known as redistribution, thus by hence higher plasma level and increased risk of toxicity, which will leading to increased risk of toxicity, thus decreased depth and duration of anesthesia, and further leading to diffusion from the site, diffusing out from the site, and increasing bleeding due to increased blood perfusion to the area. So the duration of action will be lower, there will be vasodilatation, and there will be increased bleeding at the site of action. So it is always better to add vasoconstrictors to the drugs which can be, into which it is indicated, like lidocaine. But we should not use vasoconstrictors to the tips, like to the areas fingers, toes, nose, and ear lobes. What are the contraindications of vasoconstrictions? The blood pressure, if it is more than 200 by 150, like in an uncontrolled hypertensive patient, 200 by 115 or 200 by 110 millimeter mercury. Severe cardiovascular disease like ASA grade 4 plus. So though some may be theoretical only, but just to complete the list: acute MI in the last 6 months, anginal episodes at rest, cardiac dysarrhythmias refractory to drug treatment, patient in hyperthyroid state hyperthyroid state also, and if the patient has any drug intake, history of any drug intake. Now, what the American Heart Association says, typical concentration of vasoconstrictors in local anesthetics are not indicated in patients with cardiovascular disease, as long as aspiration, slow injection, and the smallest effective dose is administrated. Like you thoroughly aspirate repeatedly, give it slowly, and the smallest effective dose, which can be given if you inject taking all these precautions, then you can give typical concentrations of vasoconstrictors added to the local anesthetics to ASA grade 3 and 4 patients. However, they pose high risks as compared to ASA grade 1 and 2 patients. Now, this is just one picture diagram of commonly used local anesthetic day in and day out. We use in our OR, lidocaine, which can be administered topically, intravenously, intrathecally, and in the epidural space also. Available as lignocaine hydrochloride. Additive added is epinephrine, bitartrate, or it can be used as jelly or as spray or as IV solution also. Now these are the various, this is a picture diagram of various forms of lidocaine hydrochloride which is available in the market. This is by the commercially available pharmaceutical companies, by Neon, mostly by Neon. I put it here. Little small mention about cocaine, which is the oldest local anesthetic. It's a naturally occurring alkaloid from the coca plant. Medical use is limited to surface or topical anesthesia, corneal or nasopharyngeal, because it causes severe constriction of corneal vessels and sloughing, leading to sloughing and drying. A toxic action on heart can lead to rapid and lethal cardiac failure, cardiac arrest. It also causes stimulation of CNS or stimulation of vasomotor centers, leading to vomiting and temperature, at high temperature or temperature disturbance in the body. It also causes euphoria followed by dysphoria. Avoid adrenaline while giving cocaine, and it can cause marked pyrexia, as I told you, with cocaine overdose has also been seen in cocaine addicts also. Procaine, Novocaine. Topically ineffective is one of the disadvantages. Used for infiltration because of low potency and short duration, but most commonly used for spinal anesthesia abroad. Because of its short local duration, it produces significant vasodilatation. Adrenaline is, however, used to prolong its duration of action. It's sexy because the main advantage is systemic toxicity of procaine is negligible because rapidly destroyed in the plasma. However, it can be used as a penicillin agent also. Bupivacaine. No topical effect of bupivacaine, slower onset and one of the longer duration of agents used for infiltration, spinal, epidural, nerve block, etc. It is unique property is analgesia without significant motor blockade. That means it causes more of sensory blockade than as compared to motor blockage. Lidocaine causes more motor blockade, whereas bupivacaine causes more sensory blockade. Popular drug for analgesia during labor analgesia, it is the most commonly used drug. High lipid solubility, high distribution in tissues, and less in blood. Benefit to the fetus. That is the reason it is given more commonly in labor patients. More cardiotoxic than other local anesthetic agents like lidocaine, and it prolongs QT interval, not given intravenously, available as 0.25% and 0.5% injections. See now what is ropivacaine? It is a R enantiomer of bupivacaine. The molecule is dextrorotated. Only difference is that. So it becomes much less cardiotoxic, and how it is the least cardiotoxic, so cardio safe drug. So nowadays bupivacaine is rapidly replaced by ropivacaine for labor analgesia also, and hence the lower in potency than compared to bupivacaine, but however the duration of action is increased, so sensory blockade is also increased. The labor analgesia effect, prolongation of labor analgesic effect, and the toxic effects are also less with ropivacaine as compared to bupivacaine. Levobupivacaine is the molecule of bupivacaine is levo-rotated to the left. So longer duration of action, and it is less potent, less cardiac toxic as compared to bupivacaine. So these are the two main advantages of ropivacaine and levobupivacaine, and they are fast replacing bupivacaine. EMLA, as I told previously, it is eutectic mixture of local anesthetic agent. Eutectic is two solid substances mixed in equal quantities by weight. They form a eutectic mixture, 2.5% of prilocaine and lidocaine. So total it becomes 5%. Melting point of the mixture is however lower than the melting points of the individual components. EMLA is lidocaine and prilocaine, as I told you, becomes an oily mixture indicated for dermal anesthesia, like putting just before putting a IV line. EMLA 5% cream specifically is applied to prevent pain associated with intravenous catheters, insertion, blood sampling, superficial surgical procedures, and topical anesthesia of leg ulcers for cleansing or debridement. However, it can also be used to numb the skin before tattooing. Okay. Now, these are interferences in all. They are somehow the relatively latest techniques of giving local anesthetics. Lidocaine soaked sponges can also be used. They cause via interferences. Local anesthetic lidocaine is injected into the patient's tissues. Liposomes, liposomal bupivacaine can also, liposomes can be loaded and can be injected into the patient's body. Now, I thank you all for a patient listening. I hope you all enjoyed my lecture. Any questions you can later on ask me. Now I will give two. There are two questions for the quiz. One is give me a classification of amide and ester local anesthetic agents, and second question is what is the pH of lidocaine. One is pH of lidocaine and second is the main difference between amide and ester local anesthetic agents. Thank you, one and all.
Thank you, ma'am. There is only one question. Dr. Suvidha Sood is not logged in for some urgent reason. Dr. Nagpal sir can answer that. What is the relevance of plasma protein binding and local anesthetic use in relevance to that?
The relevance of protein binding relates with the availability of drug, whether it will be available immediately or whether it will be available in a graded manner as the drug gets released from its protein bound sites. So the more the protein bound the drug is, the more slowly it will be released or in its free form. So duration will be more.
Thank you, sir. I think that answers the question. So we are very short of time today, so we'll be going on to the next session before Madam MD Kaur ma'am, do you want to conclude this session with Dr. Nagpal sir?
I thank Dr. Suvidha Sood for her presentation and preparation. Although the time was 30 minutes, it has gone on to 47 minutes. So we are hard pressed to continue any further. But I, however, invite Dr. MD Kaur, our head of the anesthesia department of AVVIMS, for her concluding remarks.
Thank you so much, Dr. Nagpal, for inviting me to give my comments. And
thank you, sir. Madam, you have to unmute yourself.
I'm unmuting.
Yes, ma'am. Yes, when you're audible now.
Thank you so much, Dr. Nagpal, for chairing the session, and Dr. Suvidha Sood for presenting this lecture. Though she is not here live on the session, but it was a good presentation. But I do feel like Dr. Nagpal said that we must respect the timing, because you know the sessions are time limited and the topics are endless. So, however, thank you so much. And I hope her presentation was good and, everybody must have been benefited by the presentation. And this is again an important topic. As I told you that all the topics are, important from exam point of view. That is why, we are holding these lectures. And thank you so much. And I wish good luck to the PG students. And over to Dr. Anupma for further proceedings. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
As you're all aware, we are very short on time, so we are skipping the lunch break. So we are straight away moving forward with our case scenario. The next session is of a live case discussion, which is a case of a 6-year-old child with cleft lip and cleft palate for repair surgery. Yusuf, can we have the yes, right. So Dr. Bharti Wadhwa would be the external for the case, and the internal would be Dr. Sangeeta Yadav, Associate Professor Anesthesia. Yusuf, can you play the slide of Dr. Bharti Wadhwa again, ma'am? Yes. So Madam is professor in the Department of Anesthesiology and Maulana Azad Medical College, New Delhi. She has various academic achievements to her name, and she has held many positions, important positions in the Government of India, Ministry of Health. She is a member expert, specialist board of anesthesiologists in NB. She is a national coordinator for webinars in anesthesiology NB. She is an organizing secretary of Changing Trends in Obstetric Anesthesia, ultrasound guided regional anesthesia. The case would be our PG, Dr. Kirtana is already logged in. So she would be interacting with Dr. Bharti Wadhwa. Yusuf, you can stop sharing the screen. So there'll be interaction between Dr. Kirtana and Dr. Bharti Wadhwa. Over to you, ma'am.
Ma'am, I'm not able to hear you, ma'am.
She has to unmute. Dr. Bharti has to unmute her screen.
Am I audible now?
Yes, ma'am.
Am I audible? Right.
Yes, ma'am. Yes, ma'am.
Ma'am, you are audible.
Thank you. My thanks to Dr. MD Kaur for inviting me for this very wonderful academic sessions. And my compliments to the team of EPIC for the very interesting topics that they've put together. And I've been logging in myself all these days and I've been enjoying this, I think, as much as the postgraduate students. Without taking much time, I think we can go to the case presentation that Kirtana has prepared for us. Kirtana, if you could go for slide sharing, I would like the rest of the students also to see your case. Please start screen sharing.
Yes, ma'am, I'm sharing. Good afternoon, everyone. I'm presenting the case of a 6-year-old male child from Ghaziabad, whose informant is his mother. He presented with chief complaints of deformity of palate since birth and difficulty in phonation since 2 years of age. History of presenting complaints: the child had deformity of palate since birth. He had also had history of difficulty in phonation. He had difficulty in pronouncing certain sounds such as P, T, K, D, T, S, SH, etc. And it was associated with a nasal twang in his voice. No history of mouth breathing, snoring. No history of bluish discoloration, squatting, urine output, abdominal pain or swelling. Past history: child had history of difficulty in suckling as a baby, history of nasal regurgitation of feeds present. He also had history of recurrent upper respiratory tract infections. He used to get cough and cold 1 to 2 episodes per month, for which he had taken treatment on orthopedic basis. No history of breathing difficulty or hospital admissions. History of 2 episodes of ear discharge. which resolved on medication. There was no history of hearing. Last episode of upper respiratory tract infection was 4 weeks back. He underwent correction surgery for left-sided cleft lip at 3 months of age under general anesthesia elsewhere, which was uneventful as per the mother. No further reports of the same are available. No history of jaundice, seizures, pulmonary tuberculosis. No history of any contact with an active case of pulmonary tuberculosis. Treatment history, child is currently not on any medications. Antenatal history, it was of the mother. It was a non-consanguineous marriage. It was a booked pregnancy. She had taken iron and folic acid supplementations. No history of infections, bleeding, raised blood pressure, deranged blood sugars, any other drug intake or radiation exposure in the mother. Birth history, the birth order was 1. It was a full-term normal vaginal delivery in a hospital. The child cried immediately after birth, passed urine and meconium. Birth weight was 3 kg. There was a visible deformity of upper lip and palate at birth. Developmental history, he achieved all the milestones at appropriate age, except for the development of speech, which was delayed. Immunization history, child is immunized up to age. Family history, no history of any cleft lip or cleft palate in any other family members. No history of any other congenital anomalies in the family. Ma'am, shall I summarize, ma'am?
Yeah, please summarize.
6-year-old male child with cleft palate deformity with no other apparent congenital anomalies, not having any upper respiratory tract infection, came for palatoplasty.
How can you say no other apparent congenital anomalies? You're giving a history of recurrent URI in this child.
Yes, ma'am.
Can that not suggest a congenital anomaly to you?
Ma'am, there was no other history of bluish discoloration, squatting.
Are all cardiac congenital anomalies always cyanotic?
No, ma'am. No.
What happens in a ventricular septal defect?
Ma'am, in a ventricular septal defect, the pressure on the left side will be greater than the right side. While in systole, the blood will be going from the left side to the right side. Again, it will be recirculated.
It will be a left to right shunt, right?
Yes, ma'am.
Which is
Yes,
non-cyanotic. But
yes,
what does it lead to if uncorrected?
Ma'am, it will lead to pulmonary hypertension and shunt reversal.
There is something called what we call the wet lungs.
Yes,
Child
ma'am.
with
Yes,
PSP has classically would have repeated lung infections.
Yes, ma'am.
In your case, you have a history of recurrent URI, which you have associated with, I think, with the presence of a palate. But you must understand that it could also be an underlying cardiac condition, such as a VSD. So you really can't rule out a cardiac condition just by virtue of by the assumption that the URI is the result of your presence of a palate. And why does the presence of a palate lead to recurrent URI? Why would that lead to recurrent URI?
Ma'am, due to the cleft palate, the child will have nasal regurgitation of feeds. So that will irritate the mucosa and there will be airway hyperactivity, and it will lead to upper respiratory tract infections.
Now, along with that, the other thing that happens in such children is, see, this kind of regurgitation of feeds usually happens in the younger children. Now, your child is 6 years of age. That would happen more in a younger child when they are on a liquid or a semi-solid diet. Now, in this, the regurgitation of food, when that happens, leads to something which is more troublesome.
Aspiration.
No, by this time, the control, the swallowing reflexes are pretty well established. What is happening is there is often blockage of the eustachian tube because of the regurgitation, and the blockage of eustachian tube will lead to a chronic
otitis media. Otitis media.
And this is the age group in which the child will not only present with speech defects, the child often presents with hearing impairment. So this is one history that you could have looked into, because you see your child is presenting at 6 years of age. Now 6-year-old child is much older. So the presentation will be quite different. And frankly, we very rarely see children now coming at 6 years for a palate repair. At what time do you think is the best time for this child to have got operated? If this child was born with a, what time did you say that the lip was operated? At what age?
3 months.
At
3 months, ma'am.
At 3
3
months.
months, ma'am.
Yeah, so that is perhaps the correct age. And what is the
6
correct age for repair of a palate?
9 to 12 months, ma'am.
And why do we go at 9 to 12 months?
Ma'am, 9 to 12 months, it is done before the development of speech, and also there will give room for midfacial growth also.
Yes, that's very important.
Time for midfacial.
So basically, what we do in this surgery is that we mobilize the muscle flaps and we close the defect. Now, if the defect stays uncorrected, unrepaired, and the tongue starts to grow, that kind of approximation is not achieved surgically very well if done later. And as you very correctly said, and what has happened in this child is that leads to speech impairment, because palate is an important part of speaking and speech phonation. So yes, that is an important thing here. So we have a child now who has corrected lip, cleft lip, but with an uncorrected palate at 6 years of age, with history of recurrent infections, which could be upper respiratory or it could be lower respiratory. It's very difficult from the history to clearly, figure that out. So you still have that doubt here that this could be very well a cardiac issue here too. So let's go to the examination and let's see if we can come to a better conclusion after your examination. So please go ahead. Go ahead with the examination.
General examination. Child is active, alert, comfortably sitting. There is no pallor, icterus, cyanosis, clubbing, edema or lymphadenopathy. Pulse rate is 1 or 2 beats per minute. Regular rhythm, adequate volume, no radioradial or radiofemoral delay. Blood pressure is 90 by 60 millimeters of mercury, right upper arm in sitting position. Respiratory rate is 18 cycles per minute, abdominothoracic in now, head size is normal. Both anterior and posterior frontinae are closed. No external ear malformations. No downward slanting of palpebral fissure. No hypertrophy.
I just stop you here.
Yes,
We're talking of the anterior and posterior frontinae. What is this? What is the?
Yes, ma'am.
Should you be talking about this in a 6-year-old?
No, but associated in some syndromes, it can fuse later also.
Which syndrome? So actually, Kirtan, I'm very, very happy that you came up with this kind of a statement. The reason is that whenever you're presenting in the exam, please do not give extra information. This is something that I keep telling in my class also. Stick to what is pertinent to your case. Now, if you've got a child, that doesn't mean that, look at the age of the child. If it was probably a 1-year-old, I could have accepted that. In a 6-year-old, when you say anterior and posterior fontanelle, you're taking your viva in a different direction altogether.
Yes, ma'am.
Okay, so in this child, there was really no issue of head size and anterior posterior fontanelle. Go ahead.
No downward slanting palpebral fissure, no hypertelorism or notching of the lower eyelid, scar mark on the left side of the upper lip present, no micrognathia or retrognathia, lower and upper limbs are normal. Anthropometry, weight is 18 kg, height is 115 centimeters. Veins are visible on bilateral dorsum of hand.
Why did you go for, why did you do an ear examination in this child? I'm happy with it, but what was the significance?
Ma'am, both the ear and the palate, both it's a co-development, ma'am, from the first and second pharyngeal arches. So malformation, child very well can have other anomalies also, airway, difficult airway also.
Very good. So ear examination becomes important for this particular reason. The other thing you have said, the weight is 18 kgs. Is this weight adequate for the child's age?
Yes, ma'am. According to Wheat's formula, it's 20 kg, ma'am. It is within 50%. So
how do you estimate the weight? What is the formula that you use?
Age in 2 plus 8, ma'am. 1 to 6 years.
Age into?
Age into 2 plus 8, ma'am.
What is the more recommended formula, more widely accepted formula as per your Indian Association of Pediatrics? So it is age plus 3 multiplied by 5 by 2. So we have different formulas. So the one that the Indian Association of Pediatrics recommends is this as per your Indian population. So you should know that too. This child is a little bit on the lower side as regards to weight. Right, next please.
Airway examination, external nurse normal, no nasal discharge or crusting, scar mark of cleft lip repair on the left upper lip, mouth opening admits 3 fingers of the child, chin is normal, no retrognathia or micrognathia, midline palatal cleft approximately 1 centimeter involving alveolar ridge and both soft and hard palate present, uvula is separated by the cleft, incisor teeth are separated by the cleft, no loose tooth or missing tooth, no neck deformity or restriction of neck movements. Systemic examination, respiratory system, inspection, respiratory rate is 18 cycles per minute, abdominothoracic, trachea appears to be in the midline, no visible
I think we've lost Dr. Kirtana.
Yes, ma'am. Yes, ma'am.
Some connection issue.
Yes, ma'am. Trachea appears to be in the midline. No visible deformities of the chest. Chest wall moves symmetrically with respiration. No accessory muscle use or chest retractions. On palpation, inspection findings are confirmed. Trachea is in the midline. Chest expansion is normal. On percussion, resonant notes are obtained in all areas bilaterally. On auscultation, normal vesicular breath sounds are heard in all areas, no added sounds. Cardiovascular system. On inspection, there are no visible pulsations. Palpation, apex beat felt in left fourth intercostal space, 1 centimeter lateral to the left mid-clavicular line. No other palpable pulsations or thrill present. On auscultation, normal S1 and S2 heard, no murmurs present. Abdomen, on inspection, scaphoid and shape, all areas are moving equally with respiration. Umbilicus is in the midline, inverted, no obvious things, dilated veins or scar marks. On palpation, no tenderness, no gross organomegaly in all areas. Auscultation, normal bowel sounds are heard. Central nervous system, child is active and alert, no focal neurological deficits, spine is normal.
Right. So can we just sum up now? Can we sum up your diagnosis, provisional diagnosis for this child?
6-year-old male child with repaired cleft lip and cleft palate with no other apparent congenital anomalies, and no upper respiratory tract infection came for palatoplasty.
Right. So you have this patient that is now come to you for surgery. This child has been posted for surgery. What would you go for now? What further evaluation or investigations would you ask for?
I would like to ask for a complete blood count, including hemoglobin, so that I can know whether the child is anemic and have a baseline hemoglobin value, because bleeding is expected in palliative surgeries, and a total count to rule out any.
Can I just stop you again, Kirtana? So you said that you want to rule out anemia, and because bleeding is expected in palliative surgery.
Yes, ma'am.
So you expect that the bleeding would be that much to require a blood transfusion or something?
If the child is anemic and then there's a lot of bleeding,
I'm just bringing, I want to put across one point to all of you who are listening, all the students, that if she had said, I would like to do the hemogram to rule out anemia, I would have been happy till there. Every surgery has bleeding. Okay, so that wasn't the correct answer. So again, I'm saying limit your answers, because when you speak things like this, you're giving the examiner a clue to go forward on another direction. So if you've prepared a case for palate, stick to that. Minimal information to the examiners. Okay, so fine. Here the important point for you to know is that in a child with palate, the surgical loss is not significant enough to require a blood transfusion. And the other thing is, Kirtana, how can you calculate the blood loss in a palate? Is it easy or is it difficult?
It is difficult, ma'am, because the surgeon will be using ADR and
it is next to impossible to calculate the blood loss in a cleft palate surgery, because some of the blood is going into the suction while the rest is being often goes swallowed by the child, and the surgery is done under vasoconstrictors. So this kind of a problem doesn't arise with a palate surgery. So you could have just avoided that. But hemoglobin is important because these children often have stunted growth, as you said, because of feeding abnormalities. Now, my next question, Kirtana, is hemoglobin a routine investigation for all children who come for surgery? Is it mandatory to get hemoglobin and hemogram in all the children who come for surgery?
Ma'am, in case of minor surgeries, we can go without hemoglobin after clinically.
What are the current recommendations for pre-operative hemoglobin estimation in children? So pre-operative hemoglobin estimation in children is not recommended in all cases. It is restricted to situations where a child has a chronic disease, or a child like here where you're expecting anemia. So these are certain restricted areas where you ask for hemoglobin in the preoperative period. The other thing, what you can say, if it is an institutional practice in your institution, you can say that although hemoglobin recommendation is not there for, maybe say like you got a case of, say, a hernia repair, a healthy active child, there's no reason for that child to be anemic. But if it is your institutional practice, in the exam you can say that although hemoglobin estimation is not recommended in such children, but since it is part of my institutional practice, I would like to go for a hemoglobin estimation and screening in this child. So this is how you're supposed to answer in the exam.
Yes.
Okay. So fine, you asked for a hemogram. What else?
Yes, ma'am. Total leukocyte count, ma'am, to rule out any infections in the child. Then platelet count and chest X-ray.
Chest X-ray. Why do you want a chest X-ray in this child?
Yes, ma'am.
Why do you want a chest
child is having repeated upper respiratory tract infections. There could be a component of lower respiratory.
So you've just told me your examination, there was no, absolutely nothing suggestive of a lower respiratory infection. And the child hasn't had any URI for last 4 weeks. So why do you want a chest X-ray in a child who is a growing child, and you would be exposing the child to unnecessary radiation? Are you getting a chest X-ray done for such children in your institution? I'm pretty sure you are.
Yes, ma'am. Chest X-ray is done. Yeah, ma'am.
You're getting chest X-ray done for cleft palate.
Yes, ma'am. Chest X-ray is done, ma'am. Cleft palate.
There is absolutely no need for chest X-rays in this child who is clinically absolutely fine, had a URI 4 weeks back. There is no sign of a lower respiratory infection, and you are unnecessarily exposing a child to radiation. So there is absolutely no indication of chest X-ray in this child. We are going to gain nothing. Tell me what else. I'm only agreeing with your hemogram. Next, what else?
And a blood grouping and cross matching, ma'am.
Blood grouping, cross matching. Again, you're not really going to need blood in this child, but it is always wiser to have a blood grouping cross matching. Something very simple that you can do is a BTCT. Okay.
BTCT, ma'am. Yes.
Yeah. Anything
Sorry,
else?
ma'am.
Anything else?
Ma'am, since no, ma'am.
A very important thing that you should do in these children is ask for a pediatric medicine referral to rule out congenital anomalies. You can ask for an echocardiography because you're repeatedly been emphasizing on the fact that these are the children who have associated congenital anomalies.
Cardiac anomaly. Yes, ma'am.
This child could have any associated, which is the commonest congenital anomaly associated in a cleft palate.
ASD, VSD, ma'am. ASD and VSD, ma'am.
Right. And?
Tetralogy of Fallot.
No, I'm asking congenital anomaly. Needn't be cardiac. Okay, what are the syndromes associated? It's a part of a syndromic manifestation. So which are the common syndromes? Commonest, what is associated in palate? Even more common than a cardiac anomaly.
Peary-Robin sequence.
Yeah. So what is that?
Ma'am, there is a small mandible and retrognathia, retroglossoptosis, and airway obstruction.
Airway obstruction? Airway obstruction
Yes,
is part of syndrome? Airway obstruction is not part of syndrome. This child is prone to airway obstruction. Syndrome is just what you told me, those features. Okay. So don't, again, no unnecessary information again, Dr. Keerthana. Just stick to speaking lesser. Right. So, as you know that these are the children who have associated congenital anomalies. They may have cardiac anomalies. They may have renal anomalies. It is always wiser to ask for a pediatric medicine referral to rule out a good thorough evaluation by the pediatric medicine specialist. And if they feel, they can ask for an echocardiography to be absolutely sure that we've not missed out any cardiac anomaly, which has very severe and significant implications in the anesthetic period. Right. So you've got the investigations done. You found that the HB was good. How much HB do you need? Minimal HB do you need before surgery?
Ma'am, 10 grams.
Yeah, so you need 10, right? So you need 10 gram%. You've got your TLC doesn't show any infection, and you are ready to take up this child. What would be your pre-operative orders in this child?
Ma'am, pre-operative orders, Nilper oral for 6 hours before surgery, for solids, and clear liquids till 2 hours prior to surgery. Written informed consent from the parents. Then ma'am, pre-medication.
Good. What pre-medication?
Ma'am, that I'll give on the morning of surgery, ma'am. In the morning of surgery, I'll ask the child to be brought to OT along to the pre-op holding area along with the parent, and I'll put a pulse oximeter and put oxygen by mask. And if the child is having an IV cannula, then
No, why
I'll
do you want
give
to put
IV
an oxygen?
ketamine.
No, wait. Why do you want to put an oxygen by mask in the preoperative area?
Ma'am, in case of
Child
the
will just start
surgery,
howling.
if I give,
The child will start
Huh?
howling and crying. The child will start howling the moment you put a mask on his face. End of sedation. Why do you want to give that oxygen in the preoperative area?
Ma'am, if there can be airway obstruction, so
in this child,
once I give pre-medication, yes, ma'am.
Why will there be airway obstruction in this child? In this particular child that you discussed?
Ma'am,
This child, we are not expecting airway obstruction in this child. What you have very wisely said is that you would like to keep a pulse oximeter. That was very good, Kirtana. You should keep a pulse oximeter. You should make yourself comfortable with the child and their parents. A day before the surgery, you can go visit the child. You can be friends, talk to the child. A 6-year-old is a reasonably intelligent child. Explain the procedure to him.
Yes.
When he comes to you, once you have a pulse oximeter in place, you may want to give your sedation. Now, how would you like to give your sedation? And would you like to, first of all, would you like to give sedation? Yes or no?
No, ma'am, I would avoid sedative pre-medication, ma'am.
Why would you want to avoid sedative pre-medication?
Ma'am, in a child with cleft palate, I'll anticipate a difficult airway. If at all such a situation arises, then I will prefer the child to be awake, ma'am.
Sedation doesn't mean an unconscious child. Sedation doesn't mean an unconscious or a sleeping child. Sedation means a calm child. You don't want the child to have any sedation because you're afraid of airway obstruction. Now see, if it was a child who had features suggestive of retrognathia, glossoptosis, Pye-Robin syndrome, as you discussed. Now, in those children, I would have been happy if you said, I don't want to give any sedation. But in this child that you have discussed with us, there are no such features of any congenital anomaly. Now, it is very important for us to remember that sedation is very important in children because there are many reports, studies, in your books, it's clearly written that the anxiety or the trauma that a child goes through, the agitation the child goes through in the preoperative period, if not given sedation, leads to long-term behavioral problems and even PTSD in children. So sedation is always recommended and welcome in children, both psychological and pharmacological. If you do not have any such concerns of airway obstruction like in this child, it is highly recommended that you go for sedation. Sedation can be simply by midazolam. Which route would you prefer to tell me?
Ma'am, if the child is having an IV line, then I'll prefer IV midazolam.
And if the child doesn't have an IV line, which is the usual case, what would you do?
Ma'am, IM or intranasal I can give.
You can simply give oral midazolam, which is in a dose of 0.5 to 0.7 milligram per kg body weight. It helps to calm the child. Just given half an hour before makes the child very comfortable. And you can, if not midazolam, what are the other options?
Ma'am, ketamine can be given.
Ketamine can be given orally.
IV.
Again, it can be simply given orally in a dose of 5 to 7 milligram per kg body weight. You can go for oral or midaz or oral ketamine. You can go for nasal. Do you know what is the dose of nasal midazolam?
Midazolam, ma'am, 0.3 mg per kg.
Right, good. So you can give nasal midazolam, you can give oral, you can give IM if nothing works. But believe me, oral preparations work very well. Your child will be calm and you can escort the child inside. Right. So you've taken the child inside now. Any other pre-medication that you would like in this child?
Ma'am, if I'm giving ketamine, I'll give glycopyrrolate also, ma'am, 10 microgram per kg.
Otherwise, you wouldn't want to give glycopyrrolate?
Otherwise, ma'am, I will avoid, ma'am, glycopyrrolate because a child is having recurrent upper respiratory tract infections. There could be that there will be drying up and insufficiency of secretions can lead to tube block. I'll prefer to put an RA tube, which will, if it get blocked, it will be a problem for me.
Okay, so that you very correctly, you said that you may not want to have, but here in this child that it's been 4 weeks since the URI, and in such situations, you can give glycopyrrolate. The advantage of giving glycopyrrolate in these children is that it improves the surgical feed tremendously. There are very few secretions and the surgeon is very happy working. You said that with ketamine, you might want to give glycopyrrolate. So I want to make it very clear here, when ketamine is used for sedation via the oral route, it does not lead to increase in secretions, nor does it lead to delirium. So glycopyrrolate is not required when you're using oral ketamine as sedation. One should be very clear about that. So you've given glycopyrrolate and I forced you to give some sedation to this child because he seems just fine to me. I want the child to enter the OT happy and calm. Anything else that you would like to give to this child in the preoperative period?
Ma'am, I would like to nebulize the child with salbutamol, ma'am.
Why?
In prayer.
Why?
There is a history of since the child is having history of recurrent.
Look, let's just stop here. I think you're very confused about your URI. You are very afraid of the URI. I think you're constantly coming back to the URI. So we should be very clear. Let's just bring this point very clear across. When should we take a child if he is giving you a history of URI? What are your current recommendations?
Ma'am, URI can be
okay, let me just ask you another question first. Why do we not like to take a child who has a URI as an anesthesiologist? What can go wrong?
Ma'am?
Why don't we want to take a child with a URI for surgery? Are you with me, Kirtana?
Ma'am, yes, ma'am. Yes, ma'am. Now you're audible, ma'am.
Why don't we like to take a child with URI for anesthesia?
Ma'am, because of risk of perioperative respiratory adverse events, risk of increases in a child with URI, ma'am.
Specific.
Such as laryngospasm, bronchospasm, breath holding.
There is hyperreactivity of the airway. See, breath holding and laryngospasm are totally different things. There is very simply, there is hyperreactivity of the airway. So this predisposes the child to laryngospasm as well as bronchospasm. Now that can be a very big problem in children because bronchospasm is very strong in a child and it's very difficult to correct that. Okay, so that is an issue there. The other thing is that you have, as you said, inspissated secretions which can get blocked and can give you a lot of trouble intraoperatively, and specifically in a child with cleft palate, that can lead to wound infection and poor wound healing. So the surgeon himself will not want to operate. So this is the reason why we don't want to, and we wait for how much time for the URI to settle down?
Ma'am, if the patient is having a severe URI, then I'll postpone the case and reevaluate after 2 weeks, ma'am.
What is a severe URI?
Ma'am,
and what is a mild URI? Don't use these terms, please. These are incorrect terms. Just answer my question. I asked you, when would you like to take up, and if not, how long would you like to wait?
After 2 weeks, ma'am. 2 weeks I'll reassess.
Where is it written 2 weeks? Which book says 2 weeks?
Ma'am, Miller. Ma'am, but I'll reassess the child after 2 weeks, ma'am.
For what? If your child has having severe productive cough, how long would you wait? And when would you not? When would you take up the child despite a URI? What you say is a URI?
Ma'am, if the child is having a watery congestion,
So see,
dry
I'll take
cough,
here
or
because
no.
we're short of time, and I think we need to cover up everything. So if you want the airway reactivity to subside, it takes 4 to 6 weeks for the airway reactivity to subside, right? But in this child, like you said, in many children in India, we have children who have recurrent URI. So it may not be possible to, postpone each time for 4 to 6 weeks. So in case, especially like this, where the child is going to have frequent URIs, if the child is fever free, the child doesn't have any signs of lower respiratory tract infection, which would be bronchi, creps, noisy breathing. Okay, patient doesn't have a productive cough. And patient importantly doesn't have malaise. Or if the mother is saying,
Lethargy.
Yes, lethargy. If you can rule these things out and the child just has a sniffle or serious congestion of the nose, you can take these children up under the cover of
Bronchodilators and antibiotics.
Antibiotics are not given in these situations. Simple steroid cover. Steroids are equally good, protective. Now, steroid is good for both the child and for the surgeon also. Why? Because there is going to be so much tissue handling. Preoperative steroid is recommended in these children, irrespective of whether the child has a URI or not, because it helps to keep the airway edema check. Edema of the oral mucosa around the palate, around the surgical field in check. So the surgeon will also ask you, have you given any steroid preoperatively? They're very happy if you give steroid and glycopyrrolate because that makes them feel very good. Okay, right. So we've just come to this part. Okay, now let's go further. You've given your preoperative medication. Now it's time for you to take the child inside. Would you like to go for a IV induction or a inhalational induction?
Ma'am, if the child is already having an IV cannula, I will go with an IV induction.
If he doesn't, then how would you prefer?
Ma'am, I'll induce the child with inhalational agent, and then I'll secure
Agent
an
of choice?
IV cannula.
Which is your agent of choice?
Sevoflurane, ma'am.
Why?
Sevoflurane, ma'am.
Why?
Ma'am, sevoflurane is less retent to the airway, ma'am.
And? And?
And ma'am, it doesn't.
Now there should be
Doesn't
three
cause any
important reasons, there are three important reasons for using sevoflurane in a child specific to a palate. One, you said it is a non-irritating, heat smelling, easy to induce. The other two reasons?
Ma'am, it doesn't cause any arrhythmias.
Arrhythmias, yes. Elaborate on that. Good.
Ma'am, in palate surgery for reducing blood loss, the surgeon will be giving infiltration, local infiltration of atrial.
Very good. Very good. Very good. So whenever they are using ADR for infiltration, there is a potentiation or there is increased sensitivity to both the endogenous as well as exogenous catecholamines of the heart. And this is a child who's more prone to arrhythmias. Now, if you were to use halothane, the child would be at much more risk because you can use much more ADR when we are using sevoflurane. Very good. And the third reason is, if you don't mind, Keetana, my jumping in because we are short of time, is that we need at the end of the surgery a child who is awake. And we know that there is a faster onset as well as offset of action when we are using sevoflurane. Right?
Yes,
so these are the three important reasons why you should prefer sevoflurane over halothane in this child. Right. So you're going for an inhalational induction. Very good. Next.
Ma'am, I induce the child and then I'll secure an IV cannula. Then I'll confirm mask ventilation. Once I'm able to ventilate the child, then I'll give.
Supposing you're not able to ventilate the child.
Ma'am, I'll go with the nasopharyngeal airway, ma'am. I'll try a nasopharyngeal
That's
airway.
important point here because oropharyngeal airways often are not successful in a child with a palate because of the large cleft. They tend to get lost within the oral cavity, so they won't fit in. So go for a nasopharyngeal airway. Very good. Next, would you like to use a muscle relaxant in this child?
Yes, I'll use a muscle relaxant. Once I am able to ventilate the child, then I'll use muscle relaxant. Ma'am, I'll prefer Vecuronium 0.1 mg per kg. Then after 3 minutes.
Now here, see, there is a lot of
intubate.
controversy. Kirtan, I'm stopping you again. There's a lot of controversy about the use of muscle relaxant in this type of a child because you were so worried about airway abnormalities in this child. What if you land up with a difficult airway? We know that this is a difficult airway. Would you still like to use a muscle relaxant in a difficult airway?
Ma'am, since I'm able to ventilate the child, I will go ahead with muscle relaxant, ma'am, because I want an ideal condition and I want to prevent any adverse events like.
Supposing your child had retrognathia. Supposing your child had associated retrognathia. Would you still like to go for a muscle relaxant?
Ma'am, I'll deepen the plane with the inhalation, then intubate the child when the spontaneous ventilation is there.
So in case you have children who have, in case your child has significant airway anomalies, then you will prefer not to use a inhalation, a muscle relaxant. Muscle relaxant can be used after gaining airway access. Supposing you gave a muscle relaxant and everything was going fine and all, and suddenly you realize you're not able to mask ventilate and your child is now desaturating. What can you do? You tried to intubate, you could not intubate.
Ma'am, I'll put a supraglottic airway device.
Yes, it's very important to know that supraglottic airway devices fit beautifully in a child with a palate. That was the correct answer. That should be your first reflex, and I'm very good you have said. I'm very happy that you have said that. That is a very important point. Okay, now what are the other things that you keep in mind while intubating such a child? What are you expecting will go wrong during direct laryngoscopy, and what do you do to make sure that you can overcome those issues?
Ma'am, the laryngoscope can get stuck in cleft, ma'am. So
what
I'll
do you
pack the cleft with the gauze.
Right, good.
I'll pack the cleft with the gauze piece, ma'am.
Good, good.
And I'll use a straight blade whenever possible, ma'am, so that I'll have more room for my tube to insert.
Are you comfortable with the use of a straight blade in a 6-year-old child?
No, ma'am. If possible, I'll use, ma'am. Otherwise,
it is not advisable. Let me make it very clear. Practically speaking, also, if you're not comfortable with the use of straight blade, it is no longer recommended that you use straight blade in every child. Curved Macintosh blade is equally good. I would suggest that you can even use a video laryngoscope in such children because very often you will see that the larynx is pretty anterior. So if you have the facility of a pediatric video laryngoscope, do go ahead for that. And if you are really stuck in a difficult airway situation, you have just now told us that you can put in a supraglottic airway device, and you should always keep that in mind that you can access the airway by railroading your endotracheal tube through the supraglottic airway device, like an iGel. It's very easy to use, and I have personally used it in very difficult airway situations with good results. But that was before we had a video laryngoscope. Right now, video laryngoscope makes life very easy for us. Right. So you've been able to now access the airway. Next, what? Which kind of a tube will you like to go for, and why?
Ma'am, I'll go for a south-facing oral RA tube, ma'am.
What are the problems with the use of an RA tube? What is the problem with the use of an RA tube?
Ma'am, the RA tube has a fixed curve, ma'am. So it might not be suitably. This may not be adequate for a child. Adequate, or it can be long also for a child.
So let me just put it clearly for everybody, Kirtana. Now the problem that happens is with the preformed tube, with all preformed tubes, is that one size doesn't fit all. Your child may be having a smaller weight for height or vice versa, smaller height for weight. So very often the curve does not lie where it is supposed to. So you may have a tube that's going either to in or to out, right? So you've got to be careful about that. And the second problem that is there is that, as you said before previously, it is very difficult to do suction through a RA tube. So what are the other tubes that are available that you can use in place of an RA South Pole?
Ma'am, flexometallic tube can be used, ma'am.
Okay, which takes care of the problem of a preformed tube. And any other tube that was used previously and very much liked even now by many surgeons and anesthesiologists?
Oxford tube.
Oxford tube, very good. Now, what was the advantage of Oxford tube?
Ma'am, it is an L-shaped tube, ma'am.
What was the advantage of it?
It has the same internal diameter, but the at the patient, machine end, it is thicker.
Right.
So it will not kink resist.
No. No, you started off well, but the internal diameter remains the same, but the outer diameter is tapering, so it fitted beautifully in the child. And the other thing was it had a metal connector which fitted over the Dingman retractor. Now we use a Dingman retractor that Dr. Sangeeta will talk about in her presentation. And the retractor very often tends to block the tube. So this is something that we really worry about all the time. Okay. So that thing was taken care of by the Oxford tube. Now you put in a tube, you fix the tube. What problems are you anticipating with your endotracheal tube now?
Ma'am, the endotracheal tube can get dislodged. It can come out, it can go inside and go endobronchial also.
Why will it go endobronchial?
Ma'am, the surgeon is manipulating. It's a shared airway, and while the placement of
what is more likely to happen, endobronchial or accidental extubation?
Extubation, ma'am. Accidental extubation.
Why?
They will manipulate the Dingman retractor and positioning.
Let's not blame the surgeon so much. Now, what happens is that once you have made the intubated the child, after that you will make a head position. What head position is that for a palate surgery?
Ma'am, neck is hyperextended.
Go for hyperextension. We go for such severe hyperextension that the surgeons classically say that the child's eyes should be facing the wall behind the surgeon, right? So with such severe hyperextension, there is bound to be upward migration, cephalad migration of the tube and very high chances of extubation. Okay. So this is what happens.
I think, ma'am, now there's some loss of connection. Hello, ma'am. How are you?
Hi, Akhilesh. I think Kirtana's got lost. So what I'll do is that
we will connect back in a minute or so. I'll just check now.
Right, no problem. In the meanwhile, I'll keep talking about this case only. So this is very important to remember that we have very high chance of accidental extubation in these children, and this must be kept in mind. Now, apart from that, as she very correctly said, there is sharing of the airway, and because of that, the surgeon can push the tube either in or move it out. So intraoperatively, you've got to keep seeing two things. One is your airway pressure, because very often by pressure of the Dingman retractor itself can lead to occlusion of the tube. Keep a very close watch on your airway pressure. And the other thing is your EtCO2. The EtCO2 is a much quicker estimate, faster estimate of anything that's going wrong. The hypoxia and the fall in saturation will come much, much later. So we've got to keep that in mind. Then intraoperatively, you suddenly can land up with a desaturating situation. So you quickly look into that, you stop the surgery, you make sure that there is adequate suctioning happening. And even before you allow the surgeon to proceed, they should have a pack in place, a oropharyngeal pack in place, because as we said, there's sharing of the airway, there is going to be blood loss, and there is going to be chances of aspiration of the blood if you are not careful. So that is what we keep in mind intraoperatively. Now, other things that we have to really be careful about intraoperatively is that what are we using? Are we using opioids or are we using inhalational agent? Now, both have their advantages and disadvantages. With an inhalational agent, you have the flexibility of being able to titrate the depth much faster. But with the opioid-based anesthesia, you have the advantage that the child will not have a difficult or a rocky extubation. Now, we all know that most inhalational agents are associated with emergence delirium. The children are often agitated. There's higher chances of laryngospasm and bronchospasm with inhalational agents. So personally speaking, I prefer an opioid-based intraoperative anesthesia. And one particular drug that I absolutely have become a fan of, and I think some of you might agree with me, is the use of dexmedetomidine. Now, dexmedetomidine gives us some very specific advantages. It has a very good analgesic. It's a very good sedative. It is a local vasoconstrictor, so the field is amazing. The surgeon says that sometimes, you know, they're so happy with the field, and there is very little blood loss. And what do we want at the end of the surgery? We want a child who is absolutely pain-free, calm, sedated, and with absolutely intact reflexes, because it's an airway surgery. We want the child not to aspirate. So dexmedetomidine gives us all these advantages. So I recommend use of that intraoperatively. I'm very happy with the use of dexmed, and this can come as, you know, in the exam as what is new with cleft palate surgery. Right. So this is something that we can do.
Ma'am, my connection got lost, ma'am. I'm back, ma'am, but the video is not working, ma'am.
Okay, no problem. Kirtana, I took over while you were there. So Kirtana, if you can just tell me what are the intraoperative concerns in such a child, I'd be happy to. I talked about, we've talked about the use of ATR and the problem of accidental dislodgement or endobronchial intubation. Apart from that, can you tell me something else?
Ma'am, hypothermia.
Very good, hypothermia. So your child should always be well covered. Now, supposing if you're careless, Kirtana, and your child does become hypothermic, why are you so worried about hypothermia? What can go wrong?
Ma'am, the child can, there can be excessive bleeding. The child, when I'm trying to reverse the child, there can be delayed reversal and emergence, ma'am.
Very good. Very good. So we don't want this kind. They can be hypoxia, they can be acidosis, they can be impaired platelet function because of hypothermia, leading to coagulation impairment and excessive bleeding. So you've got to make sure that your child is warm throughout the surgery. Now, when you're looking at extubation, what are you looking at? What is your aim of extubation?
Ma'am, before I'll extubate the child when the child is fully awake, ma'am.
A fully awake child cries a lot.
Yes, ma'am, but I'd like to have the airway reflexes intact. So I'll extubate the child fully awake, ma'am.
So what do you make sure? What do you do to make sure your child is awake, but not crying?
Ma'am, I'll provide adequate analgesia, ma'am. In intraoperative period, I'll give 1 microgram per kg of fentanyl, and before extubation, I'll put paracetamol suppository, ma'am, 40 mg per kg.
Why do you want to give a paracetamol suppository child in a 6-year-old bacha? Why do you want to give a suppository? Do you have no other route available? And you will give only 1 to 2 mic.
Also, I can give.
No, you will give only 1 or 2 mic per kg of fentanyl. That's all throughout the period. Surgery takes almost 2 hours.
No, 1 mics per kg per hour, ma'am. I'll give.
Per hour?
Yes, ma'am.
As an infusion?
No, ma'am, as bolus doses, ma'am.
No, you should give 2 mics per kg in the beginning. That is the dose. In children, 2 to 3 mics per kg fentanyl is the dose. After that, you're supposed to repeat every half an hour, because what is the duration of action of fentanyl? Is it 1 hour or is it lesser?
30 to 45 minutes, ma'am.
Yeah, so you give the top-up dose before the action is over,
Yes,
right?
yes, ma'am.
So you will give that intraoperable. And why do you want to give paracetamol suppository? We have such wonderful preparations of IV paracetamol.
IV, yes, ma'am.
You should go for IV paracetamol. Can you use diclofenac in this child?
Ma'am?
Can you use diclofenac in this child? Diclofenac sodium?
Diclofenac, yes, ma'am, it can be used, ma'am.
You can use that. So why are you going for suppository which has ambiguous action? Suppository doesn't work in every child, and it's not recommended in older children. Okay, so you need to give a very good analgesia. As you very correctly said, you need the child to be awake. The child should have reflexes, good reflexes. And I just spoke when you were away was that dexmedetomidine really helps us with this kind of extubation protocol. You should use arm binders to make sure that the
we
child
have 5 more minutes, ma'am.
I'm done. I'm concluding now. So you should use arm binders to make sure that the child doesn't pull at his sutures. Child should not cry, should be absolutely comfortable. Should you advise oxygen in the post-operative period?
Yes, ma'am, I'll advise humidified oxygen in the post-op.
For how long?
Ma'am.
For how long?
Ma'am, 2 hours, ma'am.
The post-op period becomes very important in this child. Are you anticipating any problem in the post-operative period in a child who has had a cleft palate repair?
Ma'am, in the post-operative period also, there can be airway edema, which can lead to obstruction, and there can be residual bleeding, which might irritate the larynx and can cause laryngospasm.
Very good, very good. And very important, Dr. Kirtana, is that sometimes what happens is that in children, you know that we have a large tongue. And now the huge cleft that was there is now sealed and repaired, and the child is no longer able to accommodate that huge tongue. The space gets reduced. And if very often there is glossoptosis, which is a posterior attachment of the tongue. Now this child has to now adjust within that smaller space in the oral cavity, and there may often be airway obstruction because of this. So you ensure that the child is nursed in the lateral or the prone position. Keep a very high index for airway obstruction, which may be due to, as you said, either the airway edema, the surgery itself, or bleeding leading to laryngospasm. Keep a very strong and suspicion and a close watch for any post-operative bleeding. The oxygenation should ideally continue for at least 12 hours. The patient should be under observation for at least 24 hours. Once the child is comfortable, awake, and pain-free, you can start oral fluids, and that has to be given also very carefully so that there is no injury to the surgical repair done. So I think we have covered the whole course of the surgery now. Dr. Akhilesh, I think we are done here.
Yes.
I would be happy.
There are few questions, ma'am, from the delegates. Yeah. It says that is it necessary to get pediatric referral to rule out congenital anomaly in every case, like the child is 6-year-old with no past complaint and no finding in examination? So is it necessary to get the pediatric?
I'm so happy with whoever has asked this question, because you see, this is a problem that we face all the time. Like you ask for a referral and the surgeon says, there is nothing clinically, why do you want it? Now, see, the reason for why I would say it is advisable to get a pediatric referral done is that we live in times where we have medical legal issues, and we are not experts as anesthesiologists. We are not physicians. We cannot claim ourselves to be pediatric physicians. So to be medical legally correct, it is right that a specialist should go for, we should go for a specialist referral, because this is a particular condition where there is a very, very high incidence of associated congenital anomalies. Like if it was a hernia where I know that probably there is nothing, or a lipoma, I'm not asking for congenital anomalies ruling out in that patient, but this is a patient where I may miss out because I'm not a specialist. 1 and 2, for medical legal, from the medical legal point of view, it is always advisable to go for a pediatric medicine referral. This is the institutional practice in my institute. Of course, you will have to follow yours, and you can discuss with your seniors regarding.
We also get the pediatric physician referral done, mostly in the cleft palate. We always get.
Yes, it is always wiser.
One thing asking: can we do nasal intubation in cleft palate?
why do you want to do nasal intubation in a small child? Now, why it is for a palate, it makes absolutely no sense, my dear child, because they are going to be operating right there.
Right.
You will be blocking the surgical field.
Surgical view. One is asking, what is Logan's bow?
What is?
Logan's bow.
I didn't get that correctly. Can you just write it down for me?
One thing more, ma'am. They say, do we have to follow HP of 10 only, or just in the cleft palate we require 10?
Now, in my institution, and I think Akhilesh, in your institution also, we follow for every patient, irrespective of whether it is a pediatric or an adult patient, that we must have a minimal HP of 10. Now, I'm again very happy whoever has asked this question, because this is my favorite question in the exam. Now, you would wonder why we follow 10, because 10 is anemia for, say, an adult male or an adult female, but we are happy with taking an anemic patient. But why 10? Why not 11? Why not 9? Now, the reason for that is that if you look at the dynamics of oxygen delivery to the tissues, there is a very interesting interplay between viscosity of the blood and the oxygen delivery to the tissues. Now, why is there a problem in polycythemia? The problem happens in polycythemia is that because of the increase in the hemoglobin, the blood becomes so viscous that it reaches the tissue slowly. If the blood has a lower hemoglobin, the blood is less viscous and the flow is faster, and there is a faster delivery to the tissues. So these two things go in an opposite manner. If you draw a curve between a graph between oxygen delivery to the tissues and the hemoglobin concentration, it is a bell-shaped curve. And the point where you have maximum delivery of oxygen to the tissues vis-a-vis the hemoglobin concentration, that value is the optimal hematocrit, that is 30, which correlates with the hemoglobin of 10. That is why we follow a rule of 10 in anesthesia for every patient. We know that this is the hematocrit at which we have maximum oxygen delivery. And we know that intraoperatively, I hope you all know that 21% oxygen is not sufficient. We need at least 33% 30 to 33% oxygen is the minimal requirement that the patient has under anesthesia. So to make up for that, we ensure that the patient has at least 10 gram hemoglobin. Great question. Thank you for asking.
Many of them are asking, isn't it safe to get basic investigations like chest X-ray, LFT, KFT? So if they speak that, so will it be okay in the exams or not?
No, it is not okay. There is nothing, you have to be safe, but you cannot just, use resources, such expensive and such precious resources in every patient. Even hemoglobin, it is not expected for a child to have, even now the recommendations, they say that you don't need to get hemoglobin in every patient. I'm following in my institution, but I'm hoping that in few years we are able to, cut that down too. You're wasting resources. You are giving unnecessary pricks to a child. There is a very established entity called needle phobia in children. It causes trauma in a child. Why do you want that? And what are you going to gain from that? Why do you want a child? Why do you want to look for a deranged liver function? If clinically your child is fine, we don't expect any problem in that child. And X-ray, you should not at all, because you're exposing a young child to unnecessary radiation exposure. It's not at all advisable. So your minimal investigations are a hemogram, a urine routine microscopy, and a BTCT. We don't go beyond that. I'll tell you why, because BTCT in a young child who hasn't had, trauma, exposure to trauma and all, that is a basic way to rule out any congenital hemoglobinopathies, which may be leading to coagulation malformations. A urine routine microscopy gives you a good, fair idea of any underlying renal or, multi-system issues. So that's a good screening method. These are screening methods. If you find some anomaly in the history, in the examination, then do go ahead. But if you're not finding anything, please do not say all this. It is not liked. We don't appreciate it.
Someone is asking if we say that it is our institutional protocol, because in our institute, we get it done for every patient. So will it be considered okay?
Yes, you can. That will give you a blanket. You can say that even though it is not part of the recommendations, but it's our institutional practice protocol and we have been following it. Yes, and as an examiner, I would accept that. One thing that you all must know is that here we are not seeing how brilliant you are as an anesthesiologist. what we are seeing as an examiner is that, are you a safe anesthesiologist? When I'm sending you out in the field as a qualified anesthesiologist, are you safe in your practice? So that is going to be and that is going to be the concern of almost every examiner who comes to you.
Fine. Thank you so much, ma'am. And
Can I just saw one thing, and I'm so sorry, at least just one point. So somebody wants to ask about suprazygomatic block for pain relief. Any experience? I have been using infraorbital block for pain management for cleft lip. It is wonderful. It really gives excellent analgesia. And I have been using sphenopalatine nerve block for cleft palate surgeries. Again, these two are the things that I did not talk about in the case. And people should look it up, read it up, and it's an important part of multimodal analysis.
Sphenopalatine you give by putting the plagets in the nostril?
Yes. We use that. And we have this spray bottle of xylocaine that we use for our Sago technique for fiber optic. Even that has a nice long nozzle that goes if the child has a large enough nostril. So, we can use that too. So
thank you so much.
Just wanted to add that, Akhilesh, even though you're very short of time.
No, thank you, ma'am. Can we ask Dr. Sangeeta to please start with her presentation?
Good afternoon, all. Now, very briefly, let's summarize cleft lip and palate. This is the most common congenital anomaly, the cleft lip, with or without palate. Asians, they are more common. Boys are more affected than girls, but isolated cleft palate is more common in girls. Unilateral clefts are more common than bilateral, and left-sided are more common. There are various genetic and environmental association. Various chromosomes has been found to be associated with the cleft lip palate. And various risk factors are maternal smoking, alcohol, poor nutrition, viral infection, diabetes, various drugs like anticonvulsant, retinoid, systemic steroid, teratogenic agents. Very briefly about the cleft, it can be cleft lip, can be unilateral or bilateral, can be complete or incomplete. Incomplete when the nostril is not involved, and complete when the nostril is involved. About the cleft, it can be prepalatal or the postpalatal. Prepalatal is primary or postpalatal is the secondary, depending upon the location of the incisive foramen. Again, it can be unilateral or bilateral. This is the picture of which we have already talked. Briefly about the embryology, clefting of the lip and nostril occur because of the failure of the nasomedial process to merge with the maxillary prominence, and failure of the two nasomedial process to merge cause rare cleft lip or bifid nose. Palatal cleft occur when there is a hypoplasia of the palatal shelf and there is a mismatching or mistiming of the two palatal shelf to come close and meet in the midline. This anomalies is found to be associated various number of syndromes. We always kept in mind. An examiner can ask you to name the few. The most common one are Pierre-Robin syndrome, Teacher-Collins syndrome, Down syndrome, Golden Heart syndrome. And ventral anomalies also been found to be associated with this, like vertebral anomaly in atresia, cardiovascular, tracheoesophageal fistula, esophageal atresia, renal or radial abnormality or limb abnormalities. You should know the Pierre-Robin syndrome is the most common syndrome associated with the cleft palate. And you should know the clinical symptoms, sign and features of these various syndromes. Examiner can ask how can you differentiate between all other congenital syndromes. Now, next important question is the timing, which we have already discussed in the Viva. Earlier, the rule of 10 was followed in the cleft lip and palate. Now, the repair done early. Cleft lip usually repair at 2 to 3 months of age, and cleft palate 6 to 10 months. And later on, the corrective surgery they can done in the later age group, like palatal revision or alveolar bone graft.
occur at 10 year, rhinoplasty, maxillary, osteotomy, repair at 17 year. Now, what are the concerns? Briefly, like the pediatric patient, associated various congenital anomalies, cardiac anomalies. In the syndromes, we can have chronic airway obstruction, sleep apnea, right ventricular hypertrophy, cole pulmonale due to chronic hypoxia, anticipated difficulty airway. Child can have respiratory infection, and very important, these children are malnourished, dehydrated, anemic. So always we have to go for the cross matching of the blood. Psychological aspect can be present in the older children, depression because of the disfigurement and difficulty in the speech. Pre-operative preparation, we should go for complete medical evaluation. Special attention should to rule out the congenital anomalies and syndrome. Potential airway difficulties, like in various syndrome we have already discussed. Cleft palate, patients, they have recurrent ear infections. So patient can have eustachian tube dysfunction, chronic otitis with clear rhinorrhea. So all these infections should be resolved before the surgery. And pre-operative sedation we can give if we don't anticipate in the difficulty in airway. But whenever we have in doubt or we are anticipating the difficult airway, so we should avoid the sedation. Difficult laryngoscopy, Cormack-Lehane grade 3 and 4, they are found to be more with the bilateral clefts and more with the congenital associated anomaly and with the retrognathia. Pre-op monitoring in the small children, precordial stethoscope is very important because we simultaneously heard the heart and breath sounds. Others are ECG, pulse oximetry, capnometry, and IBP, temperature, peripheral nerve stimulator if available. Apart from the routine induction, in the children, usually preferred is the inhalational induction. But if we have the IV line in C2, we can go with the IV induction. Difficult mask ventilation is associated with craniofacial anomalies and retrognathia. If we anticipate the difficult laryngoscopy, so as madam already discussed, what are the other plan? We can go for fiber optic bronchoscopy, ILMA, supraglottic device, video laryngoscope is very important nowadays. Can be about the secondary plans if we anticipate the difficult laryngoscopy. And we always should take care of the extensive cleft because sometime during the bag and mask ventilation, tongue will fall into the cleft and will lead to the airway obstruction. So always look for that. Proper caring of the eyes, padding, positioning of patient and circuit should be done. The different tubes we have already discussed. The most commonly used tubes are RAE tube, south facing. Other can be flexometallic and Oxford. And positioning and fixing of the tube is very important. It is always in the midline for the symmetry and it should be properly secured to prevent the displacement. Now position after induction, positioning next step is very important. Positioning is the hyper extended head. So at this time, accidental extubation is very common. So always be very vigilant at this positioning of the child during surgery. This we discussed, it is exaggerated extension of the neck, accidental extubation can occur. Next step is the placement of Digman mouth gag. This is also a very important step for us and we should be very vigilant while the surgeon puts the mouth gag. And the placement of pharyngeal pack. At all these points, tube compression and kinking can occur. So we should be very vigilant and should monitor the EtCO2 airway pressure and auscultation of the bilateral entry. This is the picture of Digman mouth gag and while the intraoperative. So always very careful for the tube compression. Maintenance of anesthesia done usually with the gas, oxygen, suitable inhalational agent, short-acting muscle relaxant, and artificial ventilation. Intraoperatively, always maintain the temperature, especially in children. Fluid replacement should be done, and analgesia should be covered. For analgesia, we can go for pharmacological method and regional block. We can give short-acting opioid, IV paracetamol, NSAIDs because child is in older children's. We can go for peri-incisional local infiltration. Blocks can be given for cleft lip infraorbital block, and for cleft palate bilateral palatine nerve blocks can be given. Post-operative concerns. The major concern in this surgery, because it's a airway surgery, so child can have post-airway obstruction or edema or the bleeding. So now intraoperative steroid dexamethasone should be given to decrease the post-operative edema. At the end of surgery, pharynx should be inspected for any bleeding or presence of any pack. Sometimes we can take a silk suture to the tongue, which allows the rapid opening of the airway. Always place the child in the lateral position so drainage of the blood and secretion can occur. Always extubate the child in fully awake, and when child is regained from the neuromuscular function, it has come out from the blockade. After lip repair, infant should restrain with the arm board to prevent the disruption of sutures. Obstruction can occur because most common cause is the lingual swelling. Why it occurs? If sometime the surgeon, the mouth gag which is put, if it is left for the prolonged period for more than 2 hours, it causes decrease perfusion to the tongue and tongue edema. So intraoperatively, make sure the gag should be removed for reperfusion of the tongue. So this is very important. And constriction, flaps, nasopharyngeal edema. For this, now recommended guidelines, they put the nasopharyngeal airway also preoperatively, and that can be left for 48 hours to prevent the airway obstruction postoperatively. Bleeding can occur, which may require re-exploration, and in severe cases, the blood transfusion can be required. This is the management, the silk suture in the tongue and nasopharyngeal airway for the prevention of the obstruction. Very briefly about the assessment of the pediatric airway in a small children. It is very difficult because child is unable to cooperate. We should thoroughly take the history and examination only to assess the airway. Child's medical history, like detail of the birth, subsequent developmental history, previous respiratory illness, any injury or surgical procedure, complications occurring during previous anesthesia, respiration, feeding, phonation, cough, cry, noisy breathing indicate the abnormalities within the airway. Enlarged adenoid tonsils, history of cessation of breathing or excessive daytime somnolence. In examination, we should see the general appearance, characteristic of face, failure to thrive, obstructive sleep disorder breathing, adenoid hypertrophy, nasal flaring suggests respiratory distress, mouth breathing occurring in enlarged tonsils and adenoids, congenital abnormalities, dysmorphic features should be noted, mandibular hypoplasia, small mouth, limited mouth opening should be noted, spontaneous mid-inspiratory pharyngeal airway obstruction, and snoring in the infants with the micrognathia. Patency of nasal aperture should be assessed. Amount of the nature, amount and color of the discharge should be noted. Examination of any neck deformity, limited mobility of the cervical spine, cervical lymphadenopathy, shape of the chest should be observed, noting the frequency and depth of respiration, chest expansion, mode of breathing, presence of any chest recession. Deviation of trachea should be done by palpation and auscultation. We can rule out any infection, bronchial asthma in a child. Thank you.
Thank you, Dr. Thank you, Dr. Aarti ma'am. Before moving on to the next, we have 1 minute I'll give you for seeing the quiz, which we could not put at the lunch break. So you'll have 2 minutes to answer the questions. Please put your questions in the answers in the chat box. Thank you, Dr. Bharti ma'am, and thank you, Dr. Sangeeta, for a lovely session. I hope the PG students must have gained a lot from the session. Thank you, ma'am. Thank you so much.
Thank you so much, Anupma. And thank you, Dr. Akhilesh.
Thank you, ma'am. Thank you, ma'am. Moving on to the next session, we have the next session on, it's a lecture on anesthesia for squint surgeries and penetrating globe injuries. The moderator, the chairperson for the session is Dr. Manoj Bhardwaj. Yusuf, can you put the slide? Yusuf, can you put the slide? Dr. Akhil Agrawal is logged in. Dr. Manoj Bhardwaj is a senior consultant in Rajiv Gandhi Cancer Institute. Yusuf, can we have the presentation? Dr. Akhil?
Hi, Dr. Anupma.
Hello, hi, Dr. Akhil, sir. So, we'll be starting. Dr. Manoj Bhardwaj. Sir is a Sir is a senior consultant in the Department of Anesthesia, Rajiv Gandhi Cancer Institute.
मिल जाएगा नहीं जाएगा मेल कैसे पता लगेगा ये तो मेरे WhatsApp में आया था
Next, Dr. Akhil Bhardwaj, slide please. Dr. Akhil. I think we can start with the recording. Yusuf, can you start Dr. Akhil's recording?
Good afternoon, everyone. At the onset, I would wish to convey my regards to the organizing committee for giving me this opportunity to speak in this gathering. And without wasting time, I will take you to my topic, which is anesthesia for strabismus surgery and penetrating globe surgery. Strabismus occurs in 3 to 5% children worldwide, and the surgery is the most common pediatric eye surgery. In adults, the incidence is much less. Orthotropic alignment occurs by 1 month of age, and visual development is over within first 7 to 8 years of life. Strabismus basically is misalignment of eye or eyes resulting from an imbalance of extraocular muscles. In children, The brain has the ability to suppress the image from weaker eye, and this results in amblyopia. This amblyopia is totally correctable if surgery is done at earlier stage, but if left untreated, then the damage is permanent. In adults, since the brain cannot suppress the image from the weaker eye, the result is in diplopia. It can affect one or both the eyes, and depending on the direction of deviation, it is classified as exotropia, esotropia, hypertropia, or hypotropia. This deviation may be intermittent or permanent, and depending on the degree of deviation, it is called as large angle or small angle strabismus. Patients usually present with diplopia, loss of stereopsis, that is 3D vision, headache, inability to read comfortably, fatigue when reading, and amblyopia. There are many risk factors associated with strabismus, but from anesthesia point of view, syndrome with craniofacial dysostosis is the most common risk factor and the most important one for giving anesthesia. It is called congenital when the onset of presentation is less than 6 months of age, and it can happen in a normal child or a child which is associated with syndromes or developmental delays or cerebral palsy. When the onset of presentation is more than 6 months of age, it is called as acquired, and it can be because of accommodant disorders or ocular diseases like tumor and ocular trauma, neurological conditions like cranial nerve palsies, myasthenia gravis, cerebrovascular accidents, Guillain-Barré syndromes, and many myopathies like thyroid myopathy and chronic progressive external ophthalmoplegy myopathy. For bringing you to your anatomy classes, we will be discussing the anatomy related only to the anesthesia for eye, and we all know that the movement of globe is controlled by 6 extraocular muscles. Medial and lateral rectus causes horizontal movements, superior and inferior rectus causes vertical movements, and superior and inferior oblique causes torsional movements. These rectus muscles, they arise from the annulus of Zinn near the apex of the orbit, and they are inserted on the outer surface of globe anterior to the equator. They form the semi-cone or an incomplete cone. Superior, medial, inferior rectus and the inferior oblique are innervated by the 3rd nerve, superior oblique by 4th nerve, and lateral rectus by 6th nerve. Nasociliary nerve is the main sensory nerve which supplies to the cornea and perilimbal and supranasal quadrant of conjunctiva, and rest of the conjunctiva is supplied by lacrimal and the frontal lobes. As far as treatment options are concerned, there are many treatment options available, and they depend on the time of presentation, age of the child, and the degree of deviation. So optical aids are given to those children who are present early with minimal deviation, and they can use optical lens, prisms, or patching of the dominant eye. Sometimes injections like botulinum toxins or bupivacaine can be given in extraocular muscles. Botulinum toxin is given into the strong muscle and it paralyzes this muscle, whereas bupivacaine is given in the weaker muscle and it causes the necrosis and resultant hypertrophy of that weak muscle and makes it stronger. Then there is conventional strabismus surgery, where there is recession which is strengthening, recession which is weakening, transposition where you take out the muscle and fix it to the other spot, either the Fidens operations. Adjustable suture strabismus surgery is a 2-stage surgery where the first stage is done under GA or the block, and you just leave a adjustable suture in the extraocular muscles. Once the patient and the eye are out of anesthesia, then you do a reassessment and then you adjust the suture according to the degree of deviation. This is done under topical anesthesia. Nowadays, mini tenotomy and mini plications are also done, which are very popular among the ophthalmologists. As we have already discussed, the timing should be as soon as possible, ideally within the first 10 months of age. And if it is not done within first 7 to 8 years of life, then the reason for surgery is primarily cosmetic. Coming to the anesthetic considerations. Since most of the patients are children, then you should always inquire about upper respiratory tract infections, prematurity and associated complications, developmental delays, cerebral palsies, and congenital syndromes. There is a whole list of congenital syndromes which is associated with strabismus, and many of them are associated with craniofacial and cardiac abnormalities. For adult onset strabismus, you should always evaluate the thyroid functions, bleeding disorders, and anticoagulants. Because the adults are mostly taken for surgery under block, therefore use of anticoagulants is to be ruled out before giving the erythrobulbar or any other block. For thyroid eye disease patients, the surgery should be delayed till the patient is euthyroid and the eye disease is stable for at least 6 months. Routine perioperative investigations are not required. Specific investigations as per the patient's comorbidities is to be done. All those children who are syndromics and are associated with congenital cardiac abnormalities, an echocardia is must. And MRI should be done in those patients who come with an atypical presentations like acute onset or swollen optic disc or cranial nerve 6 palsies to rule out the intracranial pathologies. Earlier, it was believed that strabismus is a risk factor for malignant hyperthermia, but now it has been found that incidence of malignant hyperthermia is not it's not increased in strabismus surgery even on the use of volatile anesthetic agents. You should always inquire about the intake of drugs like ecothiopate because they reduces the plasma cholinesterase level, and if patient is taking these drugs or installing these eye drops, then there could be an increased duration of action of succinylcholine. Coming to intraoperative considerations, surgeons are very fond of using topical vasoconstrictors for eye surgery like epaclonidine or phenylephrine. And if you give an incision into the pool of these vasoconstrictors or you apply these vasoconstrictors directly over any raw surface, then you can have a raised blood pressure, arrhythmias, pulmonary edemas, and cerebrovascular accidents. Phenylephrine can also dilate the pupil and can affect your strabismus surgery. There are a few very important reflexes associated with this surgery, and you should take all of them. So first we come to oculocardiac reflex. It is also known as Eschenor-Dejany reflex, and it was first described by these two guys in year 1908. It is actually defined as a more than 20% decrease in heart rate from baseline or the presence of arrhythmias which are induced by either pressure on the globe or traction of the extraocular muscles. It leads to sinus bradycardia, AV block, complete heart block, ventricular ectopics, ventricular fibrillation, even systole. So basically it can lead to any kind of arrhythmia. Symptoms are generally mild and transient, and once you leave the eyeball or you decrease the pressure, it should return back to the baseline as soon as in minimum seconds. Classical triad is of bradycardia, nausea, and syncope, and it is very common in children. The afferent fibers are through the long and short ciliary nerves, which travels through trigeminal nerve to the Gazinian ganglion and to the nucleus of trigeminal vagus. The efferent pathways through the vagal fibers, it leads to increase in parasympathetic tone and leads to bradycardia. So any of these things will lead to the activation of oculocardiac reflex, like pressure on eyeball, traction of extraocular muscles, conjunctiva or periosteum or orbital structures, orbital trauma, hematoma, manipulation of globe, force reduction test we will take later on. You see the retrobulbar block. So how does retrobulbar block leads to oculocardiac reflexes? That when you instill a lot of local anesthetic behind the globe, it can cause pressure on the globe and can lead to oculocardiac reflex. Hypercarbia, hypoxia, acidosis, light anesthesia plane, and use of opioids can increase the chances of oculocardiac reflex. If you use sevoflurane, it is safer as compared to halothane, and use of pancuronium is safer as compared to other non-depolarizing muscle relaxants as far as oculocardiac reflex is concerned. How do you prevent it? So you should ask your surgeon to avoid giving acute tractions, and gradual tractions are more easily tolerated by the patient. If you are able to give a proper retrobulbar block, it can inhibit the afferent link and will reduce the incidence of oculocardiac reflex. IV pre-medication with atropine and glycopyrrolate 30 minutes before surgery can also help. But if you give an atropine or glycopyrrolate in IM doses, like you usually do in children, then it will not affect the reflex. Deep plane of anesthesia, hypoventilation, hypercarbia, and avoidance of opioids will also help. So what if it happens even after you did everything to prevent the oculocardiac reflex? Step 1, stop manipulation. Inform your surgeon that there is a bradycardia happening. Ask him to reduce the pressure or leave the extraocular muscle. The heart rate and heart rhythm should return to baseline within 20 seconds. Ensure proper oxygenation, ventilation, and depth of anesthesia. If it is not returning back to normal, you can use atropine or glycopyrrolate, but glycopyrrolate will take 3 to 4 minutes to act. In case of recurrent episodes of oculocardiac reflex, you should infiltrate the rectus muscles with local anesthetic solutions. Especially with retrobulbar block, if there is a hemorrhage which is not visualized or which is not appreciated at the time of giving block, it can lead to continuous hemorrhage behind the globe in the orbit. And after some time, say after 1 to 1.5 hours, this continuous hemorrhage can be significant enough to cause pressure on the eyeball and can cause oculocardiac reflex after 1.5 hours of surgery. So if you are giving a retrobulbar block, you should observe these patients for a possible oculocardiac reflex at least till the effect of local anesthetic is weaned off. Coming to the next reflex, which is oculorespiratory reflex. It comprises of bradypnea, hypercarbia, and respiratory arrest. It is also precipitated by traction on extraocular muscles, and sevoflurane is safer as compared to halothane. Atropine glycopyrrolate unfortunately has no effect on ocular respiratory reflex, and retrobulbar block is the only thing which can abolish it if it happens. Coming to the force junction test. Sometimes surgeons clip the limbus with forceps and try to move the eyeball in all the directions to detect any restrictions in eye movement. They are primarily trying to identify the etiology, whether there is a restrictive etiology or there is a neuropathy etiology for strabismus. So important point to remember is that if you have asked your surgeon and if he has said that he is going to do a force junction test, then do not give succinylcholine. Why? Because those skeletal muscles, they come out of the effect of succinylcholine after 4 to 5 minutes. But extraocular muscles can have a sustained contraction till 20 minutes after the dose of succinylcholine, and therefore they can interfere with the interpretation of force junction test. There is no need of antibiotic prophylaxis for strabismus surgery, and primarily because all the ophthalmic procedures are considered to be sterile, except for nasolacrimal duct surgery. Coming to choice of anesthesia technique, so you can take the patient in general anesthesia, regional anesthesia, or topical anesthesia. General anesthesia is most commonly used technique because most of the times the surgery is done for children, and it is suitable for not only for children, even for adults, and for complicated or repeated surgeries or bilateral eye procedures. In children, we usually prefer inhalation induction with sevoflurane, and if you are maintaining the anesthesia with propofol, it will help you in reducing emergence, agitation, and post-operative nausea vomiting. But the chances of oculocardiac reflexes are lesser with inhalation agents as compared to propofol. You have to keep this in mind while choosing the anesthesia technique. Airway can be secured either with laryngeal mask airway or any supraglottic device or with an endotracheal tube. But if you're using a supraglottic airway device, you have to remember that assisted or controlled ventilation is the preferred mode over the spontaneous ventilation. Because if you choose a spontaneous ventilation, then spontaneous ventilation along with the additive effect of volatile anesthetic agent can lead to oculo-respiratory effect, and oculo-respiratory reflex can lead to oculocardiac reflex. Regional anesthesia is primary anesthetic technique for adults and can be used to supplement general anesthesia for children. Advantages definitely are reduced incidence of OCR in emergence agitation, also better post-operative analgesia and decreased post-operative nausea and vomiting. But large volumes of local anesthetics, if used, can distort the anatomy and can lead to difficulty in the strabismus surgery. Like all the regional blocks, absolute contraindications are hypersensitivity to local anesthetic or orbital infection, and relative contraindications are increased axial length of globe more than 25 mm Hg, 25 mm, presence of scars, thyroid-associated orbitopathy, space-occupying lesions, or bleeding disorders. Let us look at the retrobulbar block, which was the most common block earlier used, and the aim was to inject into the muscle cone. And then you will be able to block 3rd, 4th, and 6th cranial nerves and the ciliary nerves and ganglions. Patient is supposed to be supine in the primary case, that is looking straight up, and the site of injection is lower lid margin just above the point between medial 2/3 and lateral 1/3 of the lower orbital margin. Here you use a special needle known as Atkinson's needle, and you push the needle directly vertically inside, and once you have felt the first pop, then you direct your needle medially and upwards 45 degrees, and you keep on pushing till you feel the second pop. The second pop means you have pierced the muscle cone. Then after negative aspiration, you can inject the local anesthetic solutions. You can use 3 to 4 ml of lidocaine, bupivacaine, or ropivacaine along with epinephrine and hyaluronidase. And there are many complications. Retrobulbar hemorrhage or perforation globe is very common. To avoid this, while pushing the needle, you have to look into the eyeball. You should see that there is no movement of eyeball. There should be no pain. And then optic nerve injury and oculocardiac reflex are also there. There could be trigeminal nerve block or respiratory arrest. If by mistake you inject the local anesthetic directly into the ophthalmic artery, if you are not careful enough to aspirate before injecting, then this forceful injection can cause a retrograde flow towards the brain and can cause instantaneous seizures. If by mistake you inject this local anesthetic solution into the optic nerve sheath, then the local anesthetic can be travel to the CSF and can cause immediate post-retrobulbar block apnea. And the treatment is conservative. You just need to intubate the patient, ventilate the patient, and wait till the effect of local anesthetic is weaned. Peribulbar block is more popular nowadays because this is less traumatic. You inject into the peripalpal space. You do not try to pierce the cone of the muscles, and it produces globe and orbicularis echinacea anesthesia. Same local anesthetic solutions are used, and you use 2 needles. First, you give the lower block, which is the same entry point in the same direction, but instead of directing your needle medially and upwards, you just keep it there and inject. Once the lower lower injection has come into effect, then you take the second needle and you just pierce above the medial angle of eye and direct your needle tangentially away from the globe, and then you inject 3 to 4 ml of local anesthetic solution on both the sides. Since the needle does not penetrate the cone formed by the extraocular muscles, therefore there is less risk of penetration of globe, optic nerve, and artery, and less pain on injections. But this is a slow onset block, takes around 10 minutes to come into action, and there is less echinacea of extraocular muscles. The third block is subtenon's block. Here, there is tenon's fascia surrounds the globe and extraocular muscles, and you give a small cut of around 3 to 4 millimeters in the tenon's fascia just above the inferior fornix, and you raise this subtenon's fascia and you use a blunt catheter to push local anesthetic into this episcleral space. This local anesthetic then spreads circularly around the sclera and the extraocular muscle sheets. Complications are less, but I would say this is technically little more complex, more demanding block, because it needs to pick this tenon's fascia and give an incision on the tenon's fascia. Along with these blocks, sometimes you need to give a facial nerve block to prevent squinting of the eyelids and to allow placement of lid speculum. Many techniques are prescribed or advised, and you should use whatever technique you are more comfortable with for giving a facial nerve block. Sometimes strabismus surgery, especially in adults, can be done even in topical anesthesia, where you use simple topical eye drops, gel, and application of sponges soaked with local anesthetic into superior and inferior fornix for 10 to 15 minutes. But it is suitable only for surgery on medial and lateral rectus muscles, and there is pain and discomfort, especially during traction and detachment of extraocular muscles other than medial and lateral rectus muscles. Coming to complications, we have discussed few of these complications. And slipped muscle and lost muscles are complications when you just lose the muscle into the sheath, or the muscle and sheath are both lost behind the globe, into the globe, behind the eyeball. So if the surgeon is doing this surgery in local anesthetic, local block, or retrobulbar block, then because of slipped muscle or lost muscle, you might need to convert the patient from block into general anesthesia, because exploration of globe cannot be done under block. Post-operative complications are many, but primarily they are surgical complications. For us, oculoemetic reflex is very important. These patients, especially for those patients who undergo surgery for strabismus surgery, are very prone to post-operative nausea and vomiting. The reflex is known as oculoemetic reflex, and it could be early onset within 6 hours of operation, or late onset till 48 hours after operation. How do you prevent this post-operative nausea and vomiting? You can give up ophthalmic regional block, adequate hydration during surgery. You can use propofol or topical local anesthetics and avoid opioids. These all can prevent your post-operative nausea and vomiting. Current recommendation is to use 2 antiemetics together prophylactically, ondansetron plus dexamethasone, for strabismus surgery in children. As far as analgesia is concerned, multimodal analgesia approach should be employed using paracetamol, IV NSAIDs, topical local anesthesia, and avoid opioids as far as possible. So this brings us to the end of our anesthesia for strabismus surgery, and now we will take our next topic, which is penetrating globe surgery. What is ocular trauma? Damage or trauma inflicted to eye by external means, either surface injury or intraocular injuries. Ocular trauma is cause of blindness in about 500,000 people worldwide, and it is the most important cause of unilateral loss of vision. 90% is preventable, more than 50% occurs in patients less than 25 years, and out of them, majority are of pediatric age group. Most common place is home. Male to female ratio is 4:1, and children from lower socioeconomic strata are most commonly affected by ocular perforating globe injuries. If you look at the injury pattern, then today we will be dealing with injuries on the right side of this graph, is this chart, like penetrating injury, foreign bodies, perforating injuries, rupture, or a combination of all of them. So why is this important? So since this is an emergency or urgent surgery, therefore combination of full stomach and an open globe injury presents a unique challenge. There is a risk of aspiration because of full stomach, and any drug or maneuver that increases or raises the intraocular pressure in the injured open eye can cause extrusion of the vitreous humor and can cause permanent visual loss. So what is important is timing of surgery. Though we always believe, we are made to believe that perforating eye injury is an emergency surgery and you have to anesthetize the patient immediately, but it is actually not so. If you discuss with your patient surgeon, many times surgeon is ready to wait for adequate fasting. But how much time is adequate enough for fasting? At least 6 to 8 hours after a solid meal. Time from last meal to injury is more important because sometimes because of alcohol intake or head injuries, the clearance of contents from stomach is very slow after injury. So timing from last meal to injury is more important than absolute time of last meal. Coming to intraocular pressure, it is the pressure exerted by the intraocular contents on the port of eyeball. Normal intraocular pressure is 10 to 21 mmHg. And it is a dynamic equilibrium between the formation and outflow of aqueous humor. We all know aqueous humor is formed from plasma within capillary network of the eye ciliary body in posterior chamber. From there, it is circulated in the entire eye and it is drained through trabecular meshwork in the anterior chamber along with Fontana's spaces and Schlemm's canal. There are certain factors which increases intraocular pressure. If you will look at them, you will find that probably everything what you do in anesthesia will raise to intraocular pressure. So raised arterial pressures, external pressure with using of tight fitting face mask, raised venous pressures like coughing, vomiting, straining, twisted neck vein, tight and ties for endotracheal tube around the neck can increase the intraocular pressure to 30 to 40 mmHg. And here it is important to note that inappropriately applied quiet pressure can also raise the intraocular pressure. Hypoxia, hypercarbia, use of succinylmethonym can raise IOP by 6 to 8 mmHg. Use of ketamine, laryngoscopy and intubation can also raise IOP. Rise tube insertion can also raise IOP by many folds. But how do you decrease IOP? So reduced venous pressure by head up tilt can decrease IOP. If you keep your blood pressure less than 90 mmHg, it can decrease IOP. Hypocarbia, all induction agents except for ketamine, inhalational agents, non-vaporizing muscle relaxant, they can decrease intraocular pressure. And use of drugs like acetazolamide and mannitol can also help. So how do you approach this patient? Proper history, physical examination is must. No laboratory test in routine patients, and you have to rule out other injuries, especially head injuries. If there is a indication that patient might have other associated injuries along with the perforating globe injuries. Of course, you have to ensure NPO status. You can pre-medicate the patient with metoclopramide and ranitidine. And general anesthesia is the preferred technique for open globe injuries, especially for children, uncooperative, and intoxicated patients. Topical anesthesia can also be given, and sometimes retrobulbar peribulbar injection is also given. But if you give a retrobulbar or peribulbar injection, you use a lot of local anesthetic. There is a potential to increase the intraocular pressure because of the volume, and you can squeeze the contents of vitreous humor outside the eyeball. Topical anesthesia with IV sedation can be used, especially when the extent of injury is less and surgeon has to do a minimal repair. Sedative anxiolytics should be given to children because crying can increase the intraocular pressure. So therefore, children might be needed to sedate in their parents' lab. Reoxygenation should be done in a head-up position. Rapid sequence induction should be used if fasting status is not clear, and you should use rocuronium. While using rapid sequence induction, you should be very careful in applying the required pressure. And if you're using LMA, should not be if the fasting status is not clear or it is incomplete, because there will always be a risk of aspiration. To prevent rise in intraocular pressure, you should use gentle face mask. You should try endotracheal tube loosely around the neck, and you can use IV lidocaine and IV remifentanil before intubation to prevent rise of blood pressure and resulting rise in intraocular pressure. Balanced anesthesia using oxygen, air, and inhalational anesthetic agent should be used for maintenance of anesthesia. Try to limit narcotics because post-operative nausea, vomiting can again raise the intraocular pressure. You should maintain head up tilt during ventilation, complete surgery. Try to maintain mild hypocarbia and avoid tachycardia, and target systolic blood pressure should be less than 90 mmHg. Extubation should always be done in deep plane in lateral position, and before extubation, you should empty the stomach with the orogastric tube. And before extubation, you can again give lidocaine or remifentanil to avoid bucking and increase in blood pressure during extubation. Both post-operative nausea, vomiting, and pain should be avoided as far as possible because both of them will lead to increased IOP, and the sutures which surgeon have applied on the perforating part can give away if there is acute rise in intraocular pressure. So for both of them, you should use a multimodal approach. You should do one or more agents like ondansetron, metoclopramide, dexamethasone for anti-MSAs, and analgesia should be given with use of blocks along with paracetamol and NSAIDs. So it looks like that these surgeries are complicated and a lot of things have to be taken care of. But if you stick to your basics, you prepare yourself well, you have evaluated the patient well, then you can take care of your patients very comfortably in both these cases. And thank you for your patient hearing, and I will be ready to take any questions if there are any after this presentation. Thank you very much.
Thank you, Dr. Akhil. So we have a question. What is the minimum dose of atropine for children, for bradycardia in children?
This is a very good question, Anupama. And you see, because the origin of this question is many textbooks, especially pediatric textbooks, have been advising that a minimum dose of 0.1 milligram of atropine is must to treat bradycardia. And a lot of literature has come up nowadays, and it has been found that a minimum dose of 0.01 to 0.02 milligram, which is the normal routine dose of atropine as per the weight, should be the ideal dose. If you give a minimum dose, a fixed minimum dose of 0.1 milligram, then the dose probably would be a much higher dose for many children who are around 5 kgs of weight. So now the concept of minimum dose of 0.1 milligram of atropine for pediatric patient does not hold true.
Thank you so much. We do not have any more questions.
Oh.
Thank Dr. Akhil for the nice presentation. Yes, you want to say something?
No. All right. Just wanted to say thanks to the organizing team for inviting me, and it was a pleasure being a part of this academic activity. Thanks a lot.
Thank you. Thank you so much. So moving on to our next session, we have our next speaker, Dr. Jyoti. Can we have a CV slide, please, Yusuf? So Dr. Jyoti is Associate Professor in our department, BYIMS and Dr. RML Hospital. Her area of interest is transplant anesthesia. Can we have a recording? Dr. Jyoti is logged in. Welcome, Dr. Jyoti.
Thank you.
So let's start with the recording. Thank you, Yusuf.
Good afternoon, everyone. In my presentation, I will discuss about the equipments used for airway management, which includes the oropharyngeal airway, the nasopharyngeal airway, and the supraglottic airway devices. A fundamental responsibility of the anesthesia provider is to maintain a patent airway. It is very well said that effective and timely airway management can avoid cardiorespiratory arrest. The initial airway management include positioning maneuvers, which are head tilt, chin lift, and jaw thrust. When choosing an airway maneuver, be cognizant of possible presence of a cervical spine injury. Airway positioning maneuver help move the tongue and palatal tissue away from the posterior wall of the pharynx, which is needed to open the airway, as you can see in the picture. If these steps do not help in providing adequate ventilation and oxygenation, then an airway adjunct should be used. Airway adjuncts are used to release or bypass an upper airway obstruction. There are two types of airway adjuncts: the oropharyngeal airway and the nasopharyngeal airway. Oropharyngeal airway does this by preventing the tongue from covering the epiglottis, as you can see in the picture how the oropharyngeal airway is preventing the tongue from covering the epiglottis. The oropharyngeal airway was designed by Arthur Goodell. He was an American anesthesiologist, and he is also known for his studies on the uptake and distribution of inhalational anesthetics, as well as defining the various stages of general anesthesia. Oropharyngeal airway come in variety of sizes from infant to adult. The American National Standard specifies that the size of oropharyngeal airways be designated by a number, that is the length in centimeters. Oropharyngeal airways are used to maintain an open airway. They are also used in patients to prevent them from biting and occluding an orotracheal tube. They are also used to protect the tongue from biting. They facilitate oropharyngeal suctioning. Suctioning is much easier if we pass a suction catheter through an oropharyngeal airway. They they provide or they obtain a better mask fit or provide a pathway for inserting devices into the esophagus or pharynx. They can also be used for short-term airway management post-anesthesia. When patient is not maintaining a patent airway, patient may be sedated. The oropharyngeal airways are contraindicated if patient can cough. It means the patient still have reflexes and they will not tolerate a oral airway well. If a foreign body is obstructing the airway, then the oropharyngeal airway should be avoided as they can further push the foreign body in. Patients with nasal fracture, the oral airways or a nasal airway should not be put in. And actively bleeding nose or oral cavity, then an oropharyngeal airway should be avoided as they increase the chances of aspiration. The only indication of an oropharyngeal airway is in unconscious people. Now we come to the different types of oropharyngeal airways. The Waters airway. It is made up of metal. There are holes at the side near the distal end used for suctioning. They are no more in use due to its propensity to damage teeth and soft tissue as it is made up of metal, and any foreign material lodged within it cannot be seen as they are not transparent. Bartle-Syracuse endoscopic airway. It was designed to aid fiber optic intubation. It has lateral channels and a central groove on the lingual surface to allow a fibroscope with a tracheal tube to pass. It has a slit in the distal end which allows the fibroscope to be manipulated in the anterior-posterior direction but limits lateral movement. As part of this airway is coming on the lateral side, which will limit the movement of fibroscope. It is made from aluminum. Goodell's airway. You have seen this airway very commonly in operation theaters, and it is the most commonly used airway in operation theaters. It has a large flange, a reinforced bite portion, and a tubular channel. It is available in 9 sizes. Size 000 and 00 are for premature and full-term newborn babies. Size 0, 1 and 2 are for children. Rest are for adults. Burman airway has a center support and open sides. The center support may have openings. There is a flange at the buccal end. The side opening can be opened wider to engage or disengage a tracheal tube. Williams airway intubator. Proximal half is cylindrical, while distal half is open on its lingual surface. Was designed for blind orotracheal intubations. Ovosapien fiber optic intubating airway. It was designed to deliver a fibroscope. It has a flat lingual surface at the buccal end, are 2 vertical side walls. Between the side walls is a pair of guide walls that curve towards each other. Now we come to the Burman intubating pharyngeal airway. It is open on one side so that it can be split and removed from around a tracheal tube. This is the recent advancement in oropharyngeal airways, which you can see on the screen. It provides maximum protection of fiber optic scope. It is used for topical anesthetic optimization. It is easy. It provides an easy side unloading of endotracheal tubes. One side allows a wide range of endotracheal tube insertions, and oxygen deliveries directly to glottic opening is possible with this device. Bite block is placed between the molar teeth. It is intended to prevent the teeth from biting the endotracheal tube or the fiber optic or the suctioning catheters or other devices. How we estimate the size of a oropharyngeal airway is by keeping the upper end at the midpoint of incisors and the distal end at the angle of mandible. Then you get an approximate size of a oropharyngeal airway. Oropharyngeal airways are inserted with its concave side facing the upper lip when the junction of the bite portion and the curved section is near the incisors. The airway is rotated 180 degrees and slipped behind the tongue into the final position. This is one method of inserting the oropharyngeal airway. The other method is also present. The alternative method, in the alternative method, you use a tongue blade to push forward and depress the tongue. The airway is inserted with the concave side toward the tongue. As it is advanced, it is rotated to slide down behind the tongue. Now we come to the nasopharyngeal airways. Nasopharyngeal airway, also known as nasal airway or a nasal trumpet, because of its flared end. The flared end is present, so it prevents the airway from going inside the nose or getting lost inside it. It fixes outside the nostril, the trumpet part or the flared part. Is a flexible rubber tube which goes through the nose and at the base of the tongue. The indications for nasopharyngeal airways are when oral airway placement is difficult or patient is semi-conscious and not tolerating an oral airway. Preferably, it is preferable to use if the patient's teeth are loose or in poor condition, or there is trauma or pathology of the oral cavity. Nasopharyngeal airways are contraindicated if patient is taking any anticoagulant, if basilar skull fracture is present, if there is some pathology, sepsis or deformity of the nose or nasopharynx, and if patient is giving a history of nosebleeds requiring medical treatment, then a nasopharyngeal airway should not be used. The complications associated with the nasopharyngeal airway are airway obstruction, laryngospasm and coughing, trauma, nasal mucosa injury and secondary blood aspiration can also be seen with this. Tissue edema can be seen with this. Ulceration and necrosis if the airway is inserted for a long duration. Central nervous system trauma can also be seen, and the latex allergy. The method of measuring the size of a nasopharyngeal airway is by keeping the nasopharyngeal airway upper end at the lateral edge of the nostril and the distal end at the tragus of the ear. So you get an approximate size of a nasopharyngeal airway. How we insert a nasopharyngeal airway? So first of all, you should lubricate the nasopharyngeal airway with a water-soluble jelly. Insert into the patient nostril along the floor of the nose with a slight twisting action. And before induction, you should assess the patient for the patent nostril, and the airway should be inserted in the most patent nostril. Now we come to the different types of nasopharyngeal airway. The Linder nasopharyngeal airway. It is made up of plastic with a large flange distal and legs the bevel supplied with or with an introducer which has a balloon on its tip that can be inflated and deflated by attaching a syringe to the one-way valve at the other end. Cuffed nasopharyngeal airway. It looks very similar to an endotracheal tube or a cuffed tracheal tube. It is inserted through the nose into the pharynx. The cup is inflated and then is pulled back until resistance is felt. So it becomes stable at its place and it is not like dislodged or can be removed very easily. First we have to deflate the cup, then only it will be removed. Otherwise it can cause trauma if we pull the tube out. The binasal airway. It consists of two nasal airways joined together by an adapter for attachment to the breathing system. It is used to administer anesthesia or to provide CPAP to the babies. Nasoflow nasopharyngeal airway. This is the recent advancement in nasopharyngeal airways. It allows for direct oxygen delivery. It is available with or without respiratory indicators. Optional hydrophobic filter is present. Humidification vent is also present and ventilation adapter is available with the device. You can also connect the device with a ventilator and the device is MRI compatible. Now we come to the supraglottic airway devices. It comprises a vast group of tools designed to provide a means for ventilation, oxygenation, and administration of anesthesia gases. Supraglottic airway devices have rapidly replaced endotracheal intubation and face mask in general anesthesia cases due to their versatility and ease of use. SADs have also been called supraglottic airways and extraglottic or periglottic airway devices. Supraglottic airway devices can be classified based on two main distinctions. The first is the presence or absence of an inflatable cuff. The cuffless device may provide a reduced risk of cuff-related morbidity, but may be associated with increased risk of leaks and failure. A more common employed classification of supraglottic airway devices is the first generation and the second generation supraglottic devices. The first generation devices are simple airway devices. They have low pressure pharyngeal seals, may or may not protect from aspiration, have no specific design to lessen the risk of aspiration. Examples are classic LMA, flexible LMA, laryngeal tube, Cobra perilaryngeal airway, and air cube. The second generation supraglottic airway devices are specifically designed for safety of the patients. They have high pressure pharyngeal seal. They reduce the risk of aspiration, may be more efficacious in ventilation than the first generation supraglottic airway devices. Examples are Proceal LMA, Supreme LMA, iGel, Slipper, Busca mask, LMA, Gastro airway. Supraglottic airway devices are used alternative to tracheal intubations for routine anesthesia. It provides more stability in hemodynamics. The intracranial pressure is more stable with supraglottic airway devices and intraocular pressure is also stable. Supraglottic airway devices have lower incidence of emergence cough and postoperative sore throat, as you have seen more commonly with endotracheal tubes. It can also be used as tracheal intubation aid. We can pass our tracheal tube through the supraglottic airway device. Blind tracheal intubation through supraglottic airway devices can be done. Fiber optic guided tracheal intubation through supraglottic airway devices can also be done. It can also be used as a rescue airway when intubation is difficult, if there is failed intubation, and if you cannot intubate the patient. It can also be used in the resuscitation and pre-hospital airway management. It is also used in tracheal extubation aid. The complications associated with supraglottic airway devices are ventilatory failure when you cannot ventilate the patient with the airway device, and airway injury can also be seen while inserting the airway. You can cause trauma to the palate or soft tissue, and pulmonary aspiration of gastric content is more common with the supraglottic airway devices. If a gastric channel is not present, gastric distension can also be seen with these devices. Whereas when you ventilate the patient, air is also going inside the esophagus and gastric distension is seen. The most impactful complications with supraglottic airway device related to ventilatory failure and aspirations. So classic contraindications include patient factors that increase such risk, such as when the patient is coming full stomach, then they should not be used. When traumatic airway is there, then the supraglottic airway device should not be used, as they can further aggravate the trauma, or they increase the chances of aspiration if the patient is bleeding from that traumatic airway. The insertion techniques of a supraglottic airway devices includes a standard technique when you hold a supraglottic airway in pen holding fashion. The index finger is between the tube and the mask, and you push the airway by using your finger inside the oral cavity. 180-degree technique is used. Then the partial inflation technique can also be used where the supraglottic airway is partially inflated. Where it maintains its shape when it is partially inflated. Thumb insertion technique can also be used to insert the supraglottic airway device. Cuff deflating device. The laryngeal mask is inserted into the device. The cuff is deflated using a syringe. Why we are using this device? As we deflate the cuff by keeping inside this device, the shape of the cuff is maintained. Otherwise, when we deflate the device without using this device, then the shape is not maintained, and the insertion part becomes difficult when the shape is not maintained. Then we come to the different types of supraglottic airway devices. The pharyngeal bulb gasway. Leach introduced the pharyngeal bulb gasway in 1937. This device would stuck in the pharynx by means of an anatomically shaped hollow rubber bulb. It was the first supraglottic device designed. The classic supraglottic airway device. It is composed of an oval-shaped inflatable cuff designed to seal around the larynx. It has two elastic bends to avoid the epiglottis obstructing the passage of air. It is reusable up to 40 times after autoclaving. It presents lower seal pressure and higher incidence of gastric insufflation as seen with this device. LMA unique. It is a single-use version of the classic LMA. It was developed after some studies showed that protein deposition in classical LMA after autoclaving, when it was autoclaved after multiple use, leading to concerns of infectious disease, namely prion disease. LMA flexible. It combines the mask and cuff of the classic LMA with a narrow, long and wire reinforced tube that is flexible. As you can see in the picture, the tube is very flexible. It is folded. Intubating LMA or fast track. It allows for subsequent blind intubation with endotracheal up to size 8 through itself. It can also be used for ventilation just like the other supraglottic airway devices. Overall success rate of intubation through this device is around 96%. LMA ProSeal or PLMA. It provides a better airway seal, having a second posterior cuff allowing for a higher oropharyngeal seal. It is the first supraglottic airway device to allow access to the gastrointestinal tract by means of esophageal drain tube. Then the positioning of this airway device can also be assessed the correct positioning by inserting a esophageal drain tube through it. And if it goes into the stomach and the gastric content is coming out, then it shows that the procedure is properly placed in its place. And it reduces the risk of aspiration because the esophageal drainage tube is inserted through this gastrointestinal tract, the excess. Then the metal introducer, used to facilitate placement of the LMA procedure. The placement of LMA procedure becomes easier when we use a metal introducer. The handle of this introducer is placed, hold it in hands, and then it is pushed along the hard palate and soft palate. LMA Supreme. It is an evolution of PLMA with reinforced cuff preventing folding, narrower curve allowing easier insertion and more stable placement. It is a single-use device. Combi tube combines the feature of an endotracheal and a gastric tube. It is a single-use device, double lumen tube with 2 cups are present. It is designed to be introduced blindly. It is not recommended for general anesthesia procedures, only limited to emergency situations. King laryngeal tube, it composed of a simple airway tube with an oropharyngeal and an esophageal cuff. An opening between the 2 cuffs allowing for the passage of gas into the larynx. It is recommended only for emergencies or failure to intubate and ventilate. Cobra perilaryngeal airway. Tip is shaped like the head of a snake and has a grating allowing for ventilation by avoiding obstruction. Large volume, low pressure pharyngeal cuff just proximal to the tip is present. Streamlined linear of the pharynx airway, slipper. A cuffless device pre-shaped to sit in the pharynx with a heel and a hump to fit the soft palate and the base of the tongue. As a hollow chamber that can store up to 50 ml of drained gastric fluid. iGel is a pre-shaped cuffless device made up of gel-like material which adapts to the anatomic surface after introduction. There is also a channel for insertion of gastric tube. Buska mask has a non-inflatable cuff which is continuous with the airway lumen, allowing for expansion with positive pressure ventilation while also avoiding the problems of cuff over inflation. Gastric reflex high flow suction clearance system is present. AirCure is it is used as an endotracheal tube ramp. Endotracheal tube can be inserted through it into the trachea. It has a detachable 15 mm connector. If we detach a larger size of a tube can be inserted through it. It can be used in the same situation that would apply to other first generation supraglottic airway devices. It is a first generation supraglottic airway device as it doesn't have a gastric channel or a gastric access in it. Total track video laryngeal mask. It is a second generation intubating laryngeal mask with an additional channel for drainage of the gastric contents. Both oxygenation and ventilation may be provided during attempts for tracheal intubation. LMA T-bag oxygen enhancement device is an oxygen enhancement device designed to deliver reliable FiO2 concentrations of 70% at 6 liters per minute and 50% at 3 liters per minute. It holds approximately 300 ml oxygen in its reservoir. No significant rebreathing is seen with this device. Confirmation of respiration through T-bag movement is done. When the bag moves up and down, you can assess that the patient is breathing. It is a single-use device. LMA T-bag plus. It is same enhanced level of oxygenation as the T-bag. FiO2 concentrations of 70% at 6 liters per minute and 50% at 3 liters per minute. Mask and oxygen tubing included in this device for conversion after removal of the laryngeal mask. We can ventilate the patient with mask when we remove the laryngeal mask. Capnography port for use during sedation cases is also present. Visual indication of respiration is also there, as we have discussed earlier. The bag is moving up and down, so we can assess that the patient is breathing. LMA gastro airway. It is a proactive airway. It is used in a proactive airway management for endoscopic procedures. Separate gastric and airway access are present. It is designed to support patient safety. It is a single-use soft and flexible silicone cuff. It has an integrated cuff pilot technology. Cuff pressure indicator is also present. As you can see in the cuff that the red, yellow, and green colors are present, which indicates different pressures of cuff. And it is a very suitable device when we do an endoscopy. Then the airways ventilation is also maintained with this device. LMA protector airway. It is the only laryngeal mask that combines a pharyngeal chamber and dual gastric drainage channels. It is designed specifically to channel gastric content away from the airway. It also have a cuff pilot with indicator or pressure control system. Thank you.
Hello. Yes, we have Dr. Manoj here. Dr. Jyoti, there is a question. What is the role of supraglottic device in COVID era? Would you like to answer that?
Yes, we can use a supraglottic airway device in COVID period also, like when you are intubating a patient, but it should not be used. It should be avoided as patient is like considered most of the time full stomach, and patients are full stomach. So when you are intubating and like you are using the shields and the glasses in COVID period, you are using a PP kit. So fogging is there. And if like you are taking more time to intubate, then you can put a supraglottic device meanwhile. So patient can be ventilated, and finally the patient should be ventilated with a endotracheal tube.
So it's a okay. Before we put an endotracheal tube, Dr. Manoj, sir, can you do you want to add something to this?
Yes.
Sir, can you unmute yourself?
Nice lectures by Dr.
Yes,
Phil and Dr. Jyoti. Just want to add one comment regarding sequence surgery.
Yes, sir.
While providing anesthesia, we should consider high incidence of post-operative nausea vomiting in these patients, and that should be addressed when we start giving anesthesia to the patient. Regarding Dr. Jyoti lecture, I would like to add regarding use of nasopharyngeal airway when we are trying to intubate patient using fibrotic scope. We can introduce nasopharyngeal airway, a split nasopharyngeal airway, and through that we can introduce our scope. It will prevent any injury to the scope due to nasal spurs, and also it will have a tamponade effect in case if there is any bleeding when we are introducing the airway or the tube.
Okay, sir. And one of the delegate is asking Dr. Jyoti, how many times an iGel can be reused? Dr. Jyoti, you have to unmute yourself.
iGel is ideally a single-use device. It should not be used, but we are using it like after autoclaving, we are using it. But ideally, it should be a single-use device.
Okay. Can it be autoclaved? Is it?
No, it can be washed.
It can be washed. Yes. Oropharyngeal airway size is inserted from inside. You take the size from incisor or the corner of the mouth. one of the delegates is asking this question. How do you calculate the size from the incisor or from the corner of the mouth?
From the incisors, the middle of the incisors till the mandible.
So you do want to conclude the session, so your expert comments on that?
Yes. Thank you very much, the organizing team and Dr. Jyoti and Dr. Akhil for your nice talk.
Thank you, sir.
Thank you, sir. It was a pleasure having you. Thank you, Dr. Jyoti. Thank you, Dr. Manoj. So moving to our next session. Before that, we'll be having a set of MCQs for 2 minutes. So you'll have about a minute to answer this. So now please put your answers in the chat box. Moving on to our next session. The chairperson for the next session is Dr. J.P. Sharma. Sir is an additional professor in AIIMS Bhopal. His area of interest is intensive care, acute and chronic pain. Sir, if you are there, you can unmute yourself. The speaker for the session is Dr. Indira Malik. And we have a slide. Dr. Indira Malik. Madam is logged in.
Good evening, ma'am. Yes, ma'am.
Welcome, ma'am.
Thank you.
Ma'am is an assistant professor in anesthesia and PGIMS, Rohtak. Her area of interest is cardiac anesthesia, and she would be speaking on equipment session, laryngoscope, and video laryngoscopes. Can we have the recording, please?
Greetings, esteemed faculty members, respected chairperson, and dear delegates. First of all, I would like to thank the organizers for giving me this opportunity to present this talk on laryngoscopes and video laryngoscopes here. And I hope that the delegates who are appearing for the examinations will benefit from this talk. So how do we define a laryngoscope? A laryngoscope is a device used to view the larynx and adjacent structures, most commonly for the purpose of inserting a tube into the tracheobronchial tree. It can be classified into rigid laryngoscopes and flexible fiber optic endoscopes. Rigid laryngoscopes are the ones which are most commonly used. Now they consist of a handle and a detachable blade with a light source which is energized when the blade and handle are locked in the working position. They can be further divided on the basis of handles which can be long or short and blades which can be curved or straight. Now what are the components of the laryngoscope? The handle. This is the power source for the light by means of disposable or rechargeable batteries. There's a hinged folding or hook-on connection, and the handle is fitted with a hinge pin that fits into a slot on the base of the blade, allowing easy attachment and detachment. Most of the blades form a right angle with the handle when ready for use, but it can be acute or obtuse also, as in the case of the Patil Syracuse blade, with which the blade can be adjusted in 4 positions: 45 degrees, 90 degrees, 135 and 180 degrees. Short handles are also available, which are useful in obese patients, heavy chest and large breasts. Now the blade, this is the rigid component which is inserted into the mouth. It is available in ascending order of size, and disposable blades also are available. Now the parts of the blade, these are the base, the heel, the tongue, flange, web, tip and light source. So what is the base? This is the part which attaches to the handle. It has a slot for engaging the hinge pin of the handle, and the proximal end of the base is called the heel. Now the tongue or the spatula, which is the main shaft which is inserted into the patient's mouth, and it serves to compress and manipulate the patient's tongue and lower jaw. The long axis can be straight or curved, and predominantly the shape of the tongue is determined by the shape of this blade, that is whether it is curved or straight. The flange, it projects off the side of the tongue and it is connected to it by the web. It serves to guide instrumentation and deflect the tissues out of line of vision. And this is the structure that determines the cross-sectional shape of a blade. The tip or the beak, the tip contacts the epiglottis or the avallicula and directly or indirectly elevates the epiglottis. Usually it is blunt and thickened to avoid any trauma. Now the light source. The blade may have a bulb or a fiber optic bundle which transmits the light from a source in the handle. The bulb screws into a socket with a metallic contact commonly located near the tip. A fiber optic illuminated blade has an encased fiber optic bundle which transmits light from a source in the handle or base of the blade. And these are more reliable because due to the absence of a bulb, and cleaning and sterilization are also easier, and they do not get contaminated by the secretions, etc. from the patient's mouth. They stay cooler even if left on for an extended time period, and they have a color-coded mark on the heel. Now here in this diagram, we can see the Macintosh and Miller blades. They have been labeled. So this is the proximal end. This whole structure is the tongue. This part which is projecting out is the flange. Now here you see the web. Okay, here also the web is demonstrated in this vision, and the flange over here. And this is the part which hooks on onto the handle. And this whole thing is the usable length. This is the tip. This is the bulb which is screwed into the socket. So it can get contaminated over here, and due to the contamination by secretions, etc., sometimes the light may fail because of poor contact. Now the same thing we can see here in the Miller blade. Also, this is the heel, this is the tongue, the flange, and this is the bulb or the light source. Now describing the Macintosh blade further, this is the popular and commonly used blade. The tongue has a smooth, gentle curve extending to the tip. Flange, which is at the left to push the tongue. Cross-sectional view shows that the tongue, web, and the flange, they form a reverse Z. It is available in sizes 1 to 4, number 1 and 2 for pediatric patients, 3 for average size adults, and 4 for large adults. Now here we see the Macintosh handle and blade has been depicted. Okay, so this is the handle which contains the batteries. This is the hinge on which this will fit in, the hook on. And there is a point over here, contact point. When this point of the blade comes in contact with the handle, the power from the batteries is transmitted to the light source here. Okay, so these are the different sizes of the blades. Now these are provided with LED lights now in order to prevent the mishaps which used to occur with the screw-on bulbs. And these are single-use Macintosh blades, so you can see that they are color-coded again, and these are meant to be disposable. What are the modifications of the Macintosh blade? Left-handed Macintosh blade. Those flange is on the opposite side. Like we saw, the flange was on the left side with this blade, with the right-handed blade. With the left-handed, it will be on the right side. This is useful in cases of abnormalities of the right side of the face or oropharynx, if the operator is left-handed, and if intubation in the right lateral position is required. Now, another modification of the Macintosh blade is the polio blade. The blade here is offset from the handle at an obtuse angle to allow for intubation in patients on iron lung respirators or body jackets, which was common in case of epidemics of polio at that time. Also useful in obese patients, breast hypertrophy, kyphosis with Barrett's deformity, short neck with restricted mobility. The disadvantage of the polio blade is that very little force can be applied and control of the operator is minimal. Now here we see the polio blade, that how it is offset at an obtuse angle from the handle. Now the Miller blade. This is also a very popular blade. The tongue is straight with slight upward curve near the tip. In cross section, the tongue, web and flange form a C with a flattened top. The lamp may be on either side of the blade. A comparison with the Macintosh found that need for head extension was less and force was applied lower with the Miller blade. This is very popular in pediatric intubation. So here we see the different sizes of Miller blade from size 0, 1, 2, 3 and 4. So the commonly used sizes are 0 and 1 because this is mostly used for pediatric intubation. Maximum size 2 may be used. It is almost never used in adult intubation. Now comparison between the Macintosh and Miller blades has been shown in this picture. As you can see, the shapes are different and each has its own advantage. Now the McCoy laryngoscope. This is also a very important laryngoscope. The blade has a lever which on pressing causes the tip of the blade to tilt. It helps in lifting the epiglottis to improve the laryngoscopic view in case of difficult intubations. Now here in this picture, we have a description of the McCoy laryngoscope and how it helps. So if we see here, it looks very much like the Macintosh itself. The handle is very much similar. Even the blade looks similar, but the difference lies over here in the tip of this blade. Now this is the lever which we were talking about. When this lever is pressed towards the handle, the tip of this blade tilts in this direction. So it causes lifting of the epiglottis, elevates the epiglottis and improves the view of the larynx. Okay. So less force is required to intubate, and because of this unique design, there's less risk of patient trauma and it is ideal for difficult intubations. Now the McCoy laryngoscope blade in neutral position creates a similar fiber optic view as in the Macintosh blade. Neutral position means that when the tip of the blade is not tilted or the lever has not been pressed. However, when the lever tip of the blade is elevated, the epiglottis is lifted and the laryngeal inlet is expanded, as has been seen in fiber optic view. It therefore enables a clear glottic view in an otherwise difficult intubation. This was observed by Nagaoka et al. And you will see here in this picture. So figure A. Now figure A shows a picture which is very similar to what a McCoy laryngoscope blade would show in a difficult intubation, that we can only see the epiglottis and we cannot see the vocal cords. Now here the McCoy laryngoscope blade, the lever has been pressed and the tip of the blade has elevated the epiglottis. Here we can see that the same laryngoscope without pressing the lever, and here after pressing the lever, see how much the view has improved. So this has been seen with the fiber optic, and how the view has been improved, that has been proved. So it actually has expanded the laryngeal inlet. Now a word about MRI compatible laryngoscopes. These are certified to support MRI conditions with a static magnetic field of 3 Tesla or less. They have black aluminum handles and gold plated blades, lightweight, easily distinguishable, and they have specially designed carbon zinc dry batteries, which make them compatible in an MRI environment. This is a picture of the whole set of MRI compatible laryngoscope handle, blade and battery. And you can see that the Macintosh and Miller blades both have been depicted here. Now talking about video laryngoscopes. A video laryngoscope is a modification of the conventional laryngoscope, which enables visualization of the glottic inlet on a screen with the help of a camera situated in the plate. They are now included in the ASA and DAS difficult airway algorithm, and they should be kept in the difficult intubation cart always. Between the years 2003 and 2013, several different video laryngoscopes were introduced in the market to make airway management easier. Video laryngoscopes have been shown to result in improved glottic visualization as compared with direct laryngoscopy in routine airway management, anticipated difficult airway, unanticipated difficult airway, and in case of awake intubation also. So now this chart is a very detailed chart. It shows the classification of video laryngoscopes based on the blade shape. So here you can see the Macintosh type is there, then the angulated blade and anatomically shaped blade with guide channel for endotracheal tube. Now in the Macintosh type, we have from Karl Storz VMAC, CMAC, and the McGrath laryngoscopes. So in the Storz laryngoscopes, we have a separate monitor, which has to be kept on a separate trolley or a table. Pocket monitors are also there for CMAC. They provide reusable blades. Sizes 2 and 3 are there with Macintosh, and 0, 1, and 3 with Miller. And CMAC also has an anti-fogging system. Now with the McGrath laryngoscopes, there is an integrated monitor, that is, it is integrated on the handle itself. So it becomes very, handy, and it is pocket sized. A single-use blade with adjustable length may be there. And the disadvantage is that they do not have an anti-fogging system. So here, if we see the angulated blade type, now the second category, that is glide scopes are included in this, and McGrath Series 5 and Storz CMAC D blade. So glide scope, there is a separate monitor and fully portable range, of course. Reusable blades are also there, and they have an anti-fogging system. McGrath Series 5, again, similar to the earlier McGrath, they have an integrated monitor, pocket sized, and single-use blade with adjustable length is there. Now, the last or the most modern category is the anatomically shaped blade with guide channel. Here we have the Pentax Airway scope, the AirTrack, and King Vision. So with the Pentax and King Vision, it is integrated. That is, the monitor is on the handle itself. And pocket size, of course, single-use blade and standard AA type batteries, but no anti-fogging system is available. With the AirTrack, you may have a separate monitor, or it can connect to your device itself, whether it's a mobile phone or a tablet, which we will describe further on. And this also does not have any anti-fogging system. Now, again, the same thing, types of video laryngoscopes, which has just been enumerated in this slide, CMAC, King's Vision, TrueView, PCT, GlideScope, McGrath, Pentax, AWS, etc. What are the advantages of video laryngoscopes over direct laryngoscopy? So less force is used, that is understandable. Therefore, less hemodynamic stress response to laryngoscopy and intubation is there. Less cervical spine movement is there. A shorter learning curve, improved portability and cost compared to flexible fiber optic laryngoscopes, higher success rate, especially in difficult situations, and it is a very good teaching and training tool. Now, it has some disadvantages too. The passage of the endotracheal tube may be difficult despite a good view, and often stillet is required. And also the technique of intubation may be slightly different in different video laryngoscopes. Fogging and secretions may obscure the view. Bleeding may also make video laryngoscopy impossible. Loss of depth perception. Now, why does this happen? We have been trained to do laryngoscopy and look into the mouth of the patient. Under direct vision, we insert the endotracheal tube. In case of video laryngoscopes, the technique is different. That is, we are producing the image of the laryngeal inlet on the monitor, and we have to look at the monitor and insert the endotracheal tube with the hand-eye coordination. So therefore, the depth perception may sometimes be mistaken. Economic issues, of course, are there. No single video scope is ideal. Every video laryngoscope has some advantages and some disadvantages. Processing time is greater, and different techniques of laryngoscopy and intubation with different makes and models, which you have to learn. So now the steps of video laryngoscopy described very simply: look in, look out, look in, look out. So first step, look into the mouth and introduce the blade in the midline. Now look at the monitor to guide the scope in such a way to obtain an optimal glottic view. So you are looking out in the second step. Now in the third step, again look into the mouth while introducing a stiletted endotracheal tube. Once the endotracheal tube nears the tip of the blade, shift the gaze to the screen again and complete the intubation. Now, some of the video laryngoscopes that are there with us. So Karl Storz first generation in the year 2000, the first video laryngoscope with fiber optic components and video camera attached proximally was introduced. In the second generation, 2001, they came with MVM technology, that is micro video module, which is has a smaller camera and more convenient handling. In the third generation, in 2003, VMAC came, and this has DCI technology, that is direct coupled interface. This enabled multiple devices to be connected via one chip camera to the monitor and improves the video image. Now, in the fourth generation, in CMAC video laryngoscope, this is the latest generation video laryngoscope. It is equipped with CMOS chip, LED light output, and lithium-ion battery, which makes the whole system very, very versatile and portable. So now the CMAC video laryngoscope components, we have the monitor, as you can see over here, and there's the module and light source at the distal third of the blade. Now the CMAC has different blades. So the top row, it shows the Macintosh size 2, 3, and 4 blades. Then Miller size 0 and 1. And this is the CMAC D blade and D blade pediatric. Now the CMAC D blade, what is different about it? You can see that it is just the shape of the D blade, which is different from the Macintosh blades. The chief distinguishing feature is that it is an elliptically tapered shape which rises up at the distal end. This is especially useful in CL grade 3 and 4 intubations. The option of exchanging all the components quickly also makes it possible to swap to the D blade after we have made a preliminary assessment with the Macintosh blade. Now, facility for introduction of suction catheter is also provided with the D blade. Now, the next type of video laryngoscope is the King's Vision video laryngoscope. Again, you can see from the picture itself, it is very portable. It has a display. This is the monitor on which the image will come. This is the handle and blade, the channel for introduction of endotracheal tube, and this is the camera. So it has two types of blades, that is the channeled, where we can load the endotracheal tube, and the second, which is non-channeled, where a stillated endotracheal tube is required separately. Now coming to the McGrath enhanced direct laryngoscope. Again, this is pocket size and it has an integrated monitor, so that makes it very handy. The slim blade profile provides improved patient access. Blades are packaged, sterile and disposable, and sizes number 2, 3 and 4 are available. Again, if we see here, we have color video display which rotates and tilts also for better viewing. On-off switch is located here on the top of the blade. The handle of the top of the handle has non-slip rubberized external coating so that it does not slip. Then this is the camera stick, and the blade adjusts for different size patients. Single-use blade tips which eliminate the need for cleaning and sterilization between cases, and of course the camera and light source. Here again in this picture, the McGrath laryngoscope itself has been depicted. So the McGrath laryngoscopes incorporates a light source and miniature camera for visualization of the larynx. The image is displayed on an LCD screen of the monitor mounted on the handle. The battery is 3.6 volts. It is within the handle, powers the screen, camera and the light. Disposable sterile single-use blades prevent direct contact of the light source with the patient. Now the GlideScope. This has a steep 60-degree angulation of its blade, which improves glottic view by reducing need for anterior displacement of the tongue. Now the camera is located at point of angulation of the blade. Heated lens innovation helps in preventing fogging of the lens. This is a very, very important innovation which is provided in this video laryngoscope. And of course, it has reusable and disposable blades. So in this picture, you can see the monitor of the GlideScope. Here you can see this is the monitor. The blades are angulated at 60 degrees. And here again, you can see large and small sizes are available. Now coming to the TrueView PCT. The format is again similar. That is, the monitor is there on which the image will be provided. This is again the handle, which is rubberized to prevent slipping. This is the blade, it is angulated. This is the camera head. It connects the image, or allows the image to be projected onto the screen from the camera head over here. And this point, this is for attachment of oxygen, so that we can prevent fogging while the scope is inside the oral cavity. So it applies the optical principle of light refraction to provide a good view of a more anteriorly placed larynx. It has a telescope angled at 42 degrees with the blade, so that the glottis, which is lying at the tip of the blade, is best seen without any manipulation of the head, neck or instrument. Now the next type is the AirTrack. So again, this is very handy. You can see the whole handle and blade is just this big. Here you have a direct viewing eye cup. You can see directly with your eyes. This is the guiding channel for the endotracheal tube, which is anatomically shaped again, the whole blade. And from here, the image is transmitted. Now, the biggest advantage of the AirTrack is that it can connect to any device. It can be the screen of your mobile phone, the tablet or laptop. So you do not require a separate display monitor with this scope, as we saw in the earlier scopes. Your device itself will become the display. And how does it connect to your device? With the help of Wi-Fi. So this can be a thing that if the signal is not proper inside the operating room, then you may have a difficulty. Now the Pentax airway scope, again, this is very much similar. So anatomically shaped again, this is the handle and this is the scope from the tip of which the image is transmitted onto this monitor. And it has a separate P blade. This whole thing is disposable and detachable. And it fits onto the point over here. And you can see here how the endotracheal tube has been loaded inside. This is the guiding channel for the endotracheal tube. And again, there is a channel for the suction catheter also, which can be introduced. Now we can see here that it is compatible with wider diameter tubes. So from 8.5 to even 11 mm size endotracheal tubes can be inserted. And second thing is that because it is sterile and disposable, so no risk of infection. Stillets are not required with the endotracheal tube. And the facility for introducing suction catheter helps in preventing obscurement of vision due to secretions, etc. So several comparative studies of video laryngoscopes with conventional laryngoscopes have shown a higher success rate of tracheal intubation with video laryngoscopes, both in the normal and the difficult airway scenarios. What we need to do is practice the technique, which is unique to each equipment, first on mannequins, and availability of simulation technology also has made learning a lot easier. And we must have at least one of these devices in our difficult intubation cart. It can be a great help in a crisis situation. And we need to familiarize ourselves with the technique of each different video laryngoscope which is available so that we are able to utilize the material which is available to us to the full extent. Thank you.
Yeah, good evening, Dr. Indra. Please unmute. There are a few questions. Thank you for a good presentation. One is, few people are asking that which video laryngoscope you will prefer in COVID times.
Suryan sir.
Yes,
Suryan,
very good question, sir. And in fact, yes, sir. So, sir, personally, I think the TrueView is good, which we can use.
Okay.
Then because personally I feel that it is because with every kind of video laryngoscope, the technique for intubation is a little different. And once we are in the PPE kit and with heavy headgear and all, I think with the Magrath, although it is compact, the maneuvering of the endotracheal tube I find slightly difficult. So TrueView or GlideScope, where we can have the monitor separately on a trolley, and we just have the scope in our hand, and it is not too difficult. Like the TrueView also has a 42 degrees angulation, and the GlideScope also 6 degrees. So I think that helps in visualization and maneuvering of endotracheal tube much easier with the help of a stillet, of course. That is what we find.
Yeah, one more thing is that using Magrath has an advantage. It is a disposable blade.
Yes, and that is definitely there. That definitely is there.
You can use that blade and then use it again. People are asking, how do we sterilize? One of the students has asked that I have CMAC in my hospital. So how do I sterilize it after using in a COVID patient?
So normally we would, I think, prefer a disposable one only. And if we are using in COVID also, so we know that mostly the virus has been found to be killed by soap and water solution. So I think soap and water solution we can use if we do a good cleaning, because I would not prefer to use any chemicals on the D blade.
Okay. Again, one has asked that can we use, no, that's not relevant to you. Yeah. How do we clean normal laryngoscope and disinfect it?
Yeah, that's a very good question. That normally also, like with the oldest ones, where we were having the screw-on bulbs, there also the cleaning would be done with soap and water solution. And similarly, that is what we are doing now also. And then sometimes we can use alcohol-based solutions also to clean the laryngoscope blades. And of course, the handles should never be taken to this cleaning thing. They have to be kept separately. Only the blades should be cleaned.
So do we disinfect also laryngoscope?
Yes, sir, especially if we have used it in a infected patient, any patient who's having infection in the oral cavity or is having active tuberculosis or something, then it will probably have to be disinfected, use a Cidex solution or something.
We disinfect them when there's a spalding classification. and it categorized the equipments into critical, semi-critical, and non-critical. So as per it, all the laryngoscopes have to be sterilized and disinfected by putting the blade into the Sidex solution.
Yeah, Sidex solution. Right.
Yeah, and after taking it out, it again has to be cleaned and with the sterile gloves and kept in a sterile pouch so that it can be used again.
Right. In the other patient.
Yeah. Let me just guess. One is in emergency situation, should we attempt intubation with videoscope or Macintosh blade? If we have both.
So it depends on the, yes. So again, the learning curve is there, that if it person who's handling has done very few intubations with the help of a videoscope, he or she may find it more difficult to do that. So a video laryngoscope is definitely helpful. But again, like I said, that because with the advent of mannequins and simulation technology, if we have done enough intubations on a mannequin or done simulation videos, then I think it can be attempted. But not if the person is a novice.
Asked what is the maximum age up to which Miller blade can be used?
Personally, if I say, I think maximum up to 2 years of age. I don't know if there is any published literature on how what is the maximum age up to which it can be used.
Normally what happens that we have Miller blade of all the sizes. So the reason we use Miller blade in children is because we have to go below the epiglottis and then lift the epiglottis.
Yes.
So once they come out of their infancy, the epiglottis size normalizes and then it can be used. Normal we can use the curved blade. But in case of any in case of any oral swelling where we cannot go above the epiglottis, then in that case we can use a straight blade in the adult also. That becomes a part of a difficult airway armamentarium.
Right, sir. Okay. Right, sir.
Anything more you want to add?
So just what my personal experience has been with video laryngoscopes is that every different video laryngoscopes has a slightly different way of maneuvering the endotracheal tube. That is what I would like to extend my experience with postgraduates also, that when we start learning, we have to develop our own unique technique for each video laryngoscope. Like with the Magrath, I also always used to find that we insert the blade from midline, and while we are trying to put in the endotracheal tube in the laryngeal inlet, we have to withdraw the blade just slightly without distorting the glottic vision. So that is one of the things which I have found, which they also have to develop slowly as they learn.
Yeah, one thing more, now video laryngoscope also comes as a part of a difficult, unanticipated difficult airway algorithm also. And they say that you can use video laryngoscope as a first attempt, provided you have done a practice on that video laryngoscope.
Yes, sure, that is right. You should have been content with that device itself. Like if you've done with TrueView or with GlideScope and it is available, then you can go ahead and use it. But suppose if I've never used one of these, then I should not attempt it as a first.
Yeah, thank you so much, Dr. Indra. Thank you.
Thank you, sir. Thank you. Glad to be here.
Thank you, Dr. Indra, ma'am. Now we move to our next session. The chairman for the next session is Dr. Kiran Kumar Giridhar, sir. Sir is logged in. Sir is an ex-professor and head of VMMC and Safdarjung Hospital. He is actively involved with National Board of Examination. His area of interest is difficult airway. Sir will be chairing the session. The speaker is Dr. Nidhi Agrawal. She'll be talking on fiber optic bronchoscope. She is a professor in the Department of Anesthesia and VMMC in Safdarjung Hospital. Can we play the recording?
Good evening. I'll be speaking on flexible fiber optic bronchoscope. Flexible fiber optic bronchoscope can be used as indirect laryngoscope for endotracheal intubation. It is considered gold standard in the management of predicted difficult airway. And first fiber optic intubation was performed by Dr. Peter Murphy in 1967 using flexible choledoscope. Newer flexible bronchoscopes no longer use fiber optic technology. Therefore, the term flexible intubating scope is used for both these devices, and the technique of intubation is called flexible scope intubation. Indications: it is used for intubation in patients with known or anticipated difficult airway. for prevention of cervical spine motion in patients with unstable cervical spine, for rescue of failed intubation attempt or to rescue airway in prone position, and for avoidance of aspiration in high-risk patients. It can also be used for diagnosing airway pathologies like tracheal stenosis, tracheomalacia, or for therapeutic purposes like positioning of double lumen tubes or bronchial blockers. Contraindications: lack of endoscopic skill, assistance, or equipment, and a completely uncooperative patients are absolute contraindications. Relative contraindications: presence of copious blood, secretions, mass, or foreign body in the airway that might inhibit success, and near total airway obstruction where entry of the scope can cause total obstruction. It can be used in awake as well as anesthetized patient for intubation. In anticipated difficult airways, awake intubation is always preferred as it is safer. Also under general anesthesia, loss of pharyngeal muscle tone leads to upper airway collapse and limited fiber optic visualization. Now let's see what are the components of a fiber optic bronchoscope. This is a flexible fiber optic bronchoscope. It has two components: handle or a control body which is held in hand, and an insertion cord which goes inside the patient. The tip of the insertion cord can be bent in one plane. The handle can house batteries when that is used as a power source, or more commonly there is a separate attachment for the separate light source. A universal transmission light cord bringing light from the separate light source can be attached here. This is the eyepiece through which we can view the image directly. If you look through it, you can see an orientation mark at the 12 o'clock position. A camera head can also be locked onto the eyepiece for remote viewing on the video screen. This is the diopter ring or the focusing ring, which can be turned to focus an image. This is the port for attachment of suction tubing, and this is the suction valve. When we press this suction valve with our index finger, we can activate suctioning. This suction port is attached to the working channel, and this working channel extends from this suction port up to the tip of the insertion cord. Another port in the working channel can be used for injecting local anesthetics, for insufflating oxygen, or for passing instruments like epidural catheter or cleaning brushes. On the posterior side, there is a thumb control lever, which can be used to move the tip. If we move the control lever down, the tip moves up, and when we move the control lever up, the tip moves down. The insertion cord is the tube which goes inside the patient. There are circular depth markings at every 5 centimeter from tip to the end. So this is about 60 centimeter long. The external diameter of this insertion cord determines the minimum size of the tube which can be railroaded on it. There is an image transmitting bundle which transmits an image from the objective lens at the tip to the eyepiece, and another lens at the user's end then focuses that image. In the insertion cord, there are two light transmitting bundles also which transmit the light from the separate source to the tip. There are two angulation wires in the insertion cord that connect the control lever to the tip. These angular control wires can be broken if the control lever is moved when the tip of the insertion cord is within the endotracheal tube. In this picture, we can see on the right side enlarged part of the tip of the insertion cord. You can see the opening for working channel, two light bundles, and objective lens. The image transmitting bundle, which transmits image from the objective lens, is composed of 10,000 to 50,000 glass fibers, and it is a coherent bundle. These fibers are very fragile. They can be broken by acute bending of the insertion cord or by an external pressure like chewing by the teeth. So this scope has to be taken care of must be taken care of as it is very expensive. On the left side, we can see the correct way of holding the scope with the thumb on the posteriorly on the control lever and the index finger anteriorly on the suction valve. After use, every fiber scope must be, a leak test must be done on every fiber scope. The tubing of a manometer is attached to the ETO valve on the bronchoscope, and the scope is then pressurized to 140 to 200 millimeters of mercury in the blue zone. The scope should hold the pressure in this zone for a few minutes, but if the pressure starts falling immediately, it means that there is a leak in the scope and it should be immediately sent for repairs and further leak testing. It should not be cleaned, as the cleaning agents can get inside the scope and damage it. If the leak test is okay, then the cleaning and sterilization of bronchoscope should be done. Decontaminate the external surface and the working channel in an enzymatic detergent solution to remove blood, mucus, and biofilm. Any suction valves are disassembled and working channel is cleaned with a single-use channel cleaning brush. Rinse with sterile water to remove the detergent, and then place the scope in a tub of disinfectant or sterilant like 2% glutaraldehyde for 20 to 30 minutes. Syringe flush the working channel with disinfectant, and the final rinse with sterile or filtered water renders the fiber scope ready for use. Scope is stored in a dry environment without the suction valve. Insertion tube should be hanging down to let the working channel dry out. We can also syringe flush with air to dry it. Ethylene oxide sterilization can also be done after cleaning. Fiber optic scopes are present in from pediatric sizes to adult sizes, and the sizes depend on the diameter of the insertion cord. Internal diameter of the tube to be railroaded should be at least 0.5 to 1 millimeter more than the external diameter of the insertion cord. In the neonatal scope, the external diameter of the insertion cord is about 2.2 millimeter and can be accommodated by a minimum tube size of 3 millimeter. There is no working channel in the neonatal scope, so no suctioning can be done. The new fiberless video endoscopes have 2 light emitting diodes and a video chip at the tip that senses and transmits image to the video processing unit. There's no eyepiece. They have wider field of vision and superior image resolution than fiber optic scopes, and they come with portable small video monitor, flexible incubating video scope 5 from car stores, and disposable scopes like Ambu A scope are such video endoscopes. Coming to some ancillary equipment used with the fiber optic endoscope. These intubating oral airways are used for oral fiber optic intubation. In the pic, we can see from left to right, Ova Sapien, Berman, and William airways. They protect the scope from damage by the teeth during oral intubation, keeps it in midline, keeps the tissues away, and permit easy maneuverability of the scope within their stem. Bronchoscopy mask and swivel connectors, they allow the oxygenation and ventilation while the fiberscopy is going on through their snug diaphragm, as seen in this pics. Fiberscopic intubation can also be done through supraglottic devices in both anticipated difficult airway and unanticipated rescue intubation. This is the fiber optic bronchoscope trolley with the video monitor, camera console, and the separate light source. All the ancillary equipments and drugs used for topicalization should be stored in this portable trolley. Coming to the case, a 70-year-old male patient weighing 65 kgs with carcinoma base of the tongue was posted for wide local excision and wide radical neck dissection. History of snoring was present at night. There is no other comorbidity present. He is a cooperative patient. The preoperative air examination showed interincisor gap of 1 centimeter. Mallampati class could not be evaluated. Rest of the airway examination and investigations were within the normal limit. So the concerns in this patient is that he's 70-year-old with history of snoring, carcinoma base of the tongue, and interincisor gap of 1 centimeter. From these, we can assume, these imply that mask ventilation, supraglottic airway device insertion, and direct video laryngoscopy and intubation would be difficult or impossible in this case. Front of neck access is available to us and patient is cooperative. From this, my plan would be, according to the difficult airway algorithms, await flexible scope intubation with topicalization of airway through the nasal route if there are no contraindications to it, such as any coagulation abnormality or any nasal surgery or trauma. The nasal route may also be preferred in this patient as it may be necessary for the surgical procedure. It is better tolerated as there is less gagging. A laryngeal view is often easier to obtain due to nasopharyngeal anatomy. Disadvantages are that smaller size endotracheal tubes have to be used as compared to oral route. We generally use 6.5 millimeter internal diameter for female and 7.0 millimeter internal diameter for male patients. Epistaxis, trauma to the nasal turbinates, and bacteremia can occur, and passage of the endotracheal tube in the nose can be painful for an awake patient. For managing such cases, we have to be prepared. Planning and effective communication with the surgeons and the trained team members is the key to success. Be ready with the alternative plans for managing the airway, including tracheostomy, difficult airway cart, fiber optic intubation trolley, resuscitation equipment should all be checked and kept ready. Anesthesia and emergency drugs should be loaded. Keep in mind that local anesthesia toxicity can occur, so lipid emulsion should be available. And plan an appropriate tracheal extubation strategy in these patients, as extubation can also be difficult. Arrange for an ICU bed. Psychological preparation of the patient is of utmost importance. Explain the procedure, its benefits and safety, win the patient's confidence and make him comfortable, and take the written informed consent. In the preoperative room on the day of surgery, attach the basic monitors, insert the intravenous cannula and administer anti-CLGOR. Injection glycopyrrolate 0.2 milligram IV 20 minutes before the procedure, or 2.2 milligram IM 30 to 40 minutes before the procedure can be given. They minimize the secretions that can dilute the local anesthetic and hence bring about effective topicalization due to better contact of LA with the mucosa. Dry field also gives clear scopic views. The nasal mucosa is very vascular, so vasoconstrictors reduce the risk of epistaxis, increases the size of nasal airway passages. Xylometazoline 0.1%, 3 drops should be put in both the nostrils at least 20 to 30 minutes before the procedure. Administering drops at night before the surgery and at 6 a.m. on the morning of the surgery gives the best results. Alternatively, if these drops are not available, then cotton pledgets soaked in lignocaine 2% with adrenaline 1 in 2 lakh can be placed in the nasal cavity for 10 minutes. Both the nostrils are prepared to save time if difficulty occurs in passing the tube from one side. According to the DAS guidelines published in Anesthesia in 2020, key components of awake tracheal intubation are stop, sedation, topicalization, oxygenation, and performance. The S is in the lowercase to emphasize the optional nature of sedation. Topicalization of the airway prevents discomfort, gagging, coughing, and decreases the hemodynamic changes associated with intubation. Lignocaine is most commonly used because of its rapid onset and high therapeutic index. Doses of maximum up to 9 milligram per kg lean body weight can be used, and calculate the dose for each procedure of topicalization beforehand to prevent overshooting the maximum dose. Use less doses as far as possible to prevent lignocaine toxicity. An awake nasotracheal flexible scope intubation requires anesthetization of nasal cavity, posterior pharyngeal wall, periglottic area, larynx, and trachea. All these can be achieved by the use of nebulization, and that too without needling. It is comfortable to the patient and it is useful even in patients with limited mouth opening. 4 ml of 4% nebulized lignocaine is inhaled using a face mask for 20 to 30 minutes with oxygen flow at 8 to 10 liters per minute. Patient is asked to breathe from the nose for nasal intubation. The disadvantage is that anesthesia is incomplete and requires supplemental local anesthesia. It is also time consuming, so it is done in the pre-op holding area. After nebulization, patient is shifted to the operation area and basic ECG, SpO2 and NIBP monitors are attached and EtCO2 is kept ready. Supplemental oxygenation should always be started as soon as the patient arrives through the binasal prongs, but high flow nasal oxygen should be the technique of choice if available. Sedation and analgesia, remember that S means that S in the lowercase means that it is optional. The goal of sedation is that patient remains calm, cooperative, and responds normally to verbal commands while maintaining his airways and spontaneous ventilation and cardiovascular functions intact. This patient with old age, history of snoring, carcinoma base of the tongue is at increased risk of airway obstruction. So small incremental doses should be given. Preferably short-acting and reversible drugs will be given. And we should use only the drugs which we are familiar with, which we have been using frequently. In this case, I would use midazolam 0.5 milligram IV in combination with fentanyl 25 to 50 microgram as the need may be. Subsequent small boluses will be given only after 5 to 7 minutes if required. Over-sedation must be avoided as respiratory obstruction and loss of airway can be catastrophic. Topical anesthesia of the nasal cavity after nebulization can be supplemented with 1 spray of 10% lignocaine in each nostril. It is followed by nasal dilatation with a nasopharyngeal airway lubricated with lignocaine gel. It also helps in gauging the size of the nasal passage. A 7-size nasopharyngeal airway predicts easy passage of a 6 to 6.5 millimeter diameter, internal diameter endotracheal tube. If no nebulization has been done, then LMA Magic nasal mucosal atomization device can be used to topicalize nasal mucosa on both the sides. Topicalization of oropharynx can be supplemented with gargling with lignocaine 2% viscous 2 ml 2 times. Ask the patient to swish, gargle, and spit out the rest of the drugs. For spray as you go technique, 1 ml of 2 to 4% lignocaine is injected through the working channel of the fiber optic scope onto the targeted areas like epiglottis, vocal cords, and trachea as and when they appear during the fiberscopic intubation. Wait for 30 to 60 seconds for the local anesthetic to take effect before advancing towards deeper structures. Do not use suction concomitantly. An epidural catheter can also be threaded through the working channel for the same purpose. Sago technique is suitable in these full stomach cases in full stomach patient as the loss of protected laryngeal reflexes occurs just before tracheal intubation. Now, topicalization of the mucosa serves to anesthetize the entire airway adequately in most patients. Nerve blocks are not used routinely. I have not used nerve blocks for many years now. They are technically more challenging to perform. There is higher risk of complications such as intravascular injection and nerve damage. But if one is experienced with the use of these blocks, they can be used as alternative to spray as you go technique in combination with nebulization. Superior laryngeal nerve block bilaterally to anesthetize periglottic area and blocking glottic closure reflex, and translaryngeal block to anesthetize trachea, vocal cords, and subglottic mucosa can be used. For superior laryngeal nerve block, the patient is positioned supine with neck extended. Hyoid bone is gently displaced to the side where the block is to be performed, and the needle is inserted from the lateral side of the neck to make contact with the greater cornu and then walked off anteroinferiorly and advanced a few millimeters to pierce the thyrohyoid membrane when a give is felt. On negative aspiration for air and blood, inject 2 ml of 2% lignocaine. Repeat on the other side. Caution that carotid artery can be nearby. For translaryngeal block, patient is positioned supine with neck slightly extended. The midline of the cricothyroid membrane is identified, trachea stabilized, and a needle or a cannula over the needle attached to 5 ml syringe containing local anesthetic is directly advanced posteriorly and slightly caudally until air is aspirated, confirming the correct position in the larynx. 2 ml of 4% lidocaine is quickly injected at the end of the exhalation, which makes the patient inspire and cough, spreading the drug to the whole of distal airway. It is contraindicated in patients at high risk of gastric aspiration and due to coughing in patients with elevated ICP or open globe injury. Before starting the fiber optic intubation, ensure that the fiber scope is clean and disinfected. Check that the tip moves with control lever, suction works, light switches on. Defog the lens, focus with diopter ring, lock the camera head onto the fiber scope, focus, and adjust the orientation mark at 12 o'clock position. Lubricate the insertion cord, but not the tip, and load the appropriate tracheal tube. In this video, we will see that the diopter ring on the camera is being focused, is being rotated to focus on some printed words. And then the orientation mark is being brought onto the 12 o'clock position. This procedure of flexible scope intubation can be done with the endoscopist standing on the head end of the patient or facing the patient. In either case, the patient video monitor and the patient monitor should be in direct lines of sight of endoscopist. The endoscopist should stand on a footstool to gain height to keep the insertion cord taut and straight so that the movement of the handle can be transmitted to the tip of the insertion cord. Patient should be placed supine with head in neutral or extended position, as flexing the head as in sniffing position can lead to a butting of the tongue onto the posterior pharynx. More patent nostrils should be used for intubation, and the nasopharyngeal airway can be inserted through the other nostril for oxygenation. Choose a tube half size smaller than the usual size for nasal intubation in patients so that difficulty is not encountered during railroading because of size. In this video, we can see the fiber optic nasal intubation. We can see that there is a black area, which is the air space. We have to follow this air space to reach at the back of the nasopharynx. The angulation wires which move the tip are not strong enough to part the tissues or lift away the tissues. So airspace, which is the black area, has to be followed. At the back of the nasopharynx, if the soft palate or the tongue is abutting the posterior pharyngeal wall below, then the patient can be asked to protrude the tongue to make the airspace, or in an anesthetized patient, a jaw thrust can be given. Same is true for the epiglottis. Now, when the epiglottis comes into the view, 4% lignocaine can be injected from the working channel of the scope onto it as a spray. Here we can see, and wait for 30 to 60 seconds and then proceed towards the vocal cords. If the vocal cords are moving, they can also be sprayed with local anesthetics till the movement becomes sluggish, and then ask the patient to take a deep breath so that the vocal cords open up and enter the trachea with the tip moving downwards. In the trachea, again, inject local anesthetic so that the coughing is prevented, and go up till you can visualize the carina. Once the carina is visualized, only then the tube is railroaded onto the insertion cord. Otherwise, sometimes the insertion cord can come out of the trachea. Confirm the correct position of the tip and bring out the fiber optic scope with the tip in the neutral position. A 2-point check confirms the position of the tracheal tube. 1, visualization of the tracheal rings and carina with the scope, and 2nd, capnography to exclude the esophageal intubation. Anesthesia should be induced only when this 2-point check has confirmed the tracheal tube placement. Now, coming to troubleshooting, sometimes there can be fogging of lens. So touch the tip to the mucosa for a few seconds to warm it. One can irrigate with saline and then suction out the secretions. Insufflate the oxygen at 2 liters per minute via the working channel to clear the secretions. If unsolved, remove the scope and wipe the tip with alcohol. Sometimes there can be difficulty advancing the endotracheal tube over the scope. This could be because of the tip of the left beveled PVC tube catches onto the right arytenoid. Withdraw the tube 1 to 2 centimeters and turn the endotracheal tube 90 degrees counterclockwise to turn the bevel posteriorly, which facilitates passage. A tube with the bevel posteriorly can also be loaded onto the insertion cord. An endotracheal tube softened in warm water before loading also helps. Now, certain tubes which have soft taper tip and have a flexible tip, such as that of ILMA tube or the Parker flex tip tracheal tube or the flexible reinforced tube, can prevent the laryngeal impingement and ease the railroading of the tube on the insertion cord. So these tubes are not suitable for use if the patient is to be ventilated in the ICU, in which case PVC tubes have to be used. Sometimes there's a gap between the scope and the larger size endotracheal tube, which leads to catching up of the tube on the structures in the larynx. So use the smallest appropriate internal diameter tracheal tube. And when a pediatric scope is being used for adult intubation, an entry catheter can be loaded over the scope to minimize this gap. Now, no technique is fail-safe. There can be complications. Complications can occur even with the awake flexible scope intubation. So at every step, one has to optimize the 4 components of STOP. If the patient is over-sedated, consider reversal agents. If topicalization is inadequate, supplement. If local anesthetic toxicity has occurred, manage it. If there's obstruction in the airway, clear it and increase the FiO2. and one can change the mode of oxygen delivery. If there's performance difficulty, then experienced help should be called early. Limit the attempts to not more than 3, with 1 done by the experienced operator. Abandon the procedure if the surgery is not necessary, and the motto should be that no harm should be brought about to the patient. Stop before any harm is done. So the take-home message is that planning, preparation, effective communication, and teamwork is the key to success. Optimize the components of stop even before starting the procedure. Remember, sedation is optional, and practice the skill of flexible scope intubation routinely in peacetime to be able to perform during the wartime. Thank you.
Thank you, ma'am. It was an excellent presentation. We have a few questions from the delegates. Welcome, sir. Dr. Giridhar, sir.
Yes,
Welcome.
yes.
So there,
I would like to say it's an honor to be part of this prestigious PG Assembly. An honor to be delivering lecture in front of my teacher, Dr. Giridhar, who taught me this fiber optic bronchoscopy when I was junior at Maulana Azad Medical College. So it's really a great honor for me.
Dr. Nidhi presented very well, and she has covered the whole topic beautifully. I tell you, you have touched all the points,
Thank you so much.
I'm
sir.
very happy, very happy. Okay. And some
Thank you, sir.
questions are there, so she should
Yes, sir.
answer. I think.
Sir, the first question, madam, is can we pass a fiber optic scope through a classic LMA because it has an aperture bar?
Yes, we can. We can pass. Aperture bar, actually, sometimes we can cut the aperture bars at times if we want to use it for fiber optic intubation, because it can hinder the passage of the tube through it.
Okay.
Dr. Anupama, I want to add to this.
Yes, sir. Yes, sir.
The classic LMA is not a very good device. There are so many other devices like iGel or Ambora again, through which we can intubate patient. These supraglottic devices can be used beautifully without any hindrance, I think.
Nowadays, second generation devices are that to not blind intubation through them, we have to do fiber optic guided intubation because of the risk of trauma. So Ambora again, Ambora I, iGel, even Bascamos can be used. AirQ, although is a first
AirQ, yes, AirQ can be used.
Generally not preferred.
Yeah.
So there are better devices in using classic LMA.
Yeah, so we should not use classic.
Yes, sir. Here's another question, ma'am. After spraying local anesthetic by spray as you go technique, should we wait for a few seconds to go ahead, or both can be done simultaneously, or are there no nerve blocks needed in this?
No, for spray as you go technique, because we are topicalizing, we are spraying just then. So we do have to wait for 30 to 60 seconds. Or even longer, if you feel that vocal cords are still moving, you can spray again and then wait. Patience is required in managing such cases. You have to wait and then proceed towards deeper structures once the effect comes. Suppose you enter the vocal cords and in the trachea you are not instilling. Even if you have instilled local anesthetic, there is some coughing. So wait, instill again, and then again, after waiting for 30 to 60 seconds at least, proceed.
I want to add one more thing in this. That SAGO is sufficient to topicalize. There is no need of any blocks. And secondly, SAGO can be used with oxygen insufflation. Like you attach the oxygen 2 liters per minute to the suction channel and then infuse the installation of local anesthetic. It will give a better effect. Wait for 30 to 60 seconds and then proceed. And I have seen in my practical experience, it gives very excellent topicalization.
Yes.
And there is no need for any nerve blocks.
Sure, sir. And madam has also mentioned in her presentation that it can also clear your view of the fiber optic when you have a attached oxygen from the side.
Yes.
And another question, what is the ideal position of the tube in the trachea when you are viewing it from a camera through fiber optic? What should be the ideal position of the tube?
Distance from the carina should be at least 2 to 3 rings above I mean, the tip should be 2 to 3 rings above the carina.
The tube should be in the midline, and you have to touch first the fiber optic should touch the carina, and then you remove the tube and keep 2 to 3 centimeter above the carina.
Yeah, you should see 2 to 3 rings.
Yeah, 2 to 3 centimeter like this. And
another delegate wants to ask, what is now is fiber optic? Can it be used for an emergency intubation?
yes, nowadays it is recommended to use in emergency.
What kind
These
of
are the latest guidelines now that you can use fiber optic in emergency, and
Suppose
it should be the part of difficult airway card.
Yeah.
And it should always be
emergency
standby
kit.
in the operation theater. It should always be there.
Depends on the expertise.
Yes, yeah, there is learning curve is there. So, ma'am, one more delegate wants to ask, what is the difference if we are using fiber optic to orally? Can spray as you go technique can be used applied there also? What precaution should one take?
Yes, orally, spray as you go is as same. Only thing is that you have to put an intubating oral airway to keep the fiber optic scope in midline. So for that, the tongue, posterior part of the tongue, there are deep pressure receptors on the posterior 1/3 of the tongue, which are pressed by these intubating oral airways. So we have to topicalize that part. Plus, we can also smear the spatula or the posterior part, which is of the intubating oral airway, which is going to be in contact with the tongue. We can put 2% lignocaine jelly on it so that it is anesthetized while doing it. And for oral intubation, the problem of impingement of the tube is much more on the laryngeal. I mean, the tip of the tube catches more incidence is there for the tip of the tube catching on the arytenoids with the oral intubation. Otherwise,
Yes.
rest of the procedure is same.
Almost the same. Sure. So there are no more questions. So I would like.
I would like to summarize that FOB is very important and essential tool in tackling difficult airway. About 98 to 99% cases of difficult airway can be successfully intubated by this fiber optic instrument. First, it is important to know the instrument thoroughly for the PGs, and secondly, be proficient with the awake and anesthetized techniques. In pediatric population, fiber optic is more challenging. My advice is to learn this on mannequins, then start learning on normal airways under the guidance of faculty. This is my advice to the PGs.
I would also like to add, should we discuss about the child under general anesthesia?
Sure, ma'am. Sure, ma'am.
Suppose there's a child of TN joint ankylosis who's come for about 5-year-old who's come for intubation or for the surgery to the OT. In these cases, we have to give general anesthesia because at such a age, child will not be cooperative. So for this, after proper history and examination and ruling out any contraindication to nasal intubation, we always do the same preparation as we do for the adults. That is, we plan A, plan B. We always prepare for tracheostomy and cricothyrotomy. But remember that all these drugs and equipment should be age and weight specific. Even your lignocaine nebulization has weight specific doses for nebulization. I've given that in the write-up. So once you have prepared everything, all equipment, psychological preparation, of course, can't be done, but nebulization can be done for a child in the lap of the mother in the pre-op room. So for such a child, we nebulize the child, we administer an anti-sialagogue like glycopyrrolate 4 microgram, and then we also give drops in the nose, vasoconstrictors, and then take the patient to the operation theater where general anesthesia is done under inhalational anesthesia with sevoflurane, and we preserve the spontaneous ventilation. And we also give fentanyl to these patients, which aids in our anesthesia, obtruns the airway reflexes and helps in analgesia. So with fentanyl and general anesthesia with sevoflurane, we deepen the plane of the anesthesia, but here once the plane is deepened, we pass a nasopharyngeal airway into the other nostrils. We have prepared both, vasoconstrictor has been given to both the nostrils. So one which is more patent is kept for the intubation, and through the other, we pass a nasopharyngeal airway after measuring the proper depth and size, and then attach our circuit with a universal connector onto the nasopharyngeal airway and give oxygen and sevoflurane to maintain anesthesia. And then further intubation with fiber optic scope is done using SAGO procedure.
SAGO is very important in this.
SAGO. And remember that doses have to be calculated beforehand.
Yeah.
So these can be asked to you if you get a short case of TM joint ankylosis in your exams, they can ask you this procedure. Fiber optic scope can be asked to you if in every case, especially TM joint, burn contracture patient, you should know these, how to do should know everything. And secondly, regarding the sedation part, dexmedetomidine is also being used. If you're using that at your institution and you have the experience, only then you say about these drugs in your exam.
Yes.
Otherwise,
Yes.
only utter the drugs which you know of. That I want to add.
That was very informative, ma'am. I think anesthetizing children in awake in emergency situation is always a tough call. I thank you, ma'am. I thank you, Dr. Giridhar, sir, for attending the
Thank Dr. MD Kaur and the EPIC team for such a wonderful program that they have conducted. It is amazing, and I'm sure it has benefited the patients, the students.
I also want to congratulate the RML team, Dr. Kaur, Dr. Akhilesh, Dr. Anupama, and so many other members.
Yeah, it's wonderful being here. Thanks a lot.
Thank you,
Okay,
ma'am.
Thank you.
So today we come to the end of the today's session. I have an announcement to make. The winners of today's quiz. The first set of questions, the winners are Dr. Mohammed Shoaib and Dr. Rajarajan. The winner for the second set of quiz is Dr. Hema and Dr. Finija Francis. The winners of the third set of questions are Dr. Shikha Singh and Dr. Suryanasta. So these are the winners for today's quiz. And you will shortly receive the gift vouchers in your mail. There was one question which during the pediatric region for which answer was was not given by the presenters, and the delegates had asked for the answer. So I'm just telling you for your information. The modified Armitage formula is with 0.25% bupivacaine. The sacral, it is given in the dose of 0.5 ml per kg. Thoracic is 0.75 ml per kg up to T10. For thoracic T6, it is 1 ml per kg. Mid thoracic T4, it is 1.25 ml per kg. And the maximum volume that can be given is 20 ml. And there's one more formula, Schul's formula, in which it is 0.1 ml per segment per year of age. Either 1% lignocaine or 0.25% bupivacaine, both can be used. So with this, we end today's session. I thank you all the delegates for attending the session today, and we look forward to seeing you tomorrow. Thank you a lot. Thanks a lot.